Hello. 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 तरह का ही कर लूँगा 8
So our research scholar and students are on their way, and they will be reaching soon. So we will be conducting the session. Sorry for the delay, somewhat. Yesterday, I think it was a enjoyable night, and everybody enjoyed at Suryamukhi. I hope so. So kindly bear with the situation. We will conduct the session 5 today, where our session chair and moderator is Dr. Gopal Kundu sir and Dr. Sandeep Seth sir. So just to give you a brief outline, yesterday the program started with the oration of Dr. Krishna Reddy sir, and then we have 4 sessions yesterday conducted, where Dr. Santanu Sengupta sir, Dr. Krishna Reddy sir, Dr. A.B. Day sir, Dr. Deepak Saini sir, they presented on various issues, starting from CSIR health cohort knowledge base, then it's related to dementia, then Bharat study, longevity India. So lot of many things were discussed related to health. In session 2, Dr. Vivekanand Jha sir, Dr. Govind Makharia sir, and Dr. Ullas Kolthur sir, they elaborated on several issues related to health, especially the kidney disease, ICKD cohort, journey thus far and lesson for the future, and celiac diseases, and public health related discussion and deliberation. Then post lunch, there were session 3, but before that our S&T minister was here, and it was wonderful listening to him. And being a doctor, he elaborated on all the issues what India is looking for and how the Indian science is oriented towards those issues. So it was wonderful listening to our S&T minister, Dr. Jitendra Singh sir. And in session 3, the discussions were given by the speaker, Dr. Somen Kumar Pradhan sir, who elaborated about the observation to casual interference in tribal area. Then Dr. Puneet Prasad sir, his session was, talk was little bit curtailed due to the time management, but he talked overview of research initiative to understand health and well-being of Odisha tribal communities. So basically he is working at ILS, so he is digging all the data set and information and knowledge base in Odisha tribal communities. Then the third deliberation was made by Dr. Roma Ratan and Dr. Devadatta Bhattacharya sir and Professor A.B. Ota, and it was all about the tribal cohort vision. And we had a last session yesterday, session 4, where Dr. Pallavi Khetrapal madam, Dr. Arindam Matra sir, Dr. Anamitra Barik sir, Dr. Sailesh Mohan sir, and Dr. Shivani madam really elaborated on several issues related to health and the funding like DBT India Consortium, then Garba Ini Cohort Initiative, then BIR POP, and Precision CARRS, and Shivani madam joined online telling about the findings from the long cohort study of cardiometabolic disease in South Asia. And then we had a presentation from industry side also, Thermofisher person were there, Sri Hari sir, and he talked about all the initiative the Thermofisher is taking also, because they are in the analytical side and chemical side, but nevertheless they are also exploring, because a lot of chemicals are and things are required for the health sector also. So they are also had a footprint here. We really thank to Thermofisher. And today we have lined up with session 5, where Dr. Gopal Kundu sir and Dr. Sandeep Seth sir will be chairing. And the session speakers are Dr. Nikhil Tandon sir, Dr. Chittaranjan Yagnik sir, who will be taking the session online, Dr. Sudha Vasudevan madam, Dr. Jeevan P sir. So these all are lined up for today. So these all were the part of the yesterday program and today's session 5 program. So we are just waiting for some more people to join so that they can get the real benefit, the youngsters, and we will start now, sir. Okay, sir. Okay, sir.
रेडी है जी सर दिखाइए
So once again, a very pleasant good morning to all of you. Jai Jagannath. And we are here for second day of Cohort Connect program. Yesterday the program was very, very memorable and very, very joyful with the gracious presence of our SNT Minister, Dr. Jitendra Singh ji. The program reached to the several masses also through different social media and all. And today we will be conducting the session 5 of the second day Cohort Connect program, where the session chair and moderator is Dr. Gopal Kundu sir and Dr. Sandeep Seth sir. I have a proud privilege to introduce both the chairs, sir. So Dr. Gopal Kundu sir, he is obtained his PhD in chemistry from Bose Institute of Calcutta in the 1989. He did his postdoctoral at several places, in which the prominent one is Cleveland Clinic Foundation, University of Colorado, University of Wyoming, and National Institute of Health in USA, in the area of cardiovascular research and inflammatory disease and reproductive biology from 1989 to 1998. It is a decade time. He joined as Scientist D at National Center for Cell Science in 1998, and then got his all the promotion, and then he worked on tumor biology, cancer research, stem cells, tumor stroma interaction, angiogenesis, cancer therapeutics, biomarker development, and many more. Due to his work, he has been acknowledged by various awards. The few most important awards are Fellow Award for Research Excellence from NIH, USA, National Bioscience Award from DBT, and the Apex Award of Science and Technology, Shanti Swarup Bhatnagar Prize from CSIR New Delhi. He also earned International Award on Oncology from Greece, International Young Investigator Award from Mayo Clinic, USA, and 7th National Grassroots Innovation Award from Rashtrapati Bhavan. At present, he is working at KIT as a Director R&D. So, this is the brief profile. Now I will introduce Dr. Sandeep Seth sir. He is Professor of Cardiology, an eminent clinical scientist working on full spectrum cardiology care at AIIMS New Delhi. He is working on interdisciplinary care model related to imaging, biomarker, advanced therapies, and he is a both thought leader and hands-on physician. So I invite both the chair to the dais, our Kundu sir and Dr. Sandeep Seth sir. I request our director sir to kindly welcome both the chair with a flower bouquet. It's a proud moment for us. This campus has never seen so many doctors sat together discussing on the health issue. Our Kundu sir, a vast experience, and doctor from AIIMS. It makes IMMT campus and whole research aura a prominent one. Now I request both the chair to kindly conduct the session. Already the CVs and program is given there. Thank you, sir.
Good morning, all of you. And first, I'd like to thank Dr. Ramanuj, Director, CSIR-IMMT, and all the organizing team, and IGIB, BRIC, ILS, and other organizations to organizing this very important and impactful events. This session, we have two 30-minute talk and two 20-minute talk, followed by one industry talk. We'll request all the first two speakers to finish their talk within 25 minutes so that we can have 5 minutes discussion. Yesterday we had some issue with timing, did not get much time for discussion. So with that, we'll invite Dr. Nikhil Tandon to deliver his talk. Dr. Tandon, MD, PhD, is Professor and Dean Research at Department of Endocrinology and Metabolism, All India Institute of Medical Science, New Delhi, a leading clinician scientist in endocrinology. He has authored over 600 peer-reviewed high-impact papers in international journals with more than 120,000 citations and H index of 94.
Next.
He has served as former president of Endocrine Society of India and is a fellow of multiple prestigious academies, including National Academy of Medical Science, FAMS, Indian Academy of Science, National Academy of Science, and Indian National Science Academy. In recognition of his outstanding contribution to medical research and endocrinology-related research, he has been honored with Dr. B.C. Roy Award and the Padma Shri. Dr. Tandon will be delivering his talk in the area of diabetes and cohorts. Dr. Tandon, over to you.
Thank you, sir. Thank you. So my remit this morning is, I talked after discussing this with Dr. Shantanu, is to give you a little bit of a general sort of overview on the diabetes part and then take you through some of the longitudinal data sets we've been working with. So this is primarily for our non-clinical colleagues to sort of to try and communicate the conceptual framework in which diabetes is really looked at. Okay, so this doesn't seem to be, okay. There you are. So So this is how you actually define diabetes, by the way, so that there is no confusion about what we are talking. So diabetes mellitus is a group of metabolic diseases, which, as you see, as per the original definition, highlighted only two things. One, that it is associated with high glucose levels, and two, that it is associated with either a defect in insulin secretion or a resistance to the action of insulin. And I'm specifically saying this because as we go along, you'll realize that this is a fairly restrictive or minimalistic definition of what we actually see in people with diabetes, right? There are several subtypes of diabetes. The one which we are most familiar with, and for one which most of the clinical work is done, is actually in type 2 diabetes, which was previously called non-insulin dependent diabetes, which affects the largest bulk. So it may be 90% of all people with diabetes. And it was considered to be based on conceptual models developed in the US, especially from a population of indigenous Americans, that there is insulin resistance is a primary problem. And over a period of time, the pancreas is unable to provide adequate amount of insulin to overcome that resistance. And then insulin deficiency and hyperglycemia set in. So that was the one. The second, which is reasonably clearly defined, is type 1 diabetes, which is an organ-specific autoimmune disorder in which there is an absolute loss of pancreatic beta cells. An area which is rising quite significantly in the recent past, which is also linked to type 2 diabetes, is hyperglycemia in pregnancy, which is gestational diabetes, in which perhaps these are individuals who are prone to type 2 diabetes, but it gets unmasked because of the hormonal changes during pregnancy, and in a large instance actually reverse back to normal immediately after delivery. But that is not what is consistently being seen, and the numbers are quite spectacularly rising in the recent years. So as I mentioned, and I won't go into much detail, primarily the concept was insulin resistance is a starting point, which forces the pancreas to produce more insulin. Over a period of time, the pancreas is unable to do that. Insulin deficiency sets in, and that results in the disease. More recently, there is a belief that just talking about resistance and insulin secretory defects is perhaps being a little too minimalistic. And more recent, instead of just those two things, they're now supposed to be about 8 possible contributing factors. And I say this because it's important for us to mechanistically, as treating physicians, to mechanistically understand these, because each one of them can be potential targets for intervention for treatment in people with type 2 diabetes. So as I said, the decreased secretion and the resistance are also there, but there's also a reduction in what are called the incretin hormones, which include GLP-1, which is essentially the target today for all these anti-obesity drugs, which everybody hears every day in the newspaper. There is also an associated increase in glucagon secretion, which is a counter-regulatory hormone and therefore antagonizes the action of insulin. There is increased production of glucose from the liver, and therefore fatty liver disease and NAFLD, which is now called metabolic dysfunction associated steatotic liver disease, or MASLD. Dr. Shalimar will speak to you more about this, is an important part of the spectrum. There could be also effects at the kidney level where the ability to pass glucose from the urine, therefore reduce the load of circulating glucose, is also hampered. So there are multiple areas where it's now seen that there are potential pathogenic mechanisms which require an intervention. As far as treating clinicians go, the real important story is not just merely in controlling sugars, because the clinically relevant outcome is what are called vascular complications, which are irreversible as we see them today. We can perhaps slow the progression, but once they set in, they invariably progress, and very often progress to end-stage organ disease. And these are classified into 2 major categories. Either they are because of small vessel involvement, which can actually cause an effect on the nerves, the kidney, or the retina. So you can get vision-threatening eye disease, you can get chronic kidney disease, and I'm sure the nephrology teams yesterday, Dr. Jha and colleagues, would have actually told you about that. And then, of course, the macrovascular, or the large vessel disease, in which heart disease becomes a very, very important part. Let me now just come to the more relevant part of the diabetes discussion before I go to gestational diabetes, which will form a bulk of my talk. We've always considered diabetes to be a monolith, that this is one entity and therefore you've got to just treat it and treat it similarly. Over the last just under a decade, there's been a better understanding about the granularity of this disease, and therefore using sort of more sophisticated data analytics and looking at people from the time of diagnosis to their natural history as they evolve, it appears that you can identify clusters within diabetes. And these clusters seem to, it's not that they are totally exclusive or vertically without interface. They are, obviously, they will overlap to a certain extent, but they also carry specific characteristics which make individuals belonging to those clusters have a slightly different evolution of disease and the likelihood that this disease may be managed one way for a certain cluster and another way for another cluster. So let's start from the extreme left, which is really what type 1 diabetes is all about, which is severe autoimmune diabetes. And essentially what is happening there is a destruction of the pancreatic beta cells. There is absolute insulin deficiency, and that's really the one total extreme left situation, which is an abrupt onset disease which invariably can only be managed by exogenous insulin therapy, right? This is usually early. It is not related to weight. I mean, it's not that you have to be obese and you become insulin resistant. This is a primary insulin secretory defect caused by a damage to the beta cells. Then was a severe insulin deficient diabetes, which is not type 1. Again, this is like a type 2 variant, but unlike what was initially promulgated, that everything starts with obesity and insulin resistance, this can very well be people who have a type of type 2 diabetes who can, at least in the initial years, be manageable by oral agents, but fairly rapidly progress to becoming insulin requiring. And I use the word advisedly. In type 1 diabetes, we used to call it insulin dependent because these individuals are dependent on insulin for survival. Here I use the word insulin requiring because it means that they will require insulin for keeping their glucose under control, but they will not necessarily succumb to the disease if you don't give them insulin from the outside. The middle one, which is severe insulin-resistant diabetes, is the one on which most of the initial literature was fashioned. And as I said, this was based on studies on indigenous American population called the Pima Indians. They are in Arizona. And this is an interesting story for those who sort of believe that genetics alone or the environment alone is important. This was primarily a farming community till the big dams came, water was diverted, they could not do any farming, reservations were made where they were allowed to run casinos and they had lots of money for food and alcohol. From a 0% diabetes prevalence at the beginning of the 20th century, it's a 75 or 80% diabetes prevalence in the 1960s or 70s. And that's the transition. There has been no genetic change, obviously, in a period of 70 years. So purely an impact of the changing environment on a population which had perhaps genetic propensity to develop the disease. The other one is mild obesity-related diabetes, which a lot of people get as they grow older, and then the mild age-related diabetes. But these clusters were established for the first time in a study from the southern part of Finland. And so that really represents how they behaved there. More recently, let me just move to this. There have been 2 or 3 studies from India. In the first, from the Finnish paper or the Swedish paper, what is important is that was based on longitudinal data. So these were people on whom you had information at the beginning of their disease, at the time of their diagnosis, and see how they evolved in terms of their natural history and complications. The Indian studies which have been published thus far primarily are cross-sectional data, but still give you a sense that there are clusters which exist even within the so-called type 2 diabetes that we see out here. This is work done from Dr. Mohan's group. Again, instead of those this is a slightly different number of clusters with different characteristics. The severe insulin-resistant diabetes and the insulin-resistant obese diabetes remains, fairly overlapping with what was reported elsewhere. The combined insulin resistance and deficient diabetes is something which is differently described in the Indian population. And then, of course, we have that mild age-related diabetes, which is again common to other populations. So again, these clusters will present differently with, for example, the severe insulin deficient diabetes will have a low HOMA beta, which is a marker for insulin secretory defects, low C-peptide levels, which tells us about insulin secretion. The second cluster is often related in the initial stages with insulin resistance, and therefore HOMA-IR is increased. The one in the middle is got characteristics which are both. And this is the one in which there's a coexistence of insulin resistance and deficiency. And the last one is a milder disease, which happens much later on in life. This is unpublished data. You referred to work which Shivani presented yesterday, I think online, which is the work on a cohort which several of us in this room are involved in, which is the CARS cohort. It's been running now since 2009 in Delhi and Chennai. And so we have fairly good longitudinal data. So this is work from the CARS cohort. This is unpublished data that, interestingly, two things came up. That number one, and that's been reported by other people also, that the firm belief that it's only insulin resistance, which is at the starting point of everything, is perhaps not as relevant in India, which also has implications for sort of drugs that we use. So insulin deficiency is a larger and a more important contributor in the Indian population. I'm not saying insulin resistance is not, but the relative contribution of insulin deficiency to disease evolution is much more, number one. And number two, that the higher mortality risk and years of life loss seem to be associated more with insulin deficiency than with insulin resistance, at least in others. Again, which suggests that, considering that type 2 diabetes is a solitary, homogeneous clinical entity is an oversimplification. Perhaps it has served its time well in the way we've had, when you had two medicines for diabetes and an insulin, now when you have a plethora of medicines, you can possibly reprioritize medicines for different clusters because you're more likely to get a benefit in one cluster with one medicine more than another one. So I think it's important not just for an academic purpose, but because it has implications for us to understand disease evolution and disease management. Okay. Let me now again share with you, and this is sometimes a thing which causes confusion. Sorry, I'm just deviating slightly from the cohorts bit to a straightforward clinical story out here. Very often, people come and say, they show a report and say that the lab has said this is normal or this is abnormal. I think what we need to be very clear about is normalcy is defined for diagnosis. Once you've been diagnosed or on treatment, we are really looking at targets for control. There is a solitary set of diagnostic metrics. There is a variable set of targets for control. So if I'm a 30-year-old type 2 diabetes, I will be much more aggressive in my management. I will therefore have a different and a lower target for control. If I have an 80-year-old with mild diabetes, my target for control will be very different. So please differentiate diagnostic criteria from targets of control. And that's, again, important to understand. But by and large, the criteria for diagnosis, and I'll explain how they came about, are if you're doing a fasting value, your glucose levels have to be equal to more than 126 milligram per deciliter. If you've done a GTT and you've loaded somebody with 75 grams of anhydrous glucose, it has to be more than 200. And then there are diagnoses in between normal and abnormal, which are called pre-diabetes, which could be based either on an abnormal fasting criteria or an abnormal post-load criteria, but not high enough to hit the threshold which diagnoses diabetes. Now, where did this really come from? Again, I think in terms of for clinical medicine, the most important issue is this person diseased or non-diseased, right? And if this person is diseased, what do you need to do? And one of the strongest correlates of glucose levels are microvascular complications, specifically diabetic retinopathy, the disease of the fundus or the retina of the eye. And these thresholds really represent, based on data from 3 different longitudinal cohorts, represent inflection points beyond which retinopathy risk increases. So there is a direct clinical readout which has been used to define these criteria, which is important to understand, and I'll tell you why in a moment. In addition to this, more importantly, now this is where the confusion starts setting in, hemoglobin A1C was originally used primarily as a measure of the previous 3 months of glucose control and was used as a metric for target of control. It is now also being used for diagnosis of diabetes. If the hemoglobin A1C is more than equal to 6.5%, it is then considered to be a diagnostic of diabetes. Now, what I wanted to tell you about this is, if you now see prevalence or burden of disease, and this is really important to understand because you will find such different numbers that it becomes difficult to figure out why. These are data from the ICMR INDIAB study, in which primarily what was done was either a fasting glucose or an OGTT. So they were glucose-based diagnosis, and the projected burden in India is about 100 million people, give or take. Now, if you then include hemoglobin A1C also as a diagnostic criteria, and this is a more recent analysis from the NCD Risk Factor Consortium, that number rises, and I'm sorry you can't see it and I can't point it out to you, that number rises from 100 million to 200 million, right? So it clearly is saying that there is even heterogeneity in the way you diagnose diabetes. How does it suddenly happen that if you use a certain set of diagnostic criteria, your projected or calculated burden is 100 million people, and if you use another set of criteria, it jumps up to 200 million people. So again, it's important when you look at longitudinal data sets or you compare different studies, please look at the diagnostic criteria which have been used, otherwise they are prone to cause confusion and confabulation. If you thought this was bad enough, and this is my sort of last slide before I jump into GDM, the story of evolution of diagnostic criteria for GDM, and I'm bringing this up again because I think it's important for us to understand why we use certain numbers to decide that a person has disease or does not have disease. The initial study for diagnosing hyperglycemia in pregnancy or gestational diabetes was done in inner city blacks in the Boston area, which are very different from all of us sitting in this room, right? Now, what they did was, and they did what normal people do with statistics, they said, fine, we'll do the sugars and we will look at plus minus 2 standard deviations. Anybody beyond that will be considered abnormal. As it happened, though they did it with the purpose of, did a statistical normalcy and abnormality, those who were 2 standard deviations or more also identified a group of women who had a higher tendency to develop diabetes in the postpartum period. So there was a clinical readout which was out there. That's how it started. Then it evolved. Somebody said 100 grams, somebody said 3 tests, 2 tests, 75 grams. It kept on going. Subsequently, a study came out in which they looked at actual clinical outcomes in pregnancy. So the composite outcomes in pregnancy, both maternal and neonatal, and said that if you use these thresholds, you will diagnose individuals who are more likely to have these clinical outcomes. So we've moved from statistical to relationship with post-pregnancy outcomes to pregnancy outcomes. And that again shares how the numbers vary over a period of time. And again, it's important for you to see when you're looking at different studies as to what criteria have been used and what they're actually saying. Let me now move to the sort of the second half of my talk, which is some information on gestational diabetes cohorts, because there's a lot of other NCD cohorts which have been done. And I will now split this into two. One is work which we've done with the THSTI team on the Garbini data set, which, as you realize when you heard Pallavi speak, yesterday, Garbini was never created for gestational diabetes. But I wanted to specifically talk to you about this is because it also conveys an important message. You may start a cohort for anything, but please look at opportunities to diversify the questions you can answer with that cohort, right? So you needn't just be so restrictive that you will, you can just continue to answer the same question. And that's how also, unless you have a big pot of money which is coming repeatedly, you diversify the questions and you get more grants to continue to keep that cohort alive. So that's the first part. And the second is what happens to these women in their post-delivery years. As an adult endocrinologist, for me, it's very important to identify this problem, because this no longer is a problem which is going to be dealt by the obstetricians, whose focus of interest is the pregnancy and not what happens after the pregnancy. So you've heard about the Garbini, and I won't talk to you much about Garbini because these are slides which have already been shown by Pallavi. For those of you who were not here yesterday, essentially it's a cohort which is put together painstakingly and in large numbers to answer the issues related to preterm birth, which has its own significant clinical relevance. And they've looked at epi, they've looked at multiomics, they've looked at imaging, and they've also looked at integrated analysis. And I will not go to you in this detail because this has already been mentioned. And let me now jump to the gestational diabetes part of the Garbini cohort. So during a set of conversations in a meeting like this, we realized that it's a very important human resource, because in any case, an oral glucose tolerance test is mandated for every pregnancy. It's a clinical requirement. It's not a research tool. And therefore, the Garbini cohort was also undergoing an oral glucose tolerance test. In the initial years, in the initial few months, this test was perhaps done in non-standard conditions in a non-standardized laboratory. So we came into the picture and sort of, with the Garbini team, developed clear practice or standard operating procedures, how the test was done and how the measurements were done. And therefore, we now have the luxury of piggybacking work of gestational diabetes onto a cohort which had nothing to do with gestational diabetes to start with. So this is the message that I want to really convey. The cohort may be started for whatever reason, but you can diversify. I'm not sure if Shivani or Sailesh mentioned about the fact that the CARS cohort was started for cardiometabolic assessment, and we are now diversified into cognition and dementia and Alzheimer's disease also. You have to have the ability to really diversify whatever you start, and it helps you answer multiple questions without adding so much to the cost of setting up a new cohort for everything that you want to study. So about 3,500 participants underwent an oral glucose tolerance test. About 1,700 were considered to be appropriate both on internal and external quality. About 10% were diagnosed with gestational diabetes. So that's the current status, and there's still an ongoing accrual of that. But the important thing for us is, based on this, we can perform what are called nested case control studies. So you have a cohort, you have within that individuals who are identified as cases, and then you have within the same cohort other people who will serve as their controls, right? And so they're very important questions which can be answered, which really have not been looked at in such great detail, because we have these women entered into the cohort well before their gestational diabetes was diagnosed. We have early pregnancy data on them. We also have multiple blood samples at different time points to do those measurements. And we also have multiple anthropometric assessments, both for the mother and for the fetus. So what has been done at the moment of time is that we are looking at gestational weight gain, not just absolute gestational weight gain, which can happen in any cohort or any normal pregnancy, that you know what happened at their first booking visit and what happened at the time they delivered, but we have patterns of gestational weight evolving during pregnancy. Is it a continuous increase in gestational weight throughout? Is there a pattern which predicts that this woman is likely to develop gestational diabetes, so we can actually identify that subpopulation in advance and therefore take more care? Is there a biomarker which we can pick up early in pregnancy which predicts that 3 months later or 4 months later, this person is more likely to have gestational diabetes? So again, it becomes very important that if you can predict and project, you can intervene early rather than treat a person once they develop a disease. It's always better to aim at prevention rather than therapy. So in this particular case, we found, and this is for fetal growth trajectory similarly, normally it is considered that women who've had any degree of glucose abnormality in pregnancy, whether diabetes or gestational diabetes, and if it's not managed well, the fetus is prone to be large. It's a macrosomic fetus because insulin actually serves, the glucose goes from the mother to the baby produces more insulin, which serves like a growth factor, and the baby becomes large, and big babies have their own sets of problems. But what we've really interestingly seen is that in gestational diabetes, it was not always a large fetus. As you can see, there was an early restriction in fetal growth and then a rebound increase in size later on in pregnancy. Again, there are very little data sets which have allowed people to evaluate this, which is critical, again, to see patterns of evolution of a fetal growth trajectory. This is work which I think Pallavi might have mentioned, but if not, we've also got a mass spec-based proteomics, which is being done, and I think there's a poster outside which you can have a look at if you have the time. Again, there are initial data which are suggesting some differential proteomics in women who went on to have gestational diabetes later in pregnancy versus those who did not, and these were early trimester samples. Let me now move to the last bit, which is essentially an in-hospital cohort which we've established a few years ago, which is specifically for looking at post-delivery implications for women with a diagnosis of gestational diabetes. As I mentioned it briefly in the past, that we no longer should be looking at gestational diabetes as a limited disease entity only happening during the course of pregnancy. It is obviously a situation which is predicting future cardiometabolic risk, and the likelihood of women with gestational diabetes to develop diabetes and cardiovascular risk is significantly higher than women who don't have gestational diabetes. With a new set of diagnostic criteria for gestational diabetes, there seems to be some bifurcation based on the severity of hyperglycemia. So now there's an entity called gestational diabetes, and those who have got much higher values are called overt diabetes in pregnancy. Again, bringing in that granularity or heterogeneity within a previously considered homogeneous population. So we've established this cohort of Indian women with hyperglycemia in pregnancy and also added families for two reasons. As I already mentioned, for diabetes, it's not just a genetic predisposition, it's also your environment, which means the home environment. Interestingly, there was evidence to suggest that there is a concordance between the spouses in terms of cardiometabolic risk, which is obviously a non-genetic issue, right? The very fact that they live in a similar environment often led to similar eating habits, similar behavioral patterns, similar exercise patterns, which have then resulted in some degree of concordance in cardiometabolic risk, which therefore means that if you want to intervene and address these people, you should use a family as a unit. And the second part was that there is a vertical transmission also, which is seen. There's a transgenerational effect. So mothers with gestational diabetes have babies who are not only likely to be born large, but who later on also seem to be at a higher risk for cardiometabolic abnormalities compared to babies who are born to mothers with a normal glucose during pregnancy. So, so already mentioned this, that we tried to now, using this cohort, we're looking at the heterogeneity within the bucket of hyperglycemia in pregnancy. And we're looking at the concordance rates amongst married couples. And we're looking at the cardiometabolic profile in their offspring. So this is what was done. And to give you a sense, women who were diagnosed with gestational diabetes at the All India Institute of Medical Sciences were recruited. They were called in along with their spouses and children. A basic set of parameters were done, both biochemical. We looked at their glucose tolerance, we looked at their lipid parameters, we looked at a range of other measurements. We looked for fatty liver, which is now a very important emerging area of interest. And we've then been keeping them under our follow-up over a period of time. So this is the enrollment, so the formal enrollment, this is part of an ICMR supported study. The formal enrollment, we stopped in 2022. We're still, but for the purpose of this discussion, I'll refer to those who were enrolled till about 3 years ago. We approached about 3,000 women, only about 1,000 agreed. And you can see the breakup was about 650 women with gestational diabetes, about 200 women each who were either normal or either pre-existing or overt diabetes. Now, this is just to give you a little sense of how there are differences. If you look at the the column which says normal glucose, NGIP, you will see that they had, the ones with normal glucose had the lowest BMI, whereas those who had any degree of hyperglycemia, especially if they had an overt diabetes in pregnancy, their BMI was more. So that's one thing. The second thing is that the increase in BMI during pregnancy is a very important event which happens. So we've noticed that women who've developed gestational diabetes gain about 4 kilograms per square meters of BMI, which is a significant bump in BMI from the start point of their pregnancy to the time of their delivery. And a large number of those women never shed that weight which they have accrued, which has implications for their metabolic health as we go ahead. Right? Right. So just to give you a sense of what we've managed to cull out from this, one was comparing a cardiometabolic profile of women with a history of overt diabetes, which I said was the more severe hyperglycemia in pregnancy, compared with gestational diabetes, which is also hyperglycemia, but within certain limits, and women who had normal values. And the important thing you're seeing is that the rate of conversion from a prior gestational diabetes to actual diabetes, even after the pregnancy is over, is about 2.5% annually for a woman who has had a normal pregnancy, which would be consistent with what is seen in her age-matched non-pregnant controls in the population. That jumps to about 15% or even more in the first 12 to 18 months or 20 months in a woman who was diagnosed to have gestational diabetes. But look at the last column in the top row. If you had a more severe version of hyperglycemia in pregnancy, 70% of those women had already transitioned to type 2 diabetes in the first couple of years after their delivery. Now remember, these are not 50 or 60-year-old people. This is a bunch of women who've been pregnant recently. Let's say their average age was somewhere between 27 and 32 or 23. For them to give a type 2 diabetes at that age means they're looking at a lifetime of 40 or 50 years of exposure to hyperglycemia, which carries all the complication risk which have been noted with people like that.
Dr. Tandon, can you please summarize?
Yeah, give me 2 minutes and I'll do that. There is a new entity which is called early gestational diabetes, which previously gestational diabetes was usually done, measured in the latter half of pregnancy. Now there are data which says that there are women who have started developing gestational diabetes early in pregnancy, and they also carry significant cardiometabolic risk. Okay. This is what I was referring to, the advantage of having, so the cohort was for women, but we also included their spouses. You need to show that nimbleness when you're acquiring this thing. You can see that there is a level of, that there is about a 40 to 50% level of concordance between spouses for cardiometabolic risk factors, be it glucose, be it lipids, be it obesity. That again shows that it's an environment which is contributing significantly. Obviously, there's an underlying genetic risk, but that environment makes a lot of difference because when people living in the same household carry that risk together. Okay. Right. Let me just give you a sense of the cohort and then close this thing. Now, the cohort as it stands today is really in a good position to answer several questions on hyperglycemia in pregnancy and its aftermath. So once it's there, you can keep adding more questions, which is an important part. It gives us a detailed understanding of these risk factors amongst young couples and their offspring. It also gives us an understanding of the pathophysiological aspects of conversion to diabetes, and it has a very important role to play for us to understand what we can do between two pregnancies, because the bulk of these women will also transition to a second pregnancy. So let me stop here by saying that the primary aim of this presentation was to acquaint you with the concept that, number one, diabetes itself should not be considered to be one sort of homogeneous entity. There are different verticals which may evolve differently, may have a different complication risk. Number two, the way you need to understand diagnostic criteria. From a clinical perspective, a diagnostic criteria has to identify somebody who is normal from abnormal and requires intervention. From an epidemiological perspective, it may have a slightly different version, and these things happen. Whether it's diabetes or gestational diabetes or whatever. And for a category of disease like gestational diabetes, which is now really, so the INDIAB study, which Dr. Mohan's group has led from the ICMR, has just, the paper is going to come out now, looks at about a 20% prevalence of gestational diabetes in pregnancy as across. This is a pan-India study, so which is again important to understand. But the other important thing is to say that this gestational diabetes gives you an entry point into a life course approach to cardiometabolic risk for a woman. We should not assume that it starts and ends with pregnancy. It continues well beyond. And an opportunity should always be taken to follow these women up to see what happens and what can be done to prevent it from happening. I'll stop here. Thank you so much.
Thank you very much, Dr. Tandon, for excellent overview about diabetes along with pregnancy and obesity. We'll have 2-3 questions. I'll start with my question. So based on your studies, and I can see there are some retrospective study in Europe as well as in US, where people have shown T2DM, especially the type 2 diabetes, there is a huge linkage with obesity, along with different subtypes of breast cancer, including TNBC. Any such kind of correlative studies has been done in India? That is question number one. Question number two, when you talk about that vascular complications, and because of that, there is endothelial dysfunction, as well as some of them developing atherosclerosis. What kind of therapeutic and treatment strategies providing to those category of patients who are developing atherosclerosis along with diabetes?
Okay, for the first question, obesity and diabetes are epidemiologically linked with excess risk for breast cancer and for uterine cancer. Possibly relates to a change in estrogen dynamics in these people, especially with the fat causing a differential conversion of circulating androgens also. So that's established. I'm not sure if it's been replicated in India. I don't know much about the oncology literature, but I'm sure it would be a consistent, because the physiology behind would be common across all ethnicities. In terms of the cardiovascular risk, I think I'm going to answer it a slightly different way first. So, though those data have subsequently been, considered to be perhaps needing some modification, but two sets of data, right? In women, usually you don't get clinical cardiovascular disease before the menopause. Usually, it's a very low rate. In women with diabetes, that protection seems to go altogether, right? So it's clearly suggesting that any protection which a reproductive age group gave to a woman is overcome or reduced or significantly abolished because of diabetes. The second was a study called the East-West study, which looked at 4 cohorts, right? A cohort of a person who were normal with no evidence of heart disease, person who had previous heart disease but no diabetes, previous diabetes but no heart disease, and both diabetes and heart disease. And they looked at the 7-year risk of future myocardial infarction in this population. And it showed that if I had a prior heart attack, even if I didn't have diabetes, I had, let's say, an X% risk for future heart attacks. If I had diabetes and I did not have a future heart attack, I still had a similar risk. So diabetes was really started to be considered as a cardiovascular risk equivalent, and therefore the degree of aggression and the targets for control which people are expected to meet in people with diabetes are similar to those you would address in a person who had a prior heart attack. So aggression is the key. You will start treating at lower LDL levels, you will start targeting lower LDL, you will start targeting low blood pressure, you will start targeting lower blood. So that's how you will address the atherosclerosis risk in people with diabetes. Aggression, you start with the assumption as if they've already had a heart attack, and then you work your way up. I'm giving you a very broad picture. There are obviously subtle nuances about this also.
Thank you very much. Any question from audience? Yes. Okay.
Thank you for the talk. Just one query. Physiologically, like you said, we have seen the limits which have.
Can you talk little loudly?
Like we have seen the limits being as the 126 or the limits to define hyperglycemia or diabetes. They have been shown to have a clinical outcome. So that is how they have been defined. Is that population specific? Do they need to be studied population-wise? Because Indians have been shown to have a low muscle mass and other factors. So will the same limits define? And in relation, will it also imply the same physiology in GDM?
Okay, so let me answer the second question. Was that physiology in GDM, so if you're looking, it depends on what outcome parameter you're looking at, right? If you're looking at a pregnancy outcome, the exposure to hyperglycemia is very restricted. It's going to happen for a few months. So you're obviously not going to get easily measurable vascular outcomes out there. Therefore, you have to primarily look for either maternal or fetal outcomes. So therefore, you will not look at vascular complications if you're looking at pregnancy-related outcomes. The moment you transition it to post-pregnancy outcomes, then you come back to the whole story of type 2 diabetes. So the first question, it's a fairly relevant question. We don't have the data for it, but it may well be because your threshold of relationship between a level of glucose and a certain vascular event may vary from population to population depending on what their underlying risk in any way is. So this is going to be an incremental risk over that. The second thing is that retinopathy was, let's say, diagnosed by, fundus ophthalmoscopic examination or fundus photograph, which is one measure of an outcome, right? you can have more sophisticated measurements of retinopathy today, which can pick up maybe even earlier changes in the retina. If you use those, that threshold might change from what has been described before. So use both a population-based issue and also the metric and the instrument used to define that clinical outcome may change.
Okay, thank you very much, Dr.
Thank
Tandem.
you.
So we'll end this talk because we are running a little late. So we can have discussion due to the time. Now my co-chair will introduce the second.
So the second talk is by Dr. Chitranjan Yajnik. He is a professor and director of the diabetes unit at KEM Hospital and Research Center, Pune, India. He also serves as adjunct professor at ISCR Pune and visiting professor of molecular medicine at the University of Exeter, UK. He is going to talk about vitamin B12 folate imbalance and risk of diabetes in the offspring, findings from the Pune maternal nutrition study. Dr. Yajnik, please.
Are you able to see my slides?
Can you get
Hello?
the slides on, please?
Yeah, are you able to see my slides?
We are not able to see the slides yet. Can the technical team please connect the slides?
Can you see it now?
I think the technical team is working on it right now. Yes, now we can see the screen. Now it's much better. But we haven't seen the slides still. Yeah, now we got the slides.
Thank you, Chairman. Thank you, organizers, for letting me speak online. Speaking after Nikhil, always difficult. But I've changed my topic a little bit, and I'm going to concentrate on diabetes in South Asians, what is different. And B12 story is going to be embedded in this talk. So I actually hope it will be all right. I bring you compliments from KEM Hospital, Pune, Diabetes Department. And I'm always fond of saying that this is the only diabetes department in the world where the main logo is mother and baby. Because we firmly believe in fetal programming of diabetes when the baby is in the mother's womb. We have acquired a modern logo about 10 years ago, and that's the modern Ganesh. He works from home. He doesn't travel on the back of the mouse, but he clicks the mice. So that's the rapid transition we had. So a combination of fetal programming and rapid transition are at the root of diabetes epidemic. Nikhil said there's a lot of data, there's a lot of diabetes in Indians. The numbers might change depending on criteria, but millions. So what is the phenotype of type 2 diabetes in South Asian Indians? And I did this work almost 40 years ago when I was in Oxford. I compared 200 patients from Sassoon Hospital where I did my MD and 200 patients in the Radcliffe Clinic in Oxford. And what we found, which I published much later, what we found was Indian patients were diagnosed 10 years younger, even 40 years ago. They had 5 units lower BMI. They had smaller mid-arms, so smaller muscle mass. But they had higher waist to hip ratio. They had higher subscapular to triceps ratio. So 2 indicators of central obesity and adiposity. And when we were able to measure body fat with a DEXA machine, later on we added that for each kilogram, Indians have higher fat percent compared to the white people. And this remained unpublished, but I was speaking about it So this became the concept of thin fat Indian. And this was really supported when I published my own picture here with John Yudkin, who was my friend and collaborator, where we showed that despite having similar BMI, I had more than twice the amount of body fat percent compared to John. The same BMI, but more than twice the adiposity. We look thin, but we are adipose. And how does actually this apply to diabetes clinic? And Mohan showed you data from Nikhil showed you data from Mohan's clinic. This is the cluster report we have done from my department. And this showed in comparison to Sweden, if we look at young onset diabetes patients in Indian clinic, Swedish 2/3 patients are MOD or moderately obese. In India, more than 50% of patients in Pune and more than 65% of patients in Assam, which is an impoverished state, have severe insulin deficient type of diabetes and MOD relatively rare. So we have a distinct phenotype of early onset, low BMI diabetes in Indians. Can genetics help us understand these phenotypic differences? And I have to thank Moniza Siddiqui, now in London with the Genes and Health study in the East London. She recently published a paper relating polygenic risk scores for 3 aspects of obesity and adiposity. The green ones are the Indian patients and the pink ones are the British patients. What she showed was the Indians had lower polygenic risk score for obesity, but they had higher gene risk score for 2 types of lipodystrophy, which are related to either central fat distribution or hepatic fat distribution. So in other words, we have lower obesity as measured by BMI, but by fat distribution, we are adipose in the central and in the intra-organ fat, especially liver. She did a study with Mohan's group when she was in Scotland, and what she showed was if you look at polygenic risk score of insulin secretion of beta cell dysfunction, then that was higher in Indians, the pink group here. So Indians had a higher insulin or beta cell dysfunction risk score. So we have some genetic basis. As you know, polygenic risk factors are of course a combination of hundreds of SNPs, and their individual contributions are very small. Large part, as Nikhil explained, comes from environment, but there is certainly a genetic basis. So can nutritional history help us understand the risk of diabetes at a young age and at lean BMI in the South Asian Indians? I don't know how many of you know of this study. This is a study done by the Non-Communicable Disease Risk Group of WHO. They traced the height of different populations in the world over the last 200 years. While Europeans gained 10 to 15 centimeters in height, Indians didn't get anything, practically nothing, over the last 200 years. That means there is a chronic nutritional deficiency and failure of height to thrive almost for 200 years, or perhaps more. Nikhil is the first author of this GBT India study, where we showed age standardized percentage change in last 25 years in different states of India. And the red ones are predominantly the Bimaru states. those who have been chronically deprived either socio-economically, education-wise, or for various other social determinants of disease. And this is very interesting if we try to relate these two factors, that states which have been chronically deprived have a recent explosion because they have accumulated susceptibility to diabetes due to chronic undernutrition. And someone in England did this video and article for Guardian, and she clearly blamed British. How British colonialism increased diabetes in South Asians, and then she admitted it's complicated. And there are dramatic figures she has shown, but I was very happy. Without my permission, she showed my picture in this video, so she acknowledged some of the work we have done. And Professor Tripathi described an extreme form of undernourished diabetes in city where actually you are sitting almost 70 years ago. And last few months, you must have read about type 5 diabetes, which is a new nomenclature for this type of diabetes, which is now acknowledged by IDF and Lancet Global as a consensus statement published on this a couple of months ago. So what is the crucial window for nutritional influence, which we call programming? There are a series of studies in last 50 years which have shown the importance of fetal nutrition and future risk of diabetes. The first study was the Dutch winter hunger study, where towards the end of the Second World War, the Western Holland faced severe famine because the Germans cut off the food supply. The women who were pregnant, they also had to go on 600 calorie diets. And their children were followed up and studied at the time of army conscription. And they made some extremely interesting findings. This has now actually become a subspecialty of Dutch winter hunger studies. Those babies who face the Dutch winter hunger in the first 2 trimesters of pregnancy, they were more obese as army conscripts. Probably because their hypothalamic centers, which were developing at that time, started looking at the world as a famine place, and they overate in the later life. Programming of appetite. The Pima Indian studies, which Nikhil again mentioned, showed that if mother had diabetes during pregnancy, so fetal overnutrition, the baby was more likely to be obese and diabetic right from early age, before 10 years of age. So both fetal undernutrition, fetal overnutrition of macronutrients was known to produce increased risk of obesity and diabetes. Finally came David Barker's study in 1991, which showed in the Hertfordshire cohort that lower the birth weight, higher the risk of glucose intolerance and syndrome X, which is now we call it metabolic syndrome, at 65 years of age. So this established that poor fetal growth is a risk factor for future diabetes and metabolic syndrome. And David Barker caught this, like always, in a very catchy statement. He said the womb may be more important than the home. And India, of course, is the world's capital of diabetes on one side, gestational diabetes on the other side, as well as of low birth weight and undernutrition. So India provides a great ecological evidence that a country which produces the smallest babies in the world is also now competing to be one of the capitals for diabetes and gestational diabetes. So this has now been called the fetal programming, And the new specialty is called DOHAD, Developmental Origins of Health and Disease. And I was lucky enough to meet David Barker in 1991 and set up number of studies with him. What David Barker and Caroline Paul wrote was that intrauterine nutrition, maternal metabolism, stress, pollutants, endocrine disruptors, and whatnot. If the baby is exposed at specific sensitive windows during development, there is a permanent change in structure and function which affects the development of various organs in different ways. So be it number of nephrons in the kidney, hepatic zonation, pancreatic beta cell number, muscle, fat and bone balance, brain programming, HPA endocrine axis, various other things. And for our purpose, this increases central obesity, metabolic syndrome components, and increases risk of diabetes and heart disease. So with David Barker and Caroline Fall, I set up Pune Maternal Nutrition Study in 1993 in 6 villages near Pune. So this is the cohort bit now. It was set up to do two things. Why Indian babies are the smallest in the world. So determinants of fetal growth and body composition. And then followed up these children as long as you could to establish life course evolution of phenotypes. We went to 6 villages, enrolled more than 2,500 women. More than 800 of them became pregnant, who were studied 2 or 3 times during pregnancy intensively for their nutrition, physical activity, glucose tolerance tests, lipids. We studied fathers also, and we studied fetal growth by ultrasound. At birth, we did detailed anthropometry, and we continued to do it every 6 months for 18 years till the adult age. And every 6 years, we call the families in our paramedical ward and study them for size, body composition, nutritional intake, physical activity, cardiometabolic risk factors, cognition, and whatnot. We are currently finishing the 24-year follow-up, which has taken us longer because of the delay by the pandemic. And you can see we have very impressive follow-up rates, at least till 18 years of follow-up, more than 90%. And we set up a biobank within this cohort, starting from woman's pregnancy and going on into the adult age of the children. Parents are also part of it, and now the 3rd generation grandchildren are also part of it. So what was the average mother in the Pune maternal nutrition study? She was 42 kg, 1.52 meters, and with a BMI of 18.1. So undernourished by international criteria. Predominantly vegetarian. She ate less energy and protein than recommended. Lower intake of micronutrient-rich foods like green leafy vegetable, milk and fruits, and very substantial physical activity as you can see here. Gestational diabetes as defined by WHO criteria in 1993, practically non-existent. B12 and iron deficiency, 2 out of 3. Folate deficiency, again practically non-existent. So a very peculiar metabolic nutritional state, lower intake of calories and macronutrients, lower intake of micronutrients, but an imbalance between B12 and folate. How were the babies at birth? They were on average 2.7 kg. Compare them to English babies, they were 3.5 kg. So we measured 500 babies in Southampton, where David Barker works. And we compared various things between these babies, and that revealed some stunning findings. On anthropometry, as expected, given the low birth weight, Indian babies had low BMI and ponderal index. They had smaller muscle. They had smaller organs in the abdomen. And very interestingly, they had higher subcutaneous fat. So the thin fat Indian phenotype originates in utero. This is the thrifty phenotype of the newborn Indian baby. People said, can you really do such nice anthropometry? So I had to do MRI in 30 babies in Pune and 30 babies in England. And what did it show is to our stunning, again sort of expectation, all the three layers of abdominal fat, namely two subcutaneous and the visceral, were higher in the Indian babies despite being 800 grams lighter. And in the cord blood, we demonstrated that Indian babies had higher leptin and lower adiponectin concentrations. So at birth, Indian baby had the body composition and circulating endocrine metabolic state which predisposes them to future diabetes. Talking about this when woman is pregnant at gestational diabetes, etc., is a great compromise of science, and I am strongly against it. Therefore, this needs to start very early in life. What about the 1-carbon metabolism related associations with baby size? Red cell folate in the mother was a strong predictor of the size of the baby and not shown here also of adiposity. While homocysteine, which indicates a disturbed or dysmetabolism in 1-carbon metabolism, was a predictor of small size at birth measured as SGA, small for gestational age. And where did this high homocysteine come from? 2 out of 3 mothers had B12 deficiency, so that was the major driver of homocysteine. Folate deficiency relatively rare, homocysteine high in third of women, and MMA, an indicator of B12 deficiency, high in 90% of women. So low B12, high folate imbalance in the mother. And this is the 1-carbon metabolism. We are not going to go into it, though I had originally planned to do a detailed talk. I thought general diabetes thing would be more interesting. But 1-carbon metabolism driven by B12, folate, B2, B6, B10 and choline drives DNA synthesis, DNA repair, methylation of DNA. As we all know, this is an epigenetic mechanism, genomic stability, and importantly protein synthesis, because as we all know, the initiator amino acid for all proteins is methionine, which is methylated homocysteine. And we have shown that B12 supplementation influences methylation of various genes associated with type 2 diabetes and its intermediate traits. This is work done in Dr. Chandak's department in the CCMB. So come 6 years of age, and what do we find? We find that mothers who had lowest B12 in pregnancy and highest folate levels in pregnancy, their babies were the most insulin resistant and they were also the most adipose. In other words, 2 risk factors for future diabetes, adiposity and insulin resistance, were as if driven or at least associated with B12 folate imbalance. Findings supported by a study in Nepal, which was followed up to test our hypothesis. Come 18 years of age, and now we have a triple burden in these children. Their BMI was only 19. 30% had pre-diabetes. 40% in males and 20% in females, and two-thirds still had B12 and iron deficiency. So on one hand, undernourishment signs and symptoms, and on the other hand, metabolic dysfunction in the glucose insulin metabolism. What I am not showing today is that those who had pre-diabetes at 18 years had higher glucose at 12 years of age, higher glucose at 6 years of age, and their mothers had higher normal glucoses in pregnancy. So saying that we will diagnose them at later age and do some intervention for primary prevention is a myth. I seriously challenge from this. This paper is coming out. This paper has already come out in Diabetes Care in 2022, and the serial glucose paper is predicted to come next month in Diabetologia. What were the associations of prediabetes at 18 years? Poor linear growth in utero, so short birth length, smaller head, mother which was not overweight,
in the
obese.
next 2-3 minutes, please, because we want some questions.
Take
Also.
5 minutes, please. Yeah, 5 minutes.
Sure.
And slower liver growth, along with excessive growth in the postnatal period and a large liver at 18 years. So what we had shown for birth weight before, low birth weight followed by high BMI, it's true even for liver, because we had the foresight of measuring liver size in these babies 30 years ago. So chronic deprivation and rapid development is a soup which favors non-communicable disease. What can be done? We cannot stop development. Can we tackle susceptibility? And this is a case for so-called primordial prevention, which happens very early in life, possibly before the beginning, that is even before conception. And we did a PRIA trial, a preconceptional primordial trial with vitamin B12 and multimicronutrients in the F1 adolescents to influence F2 diabesity in the cohort. And just to summarize the findings, what we found was there was an intergenerational increase in birth weight, length, head circumference, and abdomen. So brain and organs had developed better in the children compared to the mothers. But very interestingly, did this associate with higher adiposity? So thankfully no. Without any increase in adiposity. So I think our intervention along with background secular change has improved the Indian phenotype and is now likely to actually help us curtail the diabetes and non-communicable disease epidemic if we do things right from before conception. So this is an early suggestion of amelioration of thin fat phenotype. And when we measured the neurocognitive function between 2 to 4 years of age, mothers who had received only 2 microgram B12 every day from adolescents, their babies perform better on the neurocognitive function. So take-home message is that long-term and short-term nutritional history of a population reveals nuances of diabetes etiology. Additional epigenetic susceptibility is a new understanding that's called programming, and this is modifiable unlike the genetic susceptibility. We have an evolving double burden of malnutrition because of multi-generational undernutrition but rapid development. Not only macro but micronutrients are also important, and I have shown you importance of 1-carbon metabolism. Primordial prevention is preferred because it addresses susceptibility. And then it becomes a community rather than a clinic issue, and sociology rather than the science. So arts rather than the science is the answer to our future problems in sort of designing national policies. And I thank my collaborators, my department staff, the participants in the cohort, the village staff who have made this possible. So thank you very much for patient listening.
Thank you, Dr. Yajnik. So we'll take up some questions. I have a question. In the beginning, you said that more of our patients are insulin deficient as compared to the West. So what are the therapeutic implications? Do we need to start more adult patients on insulin rather than the West?
Yes, therefore, promoting insulin secretion from within the body, or if that's not enough, providing insulin in time is the answer. Insulin resistance, of course, exists, like Dr. Nikhil said, and like I showed. So that is an additional treatment, but majority of young onset thin patients are insulin deficient, and the clinical inertia driven both by the patients and the doctors should be overcome, not to hesitate starting insulin early in treatment. And drugs like, say, sulfonylureas, DPP4 inhibitors, GLP-1 agonists, and also the drugs which work independent of insulin like SGLT should be tested. And I think such a trial is indeed happening in Chennai in Dr. Mohan's unit.
Thank you very much. Can we have a question from the audience? Yes, Nikhil.
Dr. Yajnik, wonderful talk as usual. Just a quick query. I mean, not traditionally, recent data suggests that early onset type 2 often happens with a female to male preponderance, perhaps because of the coexistent sort of contribution of PCOS and other pubertal changes. The 18-year-old data from the PMNS seem to suggest that pre-diabetes was commoner in males as compared to females. Would you have any thoughts about these two statements? Obviously don't sort of coincide with each other. Any thoughts on that?
Right. Thank you, Nikhil. We have data which is community based and a rural undernourished population, and clearly there is a male excess which we have found even in subsequent years in, like, say, parents of these children. So fathers have twice as much diabetes at 50 years of age as mothers. Now, the female preponderance in the studies you are quoting, I honestly don't know how to explain it. I fully agree that they are predominantly maybe hospital-based cohorts where women with predisposing causes are additionally enrolled or super enrolled in such cohorts. That's one thing. Second thing, you mentioned early gestational diabetes. I think it's a new unnecessary myth. When you read my paper in Diabetologia next month, you will see it all begins very early in childhood. And because we do the test early in pregnancy, to call it early gestational diabetes is wrong. You know, I strongly oppose the word gestational because this is not gestational phenomenon. And till today, we don't know what really diabetes in pregnancy is. So I have extreme views on this, but early gestational diabetes to me is one more myth being added to a large number of myths which are prevailing in the field of JDM.
Any other questions? Yeah, one question. Kumardeep.
I'm Dr. Yogendra from IHBT Palampur. I have one question, right? During the paternal genetic predisposition along with the pregnancy, the diabetes associated in pregnancy, have you come across any association with the early onset of diabetes in the offspring, or the type 2 diabetes, maybe the insulin dependent diabetes in early, or the P2DM in the latter stage of the offspring?
So you are asking me about paternal contribution, and you are asking me about increased incidence of diabetes in children born in diabetic pregnancies. Have I understood correctly?
Right. together.
Okay. So we are just now in the process of publishing our follow-up of 200 children born in diabetic pregnancies, and we have studied not only mothers but also fathers. And a very interesting story has emerged that the children born in diabetic pregnancies are at higher risk of being overweight obese as childhood and early adult age, and they also have higher prevalence or incidence of diabetes and pre-diabetes at very young age. What are the drivers of diabetes in children? What are the drivers of overweight obesity in children? And this is where it becomes very interesting. Diabetes in children is driven entirely by maternal diabetes in pregnancy, while the overweight obesity in children is driven by biparental overweight obesity. So there is possibly a genetic as well as family contribution to obesity, while intrauterine programming is the major driver of diabetes in children born in diabetic pregnancy. Does that answer your question?
Yes.
And now additionally in last 2 years there are number of very interesting papers on epigenetic transmission through sperms from the father into the baby. And a number of very interesting papers have been published in Nature. Proud to say one of them is led by an Indian female worker now in Germany, Archana Thoma, who was previously in CCMB. So she has shown beautifully how the epigenetics of the sperm influences the growth and the predisposition to disease in the offspring.
Thank you, Dr. Yajnik. We'll now go on to the next talk.
Our next speaker, Dr. Sudha Vasudevan. Mrs. Sudha Vasudevan served as Senior Scientist and Head, Department of Foods, Nutrition and Diabetic Research at Madras Diabetes Research Foundation, Chennai. She has served as Principal Investigator and Co-Principal Investigator more than 30 national and international research projects and has authored over 95 publications in peer-reviewed international journals and book chapters. She is an active member of several professional organizations, including Indian Diabetic Association, Nutrition Society of India, and the Research Society for the Study of Diabetes in India. She will be delivering her talk on unity in diversity, uniform in risk, the Indian diet story behind rising metabolic risk from ICMR INDIAB study. Dr. Vasudevan, over to you.
Thank you very much for the kind introduction. First of all, my sincere, heartfelt thanks to the organizing committee, particularly Dr. Shantanu and his team. And very good morning to all of you. And ladies and gentlemen, the respected chairperson. My talk is on unity and diversity when I'm talking about how unified our diets are across regions, across states, still how diverse they are. In spite of unity and diversity, what is so common with regards to diet and disease association? So I'm going to tell you the diet story behind this high metabolic risk, which all the speakers have been talking last 2 days. Now, my talk section is compartmentalized into 3 storylines. One is the past, and the past has been beautifully explained by Dr. Yajnik that started from the fetal. I'm not going that far. I'm going to the recent past with regards to the management of diabetes by dietary recommendation and the present scenario and the future, the way forward. So the past is the history. Post yesterday, one of the speakers said that until the discovery of insulin, it was a starvation diet, right? The post-starvation diet, we started with the recommendation of diet starting from 1930s. The yellow line represents the carbohydrate. Sorry. The yellow line represents the carbohydrates, and the red line represents the fat, and the purple line represents the protein. All are calories per day. As you can see from 1930, which was almost next to the starvation, is very low carbohydrate diet, starting at 14% energy or calories per day, whereas at the cost of very high fat, 69. The bell must ring to all of you. This is the same scenario. Today we are talking about the fat diets of cutting carbs and very low carbs, and ketogenic and paleogenic diets that we are talking about, the fat diets. And as the years passed by, the recommendation moved from 14 all the way to 59, the CSIR. This saw the carbohydrate increased and the fat declined until 2004. I've kept it as a past story to talk about, and thus the history repeats. We are still talking about very low carbohydrate diet and the high fat diet. So where are we now with regards to? Now let's take the present study. I know all this platform, everybody talked about omics. Why am I bringing comics, the scenario of the slide here? This is to tell you the double burden is from the malnutrition on top left to the malnutrition of the right with the overnutrition. And you can compare then and now how the human and the environment with the science and technology of gadgets. So can you tell me what strikes you by looking at this slide here? Looking at the gadgets and the man then and now. Any wild guess from any of the students there? What it tells you? So technology was, yeah? Pardon? My question was, from the then picture of a man down to the now picture of man, what is strikingly the different? Very obvious cartoon, right? BMI. But that's all you could see, is it? So I'm trying to tell you, in then, the science and technology with the environment of gadgets which human dealt was so bulky, and the man was very thin. Now the technology has advanced and gained to, we want slim mobile phones, slim TV, the thinnest laptop, but at the cost of gaining our own weight. Since we have gained so much weight, we can't carry any further with the gadget. So the technology we have invested on to produce such instrument. That is what it is. This is a present scenario. This environment doesn't stop just with the gadgets alone, my dear. It stops with the, it takes us to the statistic. It is statistics today. The Swiggy released a survey in 2019. Probably the survey is much advanced now, it will be much more. And they claim that 95 biryanis are sold every minute. It's high time the country calls national food is biryani. And we can offer you 35,000 varieties of biryanis and combos. And the most offered Swiggy deals are chicken biryani, masala dosa, paneer butter masala, chicken fried rice, and mutton biryani. The paneer butter masala unified the India. There is no region barriers, no state barriers. Even in a South Indian wedding, even for my own son's wedding, the caterer said, how can you plan a menu for a dinner reception menu without paneer butter masala? It's such a common paneer butter masala is pervaded all over India. The unity first you see. And this not just with the food delivery system of Swiggy or Zomato. It's further aggravated with the post-COVID food marketing. It is marketing. So you call it Zomato, Swiggy, you know, and you call it Zepto, Blinkit, name it, or Amazon, Ola, whatever the delivery system, they all encourage you, be a couch potato, and you just coolly say that, oh, they tell you, don't cook, don't bother, you don't have to cook. Why do you want to use your heels to walk when we can serve you food on wheels to you at your doorstep? And they tell you now, why shopping? Pay zero for delivery fee. We look for offers. We look for deals. Zero delivery fee. But you buy one, you get free plenty of metabolic disease package. That is what is assured. And this is another food environment which is causing a much more bubble now grow bigger. Now, this metabolic disease package is what we are thinking. So in the national recent study, we went on to travel to see what is the metabolic disease prevalence or burden today in the country. That's how the evolution of ICMR in-depth study with the main objective to estimate a representative urban, rural, state and region prevalence of cardiometabolic disease burden. And this is funded by the ICMR and the Department of Health Research, Ministry of Health. This is the largest epidemiology study, a representative of diabetes in India. And it had spanned from 2008 and we recently completed last year in 2024, and it went in various phases. The first phase is 1 to 5, and Northeast is what is my next presentation about the dietary profile going to be. The phase 6 we recently completed. The data entry is still ongoing and it is still not concluded. But including the phase 6, the total sample size is 1,28,000. And the participant rate is 95% with 1,21,000. And we had a basic dietary questions in the main questionnaire, but every 5th participant were assessed for a detailed assessment using a validated food frequency, a questionnaire. This study first published Metabolic Non-Communicable Disease Health Report of India. And this study showed what is the projection, which Dr. Nikhil also showed earlier, the projection of, it's all in hundreds, millions. Okay, starting from diabetes, pre-diabetes, hypertension, generalized obesity, abdominal obesity, hypercholesteremia, all are about 100 to 350 millions of adults projected with the burden of NCDs or metabolic profile. Now, this tells us, is there something to be blamed by diet? How much of this burden is caused by the diet? Is diet what we eat today is a problem? Or can the diet, what we eat today, can be a solution as well? So this is what we went on to take up a study with the dietary component of the ICMR in-depth, and we recently asked the question whether diet is a problem or the solution, or it could be both, and for metabolic disease. So a month ago, many of you might have known that we have published the study, Dietary Profile and Associated Cardiometabolic Risk Factors from the ICMR in-depth study in Nature Medicine. And what did the study? This study findings, this part, top 3 cereal staples, which is not unknown to us. It's very well known. Any common man know, oh wow, what is a novel finding? Nothing. It only tells you that South, East and Northeast continue to eat rice as a main cereal staple. So predominantly our Indian diet today, whether you are a vegetarian or a non-vegetarian or a lacto-vegetarian or a vegan or flexitarian, whatever you call it, our plate is still the main courses from the top cereal staples. Either it is rice in this region, or in the north, it is north and central wheat, whereas the western region, which is Goa, Maharashtra and Gujarat, 3 states alone, have got a mix of all of the 3 staples, rice, wheat and millet. So you can see that even in the east and south, it's almost till 78 and 87% of people only reported rice as a main staple. There is a small drift. People started eating wheat even in the south and east somewhat. That's why it is not 100% towards that. And this tells you, the reporter, this says that diversity in the choice of cereal staples, right? But what is your unity or unity is that whether it is north or south or east or west or central or northeast, all the regions consume 2/3 of calories coming from carbohydrates. So our Indian diets, irrespective of the region or state, consume high carbohydrate diets. Now this high carbohydrate diets showed not only the inter-region and intra-regional variation, we noticed more from the sources of carbohydrate, but the total carbohydrates by and far, all regions have reported high. So as you can see, the top is a busy slide. Let me walk you through. The top orange line shows the total quantity of calories coming from carbohydrates, and the bottom blue line shows the amount of calories contributed, carbohydrate calories contributed by added sugar, and the red and green are the red is the refined cereal grains like white rice, maida, suji, rava, etc. And the green line is a milled whole grains. I stress the word milled because it is not the whole grain in the intact form. We made it into flour like wheat flour or the millet flour based items have been consumed. As you can see grossly, the ever changing, the left top is all the regions and each compartment within each region, the states. So northern states in the region, southern states and the eastern, western, central and the northeast. So the more changing is the red and green. So the states which consume higher amount of refined cereals consume lesser amount of whole wheat flour based item, and the vice versa, and that's what you see. And the blue line is also least varying, indicating the calories contributed from added sugar is almost uniform across regions and all states, so indicating more states consume similar added sugar. And that's why we have written the carbohydrate is red marked is all about 60%. And so the uniqueness in that, what is unity and diversity? Diversity, if you, for the want of states very detailed, so we have summarized here that only 3 states in the whole country where more than 30% population reported consuming millets. And that too, the calories coming from such millets were 10% or less than 10%. Karnataka, almost 48% of adults in Karnataka reported finger millet or ragi and the jowar or sorghum. And Gujarat and Maharashtra, only 35% of the population reported. That too, the calorie contribution coming from millet is only that a little. And what is unity? As you have seen the blue line in the previous slide, all the states, almost 21 states, reported greater than 5% of calories coming from added sugar, which is a national recommendation not to exceed beyond 5%, to keep it less than 5%. Because added sugar has got no nutritional value, it only adds empty calories to make a person put on excess calorie and obesity. So except these states, so in North, Chandigarh consumed less than 5% added sugar, a healthier intake, and South Tamil Nadu and Northeast, all states except Meghalaya consumed greater than, less than 5% calories from sugar. Similarly, the fat story, inter and intra region, there is the top orange line tells you the total fat. Almost all of them were within the 30% of national recommended intake of 30% calorie, the top line. And all the rest color, the red is for the types of fat, which is saturated fat, and the green is the healthy monounsaturated fat, and the blue is the PUFA. So all of them merge. But what is interestingly, the unhealthy pattern we saw is the saturated fat was the predominant fat of the total fat, and that was much higher than the recommended intake to cut cardiometabolic risk of 7%. So almost all the regions have reported greater than 7% of saturated fat, and monounsaturated fat is overall, it is low in the all the regions. So uniqueness, the saturated fat is first the very unhealthy, united all states and regions reported greater than 7% of energy coming from saturated fat. Moving on to the protein, again the total protein very uniform across, except the Northeast, you see some surge in 2 states, particularly Nagaland and Mizoram. So you'll find otherwise the national average is 12%, and all the state regions are within the 12%, except Northeast is 13.6% of calories coming from protein. Of the total protein, the main share of protein comes from plant protein, and interestingly, the animal protein is the least in northern state and highest in the Northeast in the bottom row, and whereas the plant protein is the least in the Northeast, is the opposite. And dairy protein, as we know that North consumes more dairy protein and the Northeast consume less dairy protein. This is with the quality and the quantity of protein it tells you. And now the uniqueness, so Nagaland and Mizoram had the really highest 2 states in the country had reported high protein, and major source is the plant protein, and central zone has reported higher plant protein than the national average. And of the dairy protein, Delhi, Haryana and Gujarat reported higher protein from dairy of all the states in the country. Now this takes us, you might wonder, so from this we know that there is some unity with the high carbohydrate uniform, saturated fat across uniform, low protein across, and we might wonder, but still the traditional belief, we say that, oh, cooking practices, culinary practices vary from region to region, and how can you say that inter-region, there are unity, and then still we see that regional differentiation. So we went on to examine, is it true that rice eating versus wheat eating, it's a very strongly held belief, those who eat rice are more prone to diabetes than those who eat wheat. So we went on to see the region-wise how these carbohydrate and its sources confer risk to diabetes and pre-diabetes. So we did a pooled regional meta-analysis kind to see the heterogeneity between regions. So as you can see that this beautiful unity in diversity, all the regions for the carbohydrate percentage calorie on top, then the refined cereals with grams, energy adjusted, and whole grains and added sugar. Each region contributed similar risk. Hence, in each class, the heterogeneity measured by I-square values were very, very low, suggesting that between regions, there is no variation with regards to whether they eat rice or chapatis or whatever the millet. The risk is very similar. This prompted us to move on from pre-diabetes, also the similar story. Hence, we thought there's no point in showing a regional variation. We pulled all the region and showed what could be the cutoff point to reduce the risk.
Dr. Vasudevan, can you summarize, please?
Yeah. So this we said that this newly diagnosed diabetes and pre-diabetes, obesity, abdominal, all of them compared to the lowest tertile, highest tertile has got very high calorie. So less than 100 grams is the refined cereals, definitely is healthier. Similarly, with the white rice as well, we shown that people thought that white rice is more risk than the milled whole grain of wheat flour or millet, both showing a similar risk in this slide. And now you may wonder, so can I swap instead of rice, shall I move to millet or chapati? If the question, the answer is no, no benefit, as long as you do not cut the total quantity of carbohydrate. As you can see, 50 gram of cereals refined with the 50 gram is roughly a 2 full cars or 2 chapatis. And if you replace rice with all of this, doesn't offer any benefit as long as the total quantity. So what is the solution now? Solution is we are going to show how to cut carbs to reduce with the substitution analysis. In this forest plot, towards the left side, as you see, it's all a protective, more towards the right is a risk. So we showed that the total protein is definitely protective, not the total fat, both for type 2 diabetes and for pre-diabetes 2 compartment. And of the protein, definitely pulses legume protein, dairy protein, fermented and non-fermented, and not the animal protein, not the red meat, not the poultry, but the egg and fish in the animal protein showed protective. And fats did not confer any benefit at all. Hence, the very low carbohydrate and high fat is meaningless for us to reduce a cardiometabolic risk. Now, what is the optimal? Then what do we suggest? How do we way forward to take it forward? The solution is we did a mathematical optimization model at population level, and we offered the cutoffs how to prevent for a newly diagnosed diabetic person to go on remission, or pre-diabetes to prevent the progression to type 2 diabetes, or at a normal glucose level person, how to prevent it. So this is the cutoff values. Again, cut carbs from current 60 to 49 to 54, not drastically to 10% carb or 15% carb, and protein to double up to 19 to 20%. You don't have to change the fat. Of course, the fiber needs to go up. Will definitely help at the population level to show remission of diabetes. And for people with pre-diabetes, the plate similar carbs and protein, and those with normal glucose tolerance. And the policy implication from this solution, we need to suggest to require, need to subsidize PDF on pulses and legumes more, cut the subsidy on refined cereals like white rice, and healthier fat oils to be subsidized in the PDS. And it is, of course, a state government matter. These findings will be helpful for them to plan better PDS. My conclusion, nationwide, high carb, high added sugar, low protein, unhealthy, saturated fat is a predominant fat we are consuming, though the total fat is within the recommended, and it's time that replacing little 5% carbs, very culturally still sustainable diet, to replace with either egg, dairy, plant, fish protein definitely offers you the leg. So what is the way forward future? We need to whack ourselves. What I meant, whack, W is eat whole grains as whole, and help with more plant protein, especially from pulses and legumes, add no sugar, count your portion size, and substitute carb foods for protein foods, but not fat, and you will definitely kickstart a new life. Thank you very much. Without the support of my team and the senior advisor, Dr. Kamala Krishna Swami and Dr. Ganesh Jivan from CSIR, former technical officer, CLRA, and ICMRNA, my team and food analysis team, and the management support, I would not have been here to present all this to you. Thank you all.
Thank you, Dr. Vasudevan, for excellent talk in the area of dietary factor associated with metabolic risk and diabetes. And also congratulations to your team having papers in Nature Medicine, which is a very high impact journals. One or two questions. Any questions from audience?
Madam, wonderful presentation. I have an inquiry, ma'am. This maize roti or wheat roti, which is good for diabetes?
Maize roti, makki roti,
Maccaria.
and what is the other one?
Wheat roti.
Wheat roti.
Yeah.
So in fact, wheat roti gave much lower in terms of glycemic index. Why that, for want of time, I didn't speak. Why the milled whole grains behave very similar to refined cereal like white rice, because we make it into roti. We don't consume it like a dalia or broken wheat of anything. So whether you take makki roti, which is much finer than the roti. So wheat roti gives a more like a little lower glycemic than makki roti. By and large, all these rotis, either from millets or makki or wheat, as a roti, it all adds more glycemic load and the risk conferring, very similar to white rice.
Okay, thank you.
Thank you again, Dr. Vasudevan. Because of shortage of time, we will end it. And if any question, we can discuss during tea time.
Thank you very much, sir.
Thank you.
Thank you.
So the next talk is by Dr. Jimon. He is a faculty at the Sri Chitra Institute, and he'll be talking about epidemiology of heart failure in India. Dr. Jimon, please.
Morning. It's indeed a great privilege to be part of this initiative, and thank you organizers for inviting me to be part of this program.
Dr. Jimon, can we request 15 minutes for the talk so that we can take some questions also?
Sure, sir. So in the next 12 minutes, 13 minutes, I would briefly take you through the profile of heart failure in India based on multiple studies that we have conducted in various parts of India. Sorry. So before I move on to heart failure, let me briefly explain for the general audience what is heart failure. The normal heart pumps the blood to different parts of our body. And when we have heart failure, the heart has difficulty in pumping adequate amount of blood to different parts of the body. And based on the blood in the ventricle and how much it's been pumped out, we call it as ejection fraction. And based on, there are different types of heart failure. The heart failure with LV ejection fraction less than 40, severe reduced ejection fraction, we call it as, and there is mid-range or the moderate range ejection fraction, and there is another entity called preserved ejection fraction, where the ejection fraction is normal, but the patients will have all the symptoms of heart failure. So we started our humble approach with a heart failure registry in Kerala, in a district in Kerala, Trivandrum district. The speciality of this heart failure registry was that it was a purely population-based registry covering all heart failure admissions in a particular year 10 years ago in Trivandrum city. So which covered almost what kind of heart failure that we get at least in a city like Trivandrum, not in city, in the entire Trivandrum district in Kerala. We didn't stop there with further commitment, further funding from Indian Council of Medical Research. We went on and did a national heart failure registry covering 53 centers across India and in almost all the states in India. In addition to that, we did another registry in Kerala covering the entire Kerala region, again across 56 centers across Kerala, covering about 7,500 heart failure patients. We had another registry from our own hospital, the Sri Chitra Tirunal Institute of Medical Sciences and Technology, which is a specialized center for heart disease and neurological conditions. So we had the opportunity to look at our patients which have been followed up for a longer period of time within our hospital settings. Then there are multiple other registries across heart failure registries in India. So we thought that we would probably pool the data together and present you some of the characteristics of heart failure across India. So the National Heart Failure Registry, as I said, it's 54 centers across 21 states and 4 union territories. So what are the common findings? Now, we compiled, pooled the data from multiple other registries, including our own registries and ongoing clinical trials in heart failure. And we looked at, we did a quick IPD meta-analysis. And if you look at the average age of the patients, heart failure patients in India, it is 60 years. We have seen the same thing for the diabetes as well as for other cardiovascular disease conditions. These conditions get to Indians at least a decade earlier than their counterparts in the Western population. If you go to the proportion of men with a heart failure, it's predominantly men. More than two-thirds of them is men across multiple registries in India. If you look at the different types of heart failure with reduced ejection fraction, it's 65% of heart failure in India is heart failure with reduced ejection fraction. This is much more than the heart failure proportion with reduced ejection fraction from the Western settings. If you look at the Western settings, we see predominantly more heart failure with preserved ejection fraction, whereas in our settings, it's predominantly more reduced ejection fraction. Probably we are not detecting enough number of heart failure with preserved ejection fraction in our settings. So the preserved ejection fraction is only less than one of 6 heart failure patients in the Indian heart. In India is preserved ejection fraction. If you look at the predominant etiology of heart failure, ischemic heart disease is the predominant etiology of heart failure. More than 2/3 of heart failure in India is due to ischemic heart disease. Ischemic heart disease is predominantly heart failure developing after a heart attack. The dilated cardiomyopathy is again approximately 15%. 1 of 6 heart failure patients in India is from dilated cardiomyopathy. People earlier thought that rheumatic heart disease is contributing much to heart failure, but when we looked at the data, yes, rheumatic heart disease is still a contributor to heart failure. But then if you look at the proportions, it varies from disease registry to registries, and there's huge heterogeneity across the disease registries. But most of the studies, especially the one that we did in Kerala, where we did a population-based registry, and when we looked at the data, even in Kerala, approximately 9% of heart failure is from rheumatic heart disease. So still we are facing the double burden of both the infectious disease and chronic non-communicable diseases, and rheumatic heart disease leading to a major contributor to heart failure even in some parts of India. HCM is relatively very small in our Indian context. So when we look at other comorbidities, heart failure is a multi-morbid condition. People have multiple other comorbidities along with heart failure. It's more of a syndrome than a disease entity. So if you look at heart failure, most of them will have one or the other comorbidities. So chronic kidney disease, if you look at approximately 12%, probably this is an underestimate, because when we look at chronic kidney diseases, all those EGFR below 60 or 30, probably we are not detecting in our registries, because everyone will not report the EGFR values. But still then, if you look at it, it's approximately 12 to 15% across multiple registries in India. Another major comorbidity is stroke. It is approximately 5% of the population across multiple registries will have stroke as a comorbidity in heart failure. If you look at chronic obstructive pulmonary disease, it's much more, approximately 10%, because chronic obstructive pulmonary disease also would lead to heart failure, and that is why we see it in approximately 10% of the population. Hypertension, diabetes is predominantly common in all heart failure patients. In the registries across India, it is approximately 50% for hypertension, and for diabetes is approximately 60%. If you look at the foundational therapies, there are 4 foundational therapies all heart failure patients should ideally receive, but unfortunately in our settings, our patients are not receiving the 4 foundational therapies. So I'm looking at disaggregate the individual component of the 4 foundational therapies. If you look at the use of beta blocker, ideally it should have been more than 90%, but unfortunately it's only 57% receiving beta blockers. If you look at combination of ACE inhibitors and ARBs, it is approximately 35%. If you add on ARNIs on top of the ARBs and ACEs, it would only reach up to 40%. So the foundational therapies, the use or the prescription is suboptimal in the Indian patients. If you look at MRA usage, it's only 52% across multiple registries, and the new addition, the SGLT2 inhibitors, it's relatively, it's less than 10%, because it's, it was costly earlier, but it's relatively cheap. But then, even then, the number of people receiving these drugs and adhering to these drugs is relatively very low in the Indian settings. Oh my God. So from our registries, the Trivandrum heart failure registries, we have a long-term follow-up. We started 10 years ago. So we have published multiple papers from this registry, looking at mortality outcomes, looking at hospitalization outcomes. So we also looked at multiple other registries and looked at the mortality. So the mortality in heart failure is very high. If you look at the in-hospital mortality, it is approximately 8%, 6 to 8% across multiple registries. 90-day mortality, it is 12 to 18%. 1-year mortality, 31%, 1/3. In the National Heart Failure Registry, it is 22%. And then moving on to the 10-year mortality, it is approximately 83%. It's almost all heart failure patients die within the next 10-year period. The median survival time for heart failure in India is only 3 years. And it is much more even severe than some of the common forms of cancers in our country. So if you look at the mortality, the advantage of having longitudinal data, the follow-up data is that you could potentially look at what are the factors that are leading to mortality. So we looked at the guideline-directed medical therapy use, whether the patients are receiving the drugs according to the guideline, and if they are receiving and if they're not receiving, whether that makes any difference to their outcomes in terms of hard endpoints, the mortality outcomes. Whether you look at the in-hospital mortality, whether you look at 90-day mortality, whether you look at 5-year mortality, whether you look at 10-year mortality, the foundational therapies, the guideline-directed medical therapies have a significant impact. If they are receiving, they live longer in our cohort. We also looked at the etiology of heart failure and whether that has an impact on outcomes in terms of mortality and the hospitalization outcomes. And we see that there is differences between different types of etiology, and the common form of heart failure, the heart failure etiology, especially the ischemic heart failure etiology, that is where the mortality is relatively lower. So what we get from these registries is that heart failure is a very severe multimorbid condition, and the annual incidence in our population, based on the estimates from the Trivandrum Heart Failure Registry, is approximately 1.4 million. What does it mean? There is one case in every 23 seconds in India. And the average age is approximately 60 years, 1 decade earlier than the Western population. Suboptimal treatment, a large number of our patients are not receiving the guideline-directed medical therapies, whereas we clearly know that if we prescribe these therapies and if patients are adherent to these therapies, on an average, we can improve their survival by at least 7 to 8 years. The median survival time in the Indian population is only 3 years. And at the same time, we know that there are scarce resources in terms of managing heart failure. And if you are depending on the physicians to manage heart failure in a better way, we do not have that kind of capacity across India. And therefore, the solutions that we proposed was, thinking about task sharing, enabling other healthcare professionals to manage heart failure, and where we thought about engaging nurses in terms of managing heart failure with the aid of technology, mobile phone technology. And this study that we proposed, the collaborative care model with support from the DBT Wellcome Trust India Alliance, we are looking at whether a collaborative care model coordinated by nurses with the help of an mHealth application, would that make any difference to the prescription of guideline medical therapy? Would that make any difference to the patient outcomes in terms of hospitalization and in terms of the mortality outcomes? So we are looking at the moment, assessing the effectiveness of this collaborative care model. Our outcome is days alive and out of hospital. It is a combination. It's a combination of both mortality. It's a composite outcome of both mortality and hospitalization together. So we are looking at the effect of this the model on hard outcomes. It is happening across 22 centers in India. It's a cluster randomized control trial, 70 patients each in all the selected clusters, 1:1 allocation to the intervention and the control arm. In the intervention arm, they will receive the coordinated care, the collaborative care model facilitated by the nurse with the aid of the mobile phone technology. So our initial results say that even at the time of the discharge of heart failure, with the involvement of nurses, with the involvement of technology, what is happening is that on an average, there is 10 to 12% improvement in the uptake of guideline-directed medical therapy. And as I said before, if you do that on an average, at least in these patients, you would be able to extend the lifespan or the life expectancy of these patients at least by 7 to 8 years. We are also doing multiple other trials at this point in time, 2x2 factorial trial, where we are looking at physical activity-based rehabilitation, whether that would improve the heart failure outcomes, along with cognitive behavioral therapy for patients with heart failure and other multimorbid conditions, especially depression and anxiety. And this trial is also going on in multiple sites, and we have almost completed the trial. That outcome data getting finalized, and the results would get in the next 2 to 3 months. We have been also funded by the National Institute of Healthcare Research to conduct the heart failure rehabilitation in homes across India in multiple sites, and see whether remote heart failure rehabilitation, whether that would have an effect on improving the mortality outcomes. We also have a heart failure biobank within our institute. We have approximately 4,700 patient samples available in multiple forms. And now this heart failure biobank is open to multiple researchers across India through ICMR. With the support of the ICMR, we have communicated to almost all the researchers who are working in the area of heart failure or working in the area of cardiovascular disease conditions. So if you would be interested in collaborating with us, reach out to us. We are happy to share our resources in terms of whatever the samples that we have stored in our biobank. We have the annotated clinical data for all these patients, well documented, well phenotyped in our database. At the same time,
can you summarize, please?
Yeah, the last slide. So we are, just to give you an idea about the kind of studies that we do based on the biobank. At the moment, multiple studies are ongoing. These are some of the studies that we have either currently conducting or proposed to different funding agencies. With collaboration with multiple other agencies, we are looking at multiple studies, including genetic studies, including multi-omic studies, including epigenetic studies. to look at the impact of heart failure, the etiology of heart failure, the pathophysiology of heart failure, the outcomes of heart failure in India. So this is our team. It's not possible without collaboration across multiple hospitals, multiple institutions. We thank them for all their support. And we have been also designated as an ICMR Collaborating Center for Excellence in Heart Failure. Thank you very much.
So, Dr. Jimon, one question. What is the timeline in improvement of outcomes? Because you have data from quite a few years. So has the outcome of heart failure improved over the past few years and the medication adherence, or has it been the same?
That's a very good question, sir. I think when we looked at the Trivandrum Heart Failure Registry that we set up 10 years ago, the guideline-directed medical therapy uptake was only 20% at that point in time. 8 years after that, when we did the National Heart Failure Registry across multiple centers in India, it improved to 40%. But there is a difference. The National Heart Failure Registries most of them are teaching hospitals, tertiary care centers, and where we expect that the prescription of guideline-directed medical therapy is relatively on the higher side. But whereas the Trivandrum Heart Failure Registry was purely a community-based population registry, so there are even cases not managed by cardiologists in that registry. But on an average, yes, it is improving, but the improvement is still, it's not optimal. We have a long way to go in terms of providing optimal guideline-directed medical therapy to the patients. The mortality outcomes across multiple registries, again, the mortality rates are coming down, but it's not as comparable to the mortality rates that we normally see in the Western population. So again, still a long way for us to go.
So can we have any questions from the audience, please? Okay, if there are no questions, we'll close the session. Is there a question?
Yeah, so fantastic talk, Dr. Van. So I was just wondering, is there any age stratification of your data? So what is the age of incidence, whether there is an evolution nationally in terms of age of incidence of heart failure, and based on age of incidence, whether outcome varies?
Yes, I mean, age is an important predictor of mortality, whether you look at heart failure or any other conditions. We have now access to approximately 35,000 individuals with heart failure in our database, not only our own registries, but across multiple other registries where they are willing to share the data with us. But what we see generally in heart failure is that since it's a multimorbid conditions with high morbidity and high mortality associated with it, on an average, there isn't much difference between different age groups. It's almost the same, except for certain particular etiologies which are not that prevalent or common in our country.
And you don't see any evolution in terms of age of incidence?
Say it again.
Over last 10 years, do you see any evolution? Are younger people?
So yeah, relatively more younger people getting into heart failure, that's common, that we see over a period of time. But we can't say that that's generally a trend because these are registries set up in particular institutions. They are not really population based.
So thank you. We'll close the session now. There's no industry talk now. And we invite all of you for a cup of tea.
We thanks all the speakers, including Dr. Tendon, Dr. Yasnik, Dr. Vasudevan, and Dr. Jimon for excellent talk and discussion. Thank you, all of you. Now we will have a tea break outside, followed by photography session.
Yeah, so please finish your tea early and 15 minutes. Let's take 15 minutes for it. नहीं वो बहुत लोग बाहर है अभी चाय पी के फिर आके लेते हैं नेक्स्ट सेशन चालू करने के पहले सब बाहर है आप आएंगे
आपसे मिलने के लिए दिल्ली से बाहर ही आना पड़ता है, बस पूरा तो टाइम नहीं मिलता है, बैठते रहे तो हम 42 दिन दिल्ली से बाहर रहते हैं। हेलो 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 हेलो
मॉनिटर दिल्ली
हेलो हेलो हेलो
Yeah, everyone, please come forward. All delegates, students.
दर्शन was good. मनोज तो अपना सामान लिया
मैं तो मुझे हटना पड़ेगा, देखिए ढक जाएगा।
यहाँ पे जमा
उठा के कंप्लेन करिए ना आउट से।
All are requested to please be seated. We are conducting next session. Hello. Please be seated. फोटो और भी उठा रहा है, ओनली फोटो. बालाजी.
This is a small request for all the women participants who are present here. If possible, come on to the dais for a group photo.
Actually, there are more. This is for just for photograph. You can attend.
So here people will be there or during this time also before lunch and break. Huh? All are requested to please be seated. We will be conducting technical session 6. Please. So, good afternoon. So, this session contains one panel discussion and 4 talks. I request if Dr. Siva Subramaniam Ramkrishnan is present, he has to upload the slides here. And industry talk for SciX. Anybody from the SciX? He has to also upload. So it will be conducted. The session chair is Dr. Diptiman Ganguly and the moderator is Dr. Kumardip Chaudhary. I request them onto the dais, please. Dr. Dipyoman Ganguly and Kumardip Chaudhary. I request committee members to honor the guest with the flower bouquet. Hello. So, to introducing Professor Dipyan Ganguly, he is a physician scientist working on human immunology, currently a professor in the Department of Biology at Ashoka University. He did MBBS from the Medical College, Kolkata, India, and PhD in Biotechnology from Indian Institute of Chemical Biology, Kolkata, India. Another PhD in Immunology from UT MD Anderson Cancer Center, Houston, USA. After his postdoctoral research in the Columbia University, New York City, USA, Professor Ganguly came back to India in 2000. Professor Ganguly is a recipient of many awards, Narcis Coppo's Young Scientist Award. To mention a few, Santi Swarup Bhatnagar Prize also he has received from the CSIR. He has elected Fellow of Indian IAS, National Academy of Medical Science India, and Royal Society of Biology UK. So our moderator is Dr. Kumardeep Chaudhary. He is also he is a principal scientist in CSIR-IGIB. He is a computational biologist working at the intersection of the artificial intelligence and human genomics to advance precision healthcare. I invite both of them to coordinate this session. Thank you.
Thank you. Good afternoon, everyone. So we are about to start with the panel discussion, and in the panel we have the 6 esteemed, distinguished leaders in their respective fields who have been working in their respective domains where large amount of data is being generated throughout multiple years, across the years, and we're gonna hear their views on data sharing and the ethics. So first of all, I would like to invite Dr. Sandeep Seth. Dr. Seth is the distinguished professor of cardiology at AIIMS Delhi, and he was one of the member of the chairs in the last session. We have seen him. So welcome Dr. Seth to the stage. And next panelist is Dr. Sanghamitra Bandyopadhyay. Dr. Bandyopadhyay is the director of Indian Statistical Institute, Kolkata, and she has a lot of awards, prizes, and achievements, established achievements, including the Infosys Prize, Bhatnagar Prize, as well as the Padam Shri, the coveted prize, civilian award. Next panelist is Dr. Sanjay Juvekar. Dr. Juvekar is consultant at KEM Hospital and Research Center, Pune, and he has been pivotal in the Vadu Rural Health Program. Welcome Dr. Juvekar on the stage. We have Dr. Karthikeyan, the Executive Director of BRIC THSTI. Dr. Karthikeyan is also working as a clinical cardiologist and professor of cardiology at AIIMS Delhi. And he has been member of many regulatory and other committees involving the data sharing and the ethics. Next member is Dr. Shouvik Mathi. Dr. Mathi is the director of CSIR-IGIB New Delhi. And he has been doing the pioneering research in nucleic acid biophysics, and his recent co-invented product, Feluda, has been commercialized through in the time of the COVID pandemic. And the last name in the panelist is Dr. Shalimar. He is the leading figure in the hepatology, gastroenterology, at working at AIIMS New Delhi, and his areas of interest are acute liver failure, liver transplantation, metabolic associated liver disease, earlier known as NAFLD. Now there are different acronyms for that, and hepatocellular carcinoma. Thank you, everyone, and it's a privilege to listen to your views. And now I hand it over to Dr. Deepaman for the subsequent discussion points.
Hi, very good afternoon. So I really thank Cohort Connect, Dr. Shouvik Mathi, Dr. Ramanuj, and this has been a fantastic experience to see a cohort which was a dream for almost 5 years for a lot of us in CSIR has reached this day where we are trying to plan the future. So while planning the future, we are going to discuss about data sharing and ethical landscape in cohort studies, not inclusive of only the CSIR cohort, but all the cohort studies that we have been talking about over past 2 days. So what we have planned that we have a few questions, and so we will start with a lead discussion on those questions, and then we will ask other panelists also give their inputs. And let us start with the first question. So a major, so the first thing that we think of any population cohort, for that matter, any clinical studies, is informed consent. Now, when you are dealing with a cohort study, the population becomes too diverse, and the understandability or the information gathering of these subjects may differ greatly. So, how do you think that a really inclusive informed consent can be designed for population cohorts? I would start with Dr. Sanjay Jivekar, and then other panelists can actually come in.
Yeah, thank you, Anjan. This is great. You started with me, an anthropologist working with the cohorts, but more than cohorts, a surveillance system, which is a panel design. And we work in practically, as you said, very diverse population. And the first thing we need to really keep in mind is the truthfulness. What happens is cohorts take long time to get the results. And if you start with that, okay, this will be useful to you, to your community or something, it is going to be a failure. So the most important thing is truthfulness. Tell the population very truthfully in the consent, as well as when you have your meetings. So the community advisory board plays an extremely important role, and it has been helping all the demographic surveillance sites across the world. Wherever there are good community advisory boards actively involved in the research, it helps. So even before your consenting starts, your preparations are important. So that's what I think there are a lot of panelists, so I'll just say this thing: truthfulness. Tell truthfully what and how much of time it will be there, especially that suppose it's a cohort of say 20 years, 30 years follow-up, you have to tell what will it achieve and when will it achieve. So that those things are very important. I will stop here. Thank you.
So another question is maybe some other panelists can take up, as Professor Tandon was talking about diversification of the cohort's goals as the cohort matures. So then again, this problem of informed consent and how those diversifications can be brought in the consent procedure.
I didn't get your question. So
the cohort studies need to be diversified in terms of its goal. When for some year you have actually run one cohort, and then this, so your informed consent to start with should actually include such possibilities that goal can be diversified later on.
Actually, there's no problem as such. If your informed consent is good enough and to explain all the population across, because languages is always a challenge, because you may have your staff who goes on the field with a specific expertise in language, and you may have people who are from different variety. But then you need to balance your team in such a manner. For example, there are areas, especially all those cohorts which are closer to the urban areas, very fast urbanizing villages will have people from all over the country migrated there, and you need consent from all. So you can't have consent forms in Malayalam, Tamil, Bihar, but you need to have. If you are going to have that, if you know that there are communities, because what happens is, especially if there are families moving and only the one of the spouses is working, so that spouse may be well versed with say Hindi or English, but the other family members who are equally important, for example, if you're conducting studies around adolescent girls, and then you need to speak to them. So you need to have your consent in all the languages that your study population of the cohort speaks. That's mandatory. Thank you.
So yeah, please, Dr. Karthik.
It's working actually when we speak. No, it works. Yeah.
No, it's working. No, so I think what you meant was when the objectives of the cohort change, right? So I think, see, like any research which has a long-term time window, it is all based on the altruism of the participants. So we have to make it very clear that they are really not going to be the beneficiaries of whatever research that we are doing. So it has to be very clear that this is a contribution that they are making for a public good. So, I mean, talking to the point of transparency in the beginning, I think this is what needs to be emphasized when you're enrolling people in a cohort. So you have to make it clear that this is their altruism which is leading them to participate. They are unlikely to benefit other than in minor ways, getting a report or something like that. But otherwise, the outcomes are going to be a very long-term thing, and they are unlikely to benefit from this, but future generations may benefit from this. So I think that is the way to put it. In that sense, if your objectives change and you don't have to make more additional measurements, then it doesn't really matter, as long as you've said this in the beginning.
And there comes the role of truthfulness. That's, yeah, Professor Bandhavat.
Yeah, so I absolutely agree. It has to be a truthful, truthful communication of the goals of what will be required, the timeline that the research group is looking at. At the same time, if it is just that somebody else will benefit, then it is human nature, unlikely that I'll give my data if it doesn't benefit me. So I have to be told also how I will, or the community will get benefited. It with a pinch of salt, that also should be transparently communicated, that this is the benefit that we expect will accrue to you. That it will necessarily come, that should not be promised. But if it is just somebody else's good and I am the guinea pig there, I would not really want to take that extra effort. And also the diversity of the country, of our country, poses a grand challenge for communicating what is being done, what is envisaged, and to get the informed consent, to be sure that the person, the subject, has understood. Very often, for example, the women will not be allowed to talk in many communities, in many social groups. So how to reach out to them? These questions have to be actually answered or posed and answered well before even you start designing the consent form, because there will be social taboos that have to be taken care of. For example, in many strata of the society, after delivery, the mother will not be accessible. So how to actually get data from there? What to do? Those have to be planned well in advance, and the research group itself has to be very diverse, so as to be able to reach out to talking to the communities that we want to target is absolutely important well before we've even designed the consent form, or we are thinking, because otherwise we will think that this is very natural for a person to respond to. Well, when we go into the field, we will realize that no, it was not natural. There were certain things we have not factored in. So those things have to be thought through well in advance. And indeed, it has to be absolutely transparent and truthful, but also the benefit that will accrue to the community has to also be communicated, and films, awareness, cartoons, for example, the presentation we had with those cartoons, I mean, those communicate the message at the same time, very interesting also, and easy to understand. So that is what, and I think AI, artificial intelligence, is going to play a major role because of the diversity of the language, the diversity of the same response meaning different things, coming from different sets of people. So there, and also sometimes it happens that the field workers actually don't go to the field and put in the data. So that also has to be accounted for, data quality, etc. And there, AI is already playing a major role and is expected to play a further important role there, especially because of the language differences.
Just to add on to this only, two things are there. One is that whenever you take a consent, you give the patient a patient information sheet. So it is mandatory that you have to have it in multiple languages, which the patient understands. And second thing is, you're right that if the patient is told 20, 30 years ago later, someone will benefit, but we'll take your sample, we'll take out 20 ml of your blood, and normally you take 5 ml out only. He'll say nothing doing, I will not. So actually the benefits are there. Benefits need not be written. The patient, for instance, for a hospital, the patient is better connected to the hospital through the person who's taking the consent. So they get to know the pathway, and their pathway is easier than the rest of the patients. So just that itself is an indirect benefit. Plus, because they're being seen repeatedly on a regular basis, they're phoned and called again and again and again, their care indirectly will be somewhat better as compared to someone who's seen once in 2 years, once in 3 years. So these are indirect benefits which you tell the patient, that you are better connected. And you would, when you take out 15 ml, you would often send out 3 ml for your routine labs also. 15 ml, you don't know what happens. But 3 ml, which you send to your lab, will pick up things. So these are indirect benefits which the patient gets automatically. And these have to be outlined. Plus the last thing was that when you take a consent, the consent should include for the current study with these objectives, and in the future, we might work on other questions, and you have to give consent for that also. That is necessary because suppose you talk of cohort versus merging cohorts, then your objective has changed. So that kind of thing should be there.
Okay, and so kind of just to wrap up, so it's transparency and being open to social realities and keeping them in mind while designing all the consents, and of course motivating subjects for more emotional investment into the cohort so that the stakeholders are also involved through multiple interactions across. So maybe we can move to the next point. Now this is again a very important consideration for any cohort studies. What are the security safeguards and data governance landscape, and which should be really suitable for a country like India, where we are not known to be fantastically organized in terms of instituting all these governance models. And so maybe I can request Professor Sandeep Sheth.
So I'll just give an example. I have been organizing for the past few years a thoracic organ transplant registry. So that involves about 80 centers. That means 80 teams of surgeons, physicians, intensivists who have to contribute data. So when we started with a simple thing. Initially, it was not very data compliant or anything, but each center was listed, and we said, just give us one number. How many transplants have you done in the last 1 year? Out of 80 centers, only 15, 20 were contributing. And there was no other data asked. You just asked a single number, nothing about patients, no other details. It's totally anonymous. What is not anonymous is the hospital name. When I didn't get answers, I asked them why. What was not said was that, look, if I give my data, Apollo data versus KIMS data versus this, look, that center will use my data to say, look, we do more transplants. So then the only thing which worked was my assurance that this data will not even be shared amongst various hospitals. This data will only be published as single merge India data. So that was a simple thing, but that was on my verbal assurance. Then last year to this year, we have moved on to an agreement to share data on an international forum. So and their condition was one, your data will not be given by individual hospitals, it has to be given by data management company. Then we started understanding the rules of anonymity, rules of security. So they started managing the data. Each hospital could access only their own data. That means that data, for instance, for AIIMS, I can access my patient's name and everything. No one else could access it. When we would get data from that data management company, it would be anonymized data. So we're getting hospital number 123, 124. So even if I'm trying to look at the clarity of the data, I also get hospital 1, 2, 3, 4, 5, number of transplants done. No patient name is there. Patient ID is there. That was the first level where we learned that there's something called data security. And we had, of course, first checked that the company itself is data safety compliant. So HIPAA compliant and other compliance was checked by us. That was the first step of learning. Then when we had to transmit the data to an international registry, they were even more stricter. They said, first you need each hospital to say they are willing to give this data to an international registry willingly, and then we had to have some kind of ethics clearance. So we got an ethics clearance from one ethics committee for 80 centers. And then the next thing was that when you send us the data, you will re-anonymize the data. So that ultimately, even the hospital or the data company cannot see the data. So multiple levels of anonymization took place and took place and took place. And then they recoded the hospitals also. So ultimately what reached the international registry was just India data. Even they could not identify which hospital was sending, and they can only publish it as India data, not even North-South India data, just pure India data. So that's where we learned these levels of security and the kind of safety measures which are taken. Besides the fact, of course, hardware has to be kept safe. You have to have multiple backups, even hard copy backups, because any kind of thing can happen. So this is a practical example of how we learn various levels of data safety.
The concerns are even higher when you are actually dealing with genetic data, right? And so that...
Yeah, the consent has to include genetic data, because in the future you might want to do. That becomes even more difficult, because then ICMR, HMSC guidelines also come in, and they are even stricter.
Anyone else want to give some inputs?
So, I mean, that was a very, very interesting example that Dr. Shet gave about the companies now getting to know how many operations are done there or whatever. One thing is that also the level of data security is not uniform. The amount of security that you need for the data, that also has to be categorized into data which can be public, data which, of course, anonymized. I'm always saying anonymized, as he correctly pointed out, double and multiple levels of anonymization, which, as was mentioned by Shantanu yesterday, already in Bharat Biobank, I think, there, that level of, in this cohort, the Phenom India cohort, the multiple levels of anonymization, that has to be there so that the company, because company would know what I've given, it should not be able to recreate and get information of what is happening. So multiple levels of anonymization, security, all the security aspects, storage security, etc., network security, data has to be secure at rest and also while in transit. Strong multiple levels of encryption. Encryption technology has to be used. There are very good ciphers which have to be used so that nobody can break that data. And these days the ciphers are really, really very strong. But what will happen when quantum computers come in? That's a separate thing, because that is going to break all ciphers that exist as of now. And therefore, post-quantum cryptography is now a very important area of research. The other thing is also access control. Who will get access of what amount of data, to what level? So these things are very important. And also when it comes to international data sharing, things become much, much more complicated, because one has to adhere to the rules of individual countries and all these things. So there is another thing that I wanted to say is, usually it is said collect only that much information that is required. Okay, so minimal information collection. But then it also restricts. You cannot later on add newer questions. So that trade-off between how much data you would like to collect, given your current set of questions, whether it will be minimalistic data collection or a little more comprehensive, that is a trade-off which I think I don't have an answer to right away, but that is something which has to be thought through.
That depends on individual cohorts and objectives.
Yes, yes. The objectives changing over time. Yeah.
Yeah, Rakesh.
I think with the discussion, what we're looking at, it looks like it's very complicated to share data. I've been part of multiple IPMAs. IPMAs is an individual patient data meta-analysis where you share your data. So it's like I have shared my data to multiple international cohorts, whether it's being the Europeans or the Americans. Plus, we've recently done an IPMA where we had asked multiple European countries to contribute. So it's not that difficult. It all depends what your question is and what specific individual sites you're asking for. And if you share your protocol upfront very clearly, they're very happy to share. It means you may have, like we shared the protocols, we could get almost like 80% of the people to contribute to it. Still 20% didn't. And so it's not that difficult. So it's not that complicated. Yes, I would agree that, yes, there is a lot of sophistications. You need to have anonymized data, but then it's not that tough. Data sharing is complicated, but then people do agree to share this data anonymized, and whatever you ask for, you do get it. So
But
it's not.
is there like evolving challenge based on evolving legal landscape in this area?
No, legal landscape will depend upon, you need to know what is the question you're asking. So it's like if you're doing an IPMA, you want to look at randomized controlled trials. So you're going to ask the contributors, the authors, the corresponding authors who've done that study to share that particular question and the relevant data to that. And you need to share an upfront protocol. What is your primary question? What is your statistical analysis plan? And you share an Excel sheet with them, and they're going to give you back that data. So one is what we've been talking about is you're sharing it to an international registry, where the registry is going to give you is all the data compiled together and give you an answer regarding the broad questions. But then is the another component is an IPMA, where you asked, you say you ask a question, you got say 10 randomized controlled trials which have happened to answer one question. You want to combine them all together, you just write to the authors and say.
So then you share the summary statistic and then
Yeah, you
go
have
from
to
there.
share your protocol, you have to give your statistical analysis plan. Everybody who's contributing to it will always go back and see what was your publication. You have to be one of the stakeholders in that. Or okay, you can also independently ask them, but then if you already have a trial answering that same question, it becomes very easy to ask the other authors to contribute their data. And I think that can get converted to a big meta-analysis.
I think there are two issues here. We are talking about something else here, because what Dr. said was about able to identify the hospital, for example. But most of the data sharing, data security issues deal with individual patient data being linked to that particular individual. So that is the critical thing. So all the HIPAA regulations, for example, in fact, in the US, if the patient is above 90 years of age, you cannot include age as a metric, because there are only about 1,800 people above 90, something like that. So you can actually identify. So the identifiability of the individual is the central point of data security when we are talking about this. Of course, there are those other issues as well, but this is the thing. The critical thing is anonymization. Can you identify, based on all the variables that you've collected, can you identify the individual or not? So that is the critical point. The reason why this becomes challenging is because you're collecting individual data from individual patients, which needs to be useful for that individual patient, you need to be able to relink it. First, you anonymize it for the collective analysis, but then you need to be able to relink it with that individual if you have to, say, provide a report, or if you have to provide, manage that patient or something like that. So that is the critical thing. So there has to be an ability to anonymize, but there should also be an ability to relink to that individual securely, because it can't be done by everybody. It shouldn't be so easy. So that's the critical thing. So these are all
That's very important. I mean, how easy, based on the variables collected or data collected on variables, to identify that individual. That's extremely important. Now, if we go to the other side of the data sharing, like participating collaborators, or even beyond the given cohort, and you start, maybe you are trying to diversify the outcomes of the cohort or the objective of the cohort. Maybe I can come to Dr. Maiti to talk about it and how to involve all the stakeholders.
Yeah, I'm maybe the best person to answer that, because neither I have any experience how to work with cohort data, or nor any kind of sharing data also. Kind of layman point of view, I can answer that. So when basically we started planning this conference, okay, when Shantanu approached me, the first thing I have in my mind is that all the cohort, how many cohorts are there in our country, and what are their objective? Do you know that? That is the first question we have. And second, whether that data or knowledge from the data are getting exchanged or not. Okay, this is one kind of sharing data as well as data derived knowledge. The second layer of sharing, which I believe, is that, like when I see some student presentation, okay, most of them, if they have any population level validation of their hypothesis, they go back to UK Biobank. Okay. So if you go to UK Biobank, okay, it is running well. There are many parameters are there. Okay. I am talking about that kind of sharing. Okay. A student who is sitting in Kerala do they have access of my cohort data or your cohort data? Okay. And at this moment, we should bother about only national access. Definitely international access will be there in that way. I also believe that data sharing is happening in a collaborative way, as Dr. Shalimar told that internationally he is connected and sharing data. It will happen, but beyond this, there are requirements. We are investing huge amount of energy. Forget about the money, okay? Unless until if we do not bring these all data together, the strength of the data also will not increase, and utility also will be very limited. So we should think sharing in terms of model of UK Biobank, Israel Biobank, or Singapore Biobank, and I believe they also follow all the ethicals. If we have intention, we can create. And as you have seen that we have so many cohort people, and if you can integrate their data, it's a huge amount. But still, we do not have anything to offer to the community or researchers or students. So that should be the objective. Now, how to solve that? I think all of us, we should come together, even if all these experts sit together and design a policy kind of paper. Let's do step by step in that way. I think we can achieve that.
That's a very good point. So how to take the benefits of all this knowledge that are being gathered by all these cohorts to the younger scientists who can actually, instead of going to the international biobanks, international repositories, they can actually come for their validation work in the Indian repositories. Maybe we can just move on from here. And now there is a very interesting possibility of all these clinical cohorts. So there are incidental findings. Some of them will be clinically actionable, some of them will not be, right? And how do you break the news to the subject who is involved? What is the ethical dimensions of breaking that news? Whether you should break the news even if it's not clinically actionable. Maybe Dr. Karthik can take up.
So, so there is one point that we have really not discussed in the last 2 days. Cohorts generally don't answer questions clearly about causality. So unless there are you find a mutation or something which is clearly identifiable to a disease, then it becomes imperative that you inform participants. But otherwise, most of the findings from cohorts will be associations, which need to be proven in. Yesterday, I think Dr. Jha was talking about embedding RCTs or experimental designs within a cohort, or doing further RCTs, before which you cannot draw any firm conclusions about any associations that you have. You may say that, okay, this person has a BMI of this much, but whether this is associated, you may find after 5 years that it is associated with something, but that doesn't really mean that it causes that. So cohorts are limited in that sense. So I don't think that will be a very big issue, unless, of course, you find something which is clearly linked to something, or maybe an incidental finding. You do an imaging in somebody and you pick up a lesion or something like that. That becomes important to report, inform the patient. But otherwise, reporting every time we find an association, there will be hundreds of association studies that will come out of cohorts, especially if they are very large cohorts. So every time if we have to go back and inform people about it, this will be a whole lot confusing. I don't think that would be, that is my personal view, because you have to have an experimental design to support any causal inference to be made in cohorts. So
also, that's important. And also my point was, say you are working on anonymized data, then you find out a really high blood glucose for someone. Now, is it your responsibility to find out whether that subject actually knows about this condition.
Yeah.
And then there will be need for de-anonymization, right? And
Correct. So that's what I mentioned the last time. So the critical thing, the challenge in data security is just this. This is the critical challenge. When you de-anonymize data for analysis for a whole analysis, and then your ability to safely de-anonymize in order for you to report these results, for example. So that is the critical element of encryption or whatever it is.
Yeah.
But yes, this is the ethical issue is this, that if you find something which is clearly abnormal, then there is a responsibility for you to inform the patient about it. So
Sure, very valid point. So I would like to pitch in to just update that in the Phenome India cohort, the similar situation was encountered, and technically, ethical part is one aspect. Technically, we have implemented in the portal itself where no manual or the human intervention is there in terms of identifying the respective person. So let's say in that portal in the last day we have heard about the transfer of an identity into alphanumeric number, which is not traceable backward. Through the portal itself, if we find something anecdotal or something and the team feels that it needs to be communicated, the participant through the portal gets the notification that this is the flagged value, and you can go to respective physicians for second opinion or verification of or further checking of your parameters and all that. So that kind of technical implementation is already in place in the Phenome India.
you should be very careful with thresholds then. Like
Yes,
I
yes.
can think of something which can cause a lot of anxiety. Supposing you just go by, say, somebody's cholesterol level. So you say that more than LDL more than 130 is abnormal. It will flag it automatically as abnormal. If that information goes to the patient, you will create anxiety in 60% of the population. So that is unnecessary. I mean,
Yes.
that's why you need to be very clear about what are the thresholds at which it becomes imperative to inform the participant.
Completely agree, yeah.
So, say, let me say we're taking a blood sample for evaluation of, say, hypertension. You are looking at, say, a person tests hepatitis B or hepatitis C positive. Won't it be imperative for you to inform that this patient you've tested? So,
So clearly, hepatitis B, a diagnosis of hepatitis B has major clinical implications. It has a valid treatment associated with it. So that needs to be reported. I'm very clear about that. So you have to have a clear implication for your finding. But whereas a cholesterol of 140 doesn't have any clear implications other than causing anxiety. I mean, in that sense, unless it is 400, then it becomes a different diagnosis altogether.
So let me just put it in a different way. The patient gets another blood investigation 3 months ahead and finds his lipids were abnormal. Won't he tell you that you took my samples, you had the reports, you didn't tell me? Or he gets a coronary artery disease. He has a risk factor which you think may be trivial, and tomorrow he says, no, it was above the cutoff level which was given in the guidelines that this is abnormal. So how are you legally safe in that kind of a situation?
Yeah.
Because there would be instances where you'll have, because there are so many trivial things which we would tend to ignore. We ignore as clinicians, but when you look at guidelines, the cutoffs will say, no, it was abnormal, it is my risk factor. Could have been told to me, but you didn't tell me. You had the reports.
So you're worried about the legal implications of.
That's
so. See, I think that is why thresholds are important. I mean, you will obviously report things which have immediate clinical implications, but this is just a risk marker. It's like saying that if you had a creatinine of 1.1, you will start reporting. No, if you had a creatinine of 4, you would report. But if you had a creatinine of 1.1 or 1.2, you would not report. I mean, I think we have to have some leeway in that kind of a thing, because the way you're saying it, then you'll have to, everybody has to get their own reports. So which is fine, which is totally fine if that is the thing that you want.
That is exactly what I thought, that when the data is getting collected, the person is giving this consent, it should be part of that. Do you want to get the data back? So your data can always be given to you.
Everyone will say yes, all the subjects.
No, may not be. We don't know. I mean, there should be a patient, that patient's rights, or not the patient, sorry, the subject's rights is all important. I have a right not to know also. Like I have a right to know, I also have a right not to know. Plus, only those, I mean, it should only be a report, not a flag. Now, what you do with that report is your business. You now go to another doctor and take treatment or not, that should be your business. So, and also there should not be cohorts, like cohort to cohort, there has to be some standards. So at the national level, I think cohort studies also, the standards should be developed, what to do, when to do, etc.
So can I just add in? I think that's a very valid point. And what we have actually done in Phenom-India is when we are taking the consent, we actually ask this question, do you want to know your report or not? If they have clicked yes, we send, so most of them actually want to know their report and we send the report to everybody. We have also taken a consent that if there is a life-threatening thing that we find, and this we majorly meant genetic profile and all, do you want to know that? Because if we want to know that, if they want to know that, and that is actionable, and we have written if it is actionable. So we have done that in the consent itself. And we, whoever has said, for us 100% have said yes, we send the reports to everybody. And for example, Karthik was talking about cholesterol. We give the report that is being given to us by the diagnostic lab. So we do everything, and it is done, like Kumardeep said, it is anonymized and computer. We don't do a manual handling. Computer handles and sends it in their profile. They get a SMS that results have been uploaded, please go and see. So you're right, you should do it in the consent.
So clinically actionable and also clinically proven. Those, that should be only.
Yes.
Yeah, maybe we should slowly try to wrap up the thing. So one thing is left we couldn't discuss, and that's the implications of the knowledge gathered. For example, if there are possibilities of commercialization of that knowledge, if there are intellectual property, like significant intellectual property with significant implications involved in the knowledge gathered in a cohort study. So what are the ethical landscapes in terms of that? So who are the stakeholders who should share these IPs? How the subject should be acknowledged in terms of garnering commercial values out of the knowledge gathered from cohort studies?
Stakeholders, you said it's an extremely important thing. I think it is very important for all the researchers should remember that when you are writing your study, that time you should write your stakeholder engagement plan very clearly. As of now, people are only thinking about stakeholder engagement only to the extent of getting participation. I think it is even beyond that to address some of the issues that you have raised. And at that, you need to list your stakeholders, rate them, and then map them appropriately on a, say, power influence matrix and the need, what you want to do and how much of information you can give and at what time. And you bring up that in your consent time itself, especially in a cohort. If it was a cross-sectional study, it's a different ballgame. But in a cohort time, you know that at any given moment of time, you may have an additional information which is extremely valuable. So at what time you give. So if you keep it right in the proposal time, get it ethics approval as well, and also bring it out very clearly at the time of communication. So one more thing is very important, which is linked to almost all the questions which we have discussed, is the communication. I think everything boils down to communication. If you really have very good communication all throughout your study, probably most of these questions would be answered. Thank you.
Okay, thanks a lot for your time and really inputs on these really contentious issues. Some of them are really contentious. We don't really have ideal answers for all the questions, but definitely answers are also evolving as we are gathering experience. I'll just end by Dr. Maiti, because we have gathered by the Phenom cohort team. And so what are the future directions in terms of sharing the knowledge gathered by Phenom cohort to all the stakeholders, as well as how you can, is Phenom cohort open for collaborations from other cohorts
Yeah,
or other
first,
investigators?
the task we have kept ourselves is creating Bharat Biobank, kind of, mirror of like a UK Biobank. And target is that initially let us put for 1000 odd data, because we are doing deep phenotyping. We have also going ahead to do, genomics of 1000 individuals, as well as we have done already microbiome, and do experiment that where we are facing problem, whether we are getting any benefit out of it, in the sense community is getting benefit out of it, students, other, cohort, owners, and so on and so forth. And if we see that there are good response, and if we overcome the bottlenecks which we are facing during this 1000 experiment, I think the next step will be, can we bring each and every cohort data, put in the similar way in a single platform, so that, multiple cohort doesn't have multiple platform to share with the, a different, way to share. And to do that, as individual, I am studying UK Biobank very deep, okay, and understood that AWS is basically maintaining it. They have a very good, systems, pipelines, everything is set, and we have started working with them also. And during this discussion, again, when I talk, similar way to other scientists, and so and so forth, why to go to AWS? Why not within a government system? And I believe that this kind of, data sharing platform, data storing platform has to be maintained very professionally, okay, with all kind of safeguard, and which basically is possible. It is not that impossible. Only thing is that how we are, writing our agreement, tying up with the companies who has high ethics, also demonstrated their ethics outside of our country. So these are the few things we have set ourselves to take it forward. If we are successful and putting all cohort, I think we will have a very large integrated data, and next few generations will be benefited out.
That will be fantastic, yeah.
Thanks.
So, Professor Bandyopadhyay, you wanted to...
I come from the Indian Statistical Institute, okay? So not a biology institution at all, life sciences institution at all. So I personally am a computer scientist, taking pleasure in developing algorithms, not using whatever is out there, but in developing algorithms for the last 20 years for mostly analyzing biological data sets, data, healthcare data, etc. And my institute, of course, has a lot of statisticians, mathematicians. What my appeal to all of you who are primarily domain experts here is, we do not get Indian data. Whenever we have an algorithm, we end up applying it to US data, to European data, even to Chinese data. But Indian data is so hard to get by. If that can actually be taken into account and data be shared not only amongst yourselves, but for all the researchers in the country, for all the students in the country, I think ultimately we will all benefit. So that was an appeal that I thought this platform, I can say
Maybe
that.
we can, okay, yeah.
I just wanted to add to this. Extremely important is, right in the beginning, do a good documentation of your data. One of the reasons why our data are not as much shared as others is the fear of sharing, because of the fear of quality of our own data. That has been proved to be true in many cases. So to ensure that your data quality is good right from the beginning, do a good documentation. We have this techniques called the DDI, Data Documentation Initiative. Follow those techniques, and you will be more confident about sharing your data in a responsible manner.
So we'll just end this panel. Maybe I can ask all of you to say 2 keywords which should be kept in mind while we are thinking of data security and ethical landscape in cohort studies. Maybe I start with Dr. Shalimar.
I think the most important points would be is the truthfulness. 2 would be as I'll say what ma'am said is data sharing. I think if you write to right people, people would definitely be willing to share. It's like we are not interacting among ourselves. We've been in India, we think probably our data is inferior. I think that is something which we need to come out from that phobia. We have very good data, but then you need to interact. So we do get data from other like open sources, like you'll have it from the net, you'll have available from those Chinese and other things, what you're like. But then each of these data have their own issues. Those data analysis, which is done for, like say, we do it from a foreign population, it doesn't stand true for anything in our population. It's just, I'll say, it's total crap for us. We are totally different. These are not drug targets where you have a drug's going to work on a virus and kills that. It's going to work pan. But the other things we've seen very clearly, many things don't work. So I think more interactions is something which we look forward to, ma'am.
So it's truthfulness and
Truthfulness
and interactions. Okay.
and interaction,
Now,
communication.
you're
Truthfulness and communications.
Okay.
Yeah. So two things. One is inclusivity. And second, which we've not talked about, is we must be very sure that there's no conflict of interest. That the study is done by people who have no interest, financial interest or any other interest in the outcome of that study.
Inclusivity, but
inclusive in the sense that
getting rid of
entire
conflicts.
community, entire
Yeah.
country, nobody is left behind to get the benefit of that
Right.
study.
I think data safety is very important, data security. And as Shalima said, it looks complicated in the beginning, but once you start doing it, it becomes relatively simple.
I just want to echo what was said about the need for high quality Indian data. So I think that should be the objective. And whenever somebody is thinking of doing a cohort, I think the objectives need to be clear. It's not that we are just collecting data at random and then analyzing at random and then we get random results. So it has to be an objective based collection of data.
So truthfulness, engagement, communication, inclusivity, no conflict, objective, being more objective about data. Okay.
So sharing data to a person who may not know who is the creator of this data or owner of this data. That kind of sharing, I mean.
No ownership, I mean, like community ownership of the
Yeah.
data, right? So, yeah, so some questions from the audience. Yeah, one question, yeah, of course, why not?
I think we collect data with all integrity and good intention. My point is that when we do anonymize and technically speaking, if you give me the age, gender, the disease history and all, finite possibilities there we can identify the individual, computationally speaking. Can we put a legal law like that, that the one who is trying to identify is at fault rather than who is sharing the data? For example, I have shared the data to Dipyaman because they have written a project to access the data. But if they identify the individual, it is their fault, not the person who has collected the data or shared with a good intention.
Yeah, I think that is why the security of the data is so important, that ineligible people should not be able to access it. Not only that, it has, for example, genetic data. If the genome of the individuals, that database is hacked, it can be actually used for very nasty purposes. So the scientific study then gets, in fact, even the founder of my institute, Malanobis, Prashanta Chandra Malanobis, had started with some anthropometric studies with racial likeness, which actually had its fair share of criticisms because, that depends on the interpretation, how you're interpreting the data. So therefore data, and yes, the person who's trying to misuse the data is at fault, of course. And therefore, assuming that that will happen, all the anonymizations and all other, like the hospitals do not share data these days. So what is being done in the machine learning domain is something called federated learning. distributed learning. So there will be individual models which will be learned within the hospitals, and then these models will be, they will be combined into a global learning. And how close, mathematically, then we have to prove how close it would have been had the entire data been in one place. So these are the research which is happening. Federated learning is very important nowadays.
Thank you. With that, we are about to conclude this panel session. So I thank our esteemed guests and the panelists. And we do know that the common vision is there to make the data more transparent, more accessible to the end user, as well as keep not compromising the security and the other ethical guidelines. And I have read somewhere that the onus is also on the participants also, because I'll just give a paraphrasing statement that do not reveal any information which can identify you. So if you ask this question, even if you are a participant or about to get enrolled into any kind of cohort, you should ask upfront this question. And if you are satisfied, definitely you should go about it. And you can ask multiple questions to the organizers, like what are the benefits, to ensure there is a transparency and other kind of things. So with that, I thank everyone, and now I switch it over.
Thank you
Sure.
for the stimulating panel discussion, data sharing ethics in cohort studies. Now I request Dr. Dipyaman Ganguly to give a flower bouquet to Dr. Sandeep Seth and Dr. Kumardip Chaudhary to Dr. Sangamitra Bandyopadhyay. So come to the Again, Dr. Dipyaman Ganguly to Dr. Sanjay Zuvekar and Dr. Kumardip Chaudhary to G. Karthikeyan. And Dipyaman Ganguly to Dr. Sovik Maiti and Dr. Kumardip Chaudhary to Dr. Salima. Now we'll have after this, we'll have a just quick photograph here of the panelist and session chair and moderator before moving to the next talk. We'll have a lunch now. Sir, actually 2 o'clock. वो लेट हो जाए एक टॉक करके
नहीं बोल रहा हूँ सुनो we'll have lunch now lunch भी arrange हो गया
okay
we'll have lunch 2 o'clock we'll be at 7.
Okay, now we have a lunch, so we'll move to the lunch. After that, after 2 o'clock, we will start the session. So over to lunch. ना वो बोले कि लंच करके
लंच के बाद अगले टॉक्स हैं, बट ये क्वेश्चन था कि इनका चेयर चेंज हो गया जो अगला सेशन है ना, ये 4 टॉक। हाँ तो
chair and moderator to come to the dais. Dipyaman Ganguly and Kumardeep Chaudhary, sir. Please come to the dais and coordinate the session. Thank you.
Okay, welcome back after a fantastic lunch. Let's get back to our academic sessions. So we have continuation of the past technical session, and we'll have 3 speakers. So let us invite first is Dr. Lakshmi Ramakrishnan. So may I request you to come over if she's here? Okay. Sorry. So Dr. Lakshmi is an academic researcher in the Department of Cardiac Biochemistry at AIIMS, New Delhi. Her research focuses on the immunology of autoimmune and inflammatory diseases, particularly skin and cardiovascular conditions. Okay. Dr. Lakshmi, it's all yours.
Thank you. First of all, I'd like to thank Dr. Shantanu and the organizers for having me here. I'm here to give an overview of the New Delhi birth cohort. I can safely say that this is undoubtedly the oldest cohort in India, one of the oldest cohort in India. Yesterday there was some debate going on about who's the youngest. So I can safely say this is the oldest cohort. So a cohort which actually started from fetus and it's now in the 5th decade. So the cohort was set up way back in 1969 by two pediatricians, Dr. Santosh Bhargav and Dr. Shanti Ghosh, who were in Safdarjung Hospital at that point of time. And this prospective study was set up by them to understand the rate of low birth weight, preterm birth, infant mortality, and physical growth and cognitive development in children at that point of time. And so from a survey area of around 12 kilometers square in Lajpat Nagar area of New Delhi, the investigators recruited around 21,000 women of reproductive age and measured their height, socioeconomic status, menstrual dates, and followed them up. So when women became pregnant, they visited them, and every 2 months they visited, and until 37th week of gestation, and from there on, every alternate day till pregnancy. And the pregnancies were noted, and there were 9169 pregnancies, out of which there were some 8181 live birth. And this cohort, it's referred to as FN generation. When I come to it later in the NDBC cohort, this cohort will be referred to as FN generation. And after the birth, the length and weight of the infant was taken within 27 hours of birth, and at ages 3, 6, 9, and 12 months, and thereafter every 6 months till the age of 21, sorry. So we can see that there was an exceptional record of growth through infancy, childhood, and adolescence. This childhood phase of the study, these are the findings. There were 8030 singleton births, 74 twins, and 1 triplet. 71.6% of the newborns were term babies, 16.4% were preterm, and 12.4% were post-term. The mean birth weight of the infants were 2.79 kgs. Length was 48.3 centimeters, and head circumference 33.5. The low birth weight prevalence, which was one of the objectives for the study, was 26.2%, much more than 10% reported in Western countries. And the mortality in the low birth weight category was 13.2%, more than that of the normal weight category. Stunting was a major problem at 2 to 3 years, with nearly 60% of the infants stunted, and this continued till 5 years. And another finding of the childhood phase was that birth weight and gestation age significantly influence future physical growth and cognitive development. The finding was that preterm babies and low birth weight children had less schooling compared to the normal, to the AGA group. And one of the outcome of the study was also an establishment of growth curve from birth to 20 years. So this figure shows that there was lots of attrition during the childhood phase. There were 4 phases of follow-up. From phase 1 to phase 2, lots of people migrated out due to demolition at that time and without having a trace of their address. And so at the end of phase 3, there were around 2,800 children left, cohort left in the phase 4 was actually a follow-up of only those children who completed 20 years of age at 1990. So the childhood phase ended in 1990, around 1991. Then there was a big gap, and then there was the cohort was retraced in 1998. So why this happened? This happened, a rekindling of interest in the cohort developed because of a chance meeting of Professor David Barker and Dr. Bhargava. He was, as mentioned by Dr. Yagnik also in the morning, he proposed that fetal origin of adult diseases, and he wanted to, and this cohort was an ideal cohort to study that. So he approached Dr. Bhargava with the objective to study the effect of in utero, infancy, and early childhood growth on development of adult chronic diseases, Barker hypothesis, which propounded by David Barker proposes that poor nutrition during fetal development followed by an exposure to relative nutritional excess leads to development of a variety of adult diseases, which at that point of time was referred to as fetal origin of adult disease and now designated as developmental origin of health and diseases. And NDBZ was a great resource for understanding the pathogenesis of adult onset disease due to the availability of excellent data on fetal, infancy, and early childhood growth. So the retracing of the cohort started in 1998 and went on for the next 4 years. And nearly 2,584 children of the cohort could be retraced, initial cohort could be retraced, and this formed around 32% of the cohort. And after initial consent and screening, 1,526 of the cohort subjects were recruited, and they were at that point of time around the age of 30. 23.5% of the cohort had low birth weight. The socioeconomics data, blood pressure, ECG, weight, height, waist, and hip circumference, and skin fold thicknesses of these cohort subjects were measured at that point of time. And OGTT was administered, and glucose and insulin were measured at 0, 30 minutes, and 120 minutes. And also insulin resistance and first phase insulin secretion was assessed using these glucose and insulin values. Other than these measures, lipids, homocysteine, inflammatory markers, that is hsCRP and fibrinogen, and PI1, plasminogen activator inhibitor 1, which is a thrombotic markers, were also assessed in the cohort. So one of the important finding of this study was related to development of diabetes in the low birth weight cohort. So even at the age of 30, there was a prevalence of around 10.8% of IGT in this cohort. Diabetes was present in 4.2% of the subjects. And in cohort who were diabetic, there was a higher BMI, waist-hip ratio was high, fasting and insulin, 20 minutes insulin was high, as well as insulin resistance was seen in these subjects. However, there was a lower 30-minute incremental insulin value. The important finding which emerged from this was that those who developed diabetes had a low BMI between birth and 2 years of age, but had around 4 years of age, there was a rise in BMI, which sustained till adulthood. So there was an adiposity rebound, which happened at the age of 4 years. So, but even at the age of 12 years, they were not actually obese, but they had, compared to other children, they were gaining weight. They were gaining weight compared to their low weight earlier. Between 0 to 2 years, they had a sustained increase in body weight, which this led to a development of diabetes, which was the hypothesis of the study also, that low birth weight followed by adiposity rebound is likely to result in adult chronic diseases. And this was published in New England Journal of Medicine at that point of time. And after this adult phase 1, the cohort was again again approached in 2006 to 2009. And at that point of time, around 1149 subjects were studied, and they were at the age of 32 to 37 at that point of time. And many of the measures which were performed earlier were again repeated, like anthropometry, BP, OGTT, fasting insulin, lipids, socioeconomic status. And in addition, we also wanted to look at the bone health. So DEXA was also performed, and so was carotid intima media thickness to understand the endothelial function. And we also did telomere length at that point of time. And then there was another follow-up phase in 2016 to 2019, where again around 900 subjects were studied, and they were now at the age of 42 to 47. And again, most of the measures like anthropometry, BP, OGTT, fasting, insulin, lipids are repeated. And in addition, we also did an echo to understand ventricular dimension, mass, and function. So after the first publication in New England Journal of Medicine, several more publications came out from these follow-up of the subjects. The important findings were that more rapid weight gain after infancy was also associated with higher adult blood pressure and plasma lipids. 29% of the cohort, even at the age of 30, had metabolic syndrome. And the greater BMI and weight gain at infancy was associated with this greater risk of metabolic syndrome and its components. Birth weight and BMI gain during infancy and early childhood predicted adult lean mass. However, the greater BMI gain in later childhood and adolescence predicted increased adiposity, adult adiposity. And as I mentioned, we were also interested in looking at bone health in adulthood, and it was seen that measures of bone size, that is area and bone mineral content, was positively related to height and weight gain at birth and growth during infancy, whereas bone density was positively related to BMI and BMI gain during childhood and adolescence. There was also an interest in to see whether there was a higher risk of obstructive sleep apnea in adulthood due to childhood growth. And 31% of subjects were at high risk of OSA in this cohort. And greater gain in conditional BMI or weight in early childhood was associated with this increased risk of OSA in middle age. We were also interested in looking at the cardiovascular risk profile of these subjects, and to understand if there was any association with early growth. So the findings was that birth weight and BMI gain between 2 and 11 years of age and adulthood were positively associated with pro-inflammatory and pro-thrombotic markers, which indicate increased cardiovascular risk. And between the age of some of the measures which were repeated in different phases of the cohort, from that we realized that between the age of 29 and 36, all the cardiovascular risk factors assessed were showing an increase. There was an alarming rate of increase between the age of 29 and 36. The CSIR-IMMT assessment showed 33% of men and 36% of women had carotid plaque, and this was associated with longer body length at 2 years. The cohort generally had a smaller LV mass and normal systolic and diastolic function when compared with published data on other Asian Indians and the West. However, the prevalence of obesity, hypertension, and diabetes was higher in the NDBC cohort. one of the findings was that there was the hypertriglyceridemia was present in a large number of men in the cohort. Around 41% of the men had hypertriglyceridemia. And this was associated with more rapid BMI and weight gain through infancy, childhood, and adolescence. So we wanted to understand if there are any effect of birth weight on genes which determine the hypertriglyceride levels. So we looked at polymorphism of 3 genes, 2 SNPs in ApoA5 gene and 1 in hepatic lipase and 1 in PPR gamma. However, we didn't find any significant relation with birth weight or weight gain. However, the risk factor of ApoA5 was present in significant number of the cohort. We were all to understand the mechanism of low birth weight, body gain in early childhood with adult disease. We wanted to look at telomere. Telomere has been linked to chronic diseases, and it is known that increased oxidative stress leads to shorter telomere. So we wanted to see if there is any influence of early growth with telomere length in this cohort. The only positive association we found was with gestational age and with BMI gain from 11 to 29 years, and this was associated with shorter telomere. There was no significant association of birth weight with telomere length. We also did markers of cellular senescence in a subsample, and we found that birth weight and birth BMI was inversely associated with P21 gene expression, which is a marker of cellular senescence, suggesting that small size at birth leads to accelerated cellular senescence. So the cohort was not just restricted to the adult cohort. We had, this picture shows 4 generations of the cohort actually. So this, there is the cohort, mother of the cohort, the daughter of the cohort, and also the grandchild. So this now is a 4-generation cohort. Although we didn't set out to actively recruit the others, but there was always an opportunity, and they came forward to interact with the investigators. And now it is basically a 4-generation cohort now, with around the F1 generation, which is the original cohort, has around 2,000 subjects. And you have F0 generation, which is the parents of F1 cohort. So you have some cohort whose only mother is alive, some cohort whose father is alive, and around 941 in whom both the parents are alive. And then you have around 3,572 F2 generation, children of the F1 cohort, and as well as the grandchildren, that is around 9 grandchildren. This census was done around in 2018. At that point of time, there were 9 grandchildren, and now I'm sure the numbers would have increased, and we would have more the F3 and F2 and F3 generation also. No? So this is now a 4-generation cohort. So there was also opportunity to do an intergenerational change, study on intergenerational change, because there was a study planned in the F2 generation also, and what emerged was that there was a positive generational change in height and BMI compared to the F1 cohort. The F2 children had a higher height and higher BMI. This possibly indicates an improved socioeconomic condition and nutrition and environment. So although there was no active intervention, but still this showed a positive improvement in change in intergeneration. However, this
maybe you can wrap up.
Yeah.
Maybe you can wrap up soon. Like
yeah.
2
So
minutes.
also the cardiovascular risk factors, when studied in the next generation, showed an adverse profile in the F2 generation also. In addition, the NDBC is also part of a cohort consortium where 5 different cohorts, birth cohorts, together have come and pooled the data and looked at many of the outcomes. So this is one of an important part of NDBC. And this sort of summarizes the 8 phases in which the NDBC study has been performed. And this is a publication which has come out from the Cohort consortium, the 5 different cohorts which have pooled their data together to analyze several important outcomes. And summarizing, it is NDBC is one of the oldest cohort from India. It's entering the sixth decade of continuous follow-up. The unique feature of this cohort is that there is growth tracking from infancy, childhood to adolescence and adulthood. The important finding is rebound, adiposity, and relative weight gain in later years of childhood is detrimental to low birth weight baby and predisposes to cardiometabolic disease in adulthood. It is now a 4th-generation cohort. Many of the trials and tribulations and the details of the cohort has been published by Dr. Santosh Bhargav in his book, The Adult Health and Human Capital, Impact of Birth Weight and Childhood Growth. And many lessons about this cohort can be learned, the challenges and can be learned from the book.
Thank you for your comprehensive description of the NDBC. So are there any questions from the audience? We can have like 2 questions. Yes, please.
So initially, I believe you had not taken blood samples from the very first time.
In every phase of the study.
But I understood when they started it, there was no blood samples being. Yeah.
You have 4 adult phases. But there has been no active biobanking of the samples. We have.
Yeah, because this is a most important cohort. I think we should all see if we can do something here. Of course, I don't know the structure or whose permission is required or not. I think this is the oldest cohort, and I think there should be a lot of things that can be done using this cohort.
Yeah, I agree with you, Dr. Shantanu. The custodian of the birth weight data is Dr. HBS Sachdev, and I'm sure he'll be more than happy to collaborate and take this forward. And it has lots of potential. It is now the healthy aging can be studied in them. Lots of markers have been studied in the earlier phases, which can be now, correlated with outcomes if they are traced again, if the cohort is traced again. So it is, I agree that it's a good, yeah, you can talk to Dr. Sachdev and Dr. Bhargav and take it forward.
Just a brief question. So this is started in 1969. Here.
Sorry.
Yeah, it's in 1969. Yeah. So what kind of dating methods, will there be a heterogeneity in the dating methods between the earlier samples and these samples? Like, were you using ultrasound in 69 and
No. Ultrasound was not done
but
in 69.
later samples might have ultrasound.
Ultrasound was done in only 2 phases. And the late adulthood phases it was done, not in childhood.
So don't you think dating would be accurate? Dating of the pregnancy would be an issue? No, it's so
actually Dr. Purnima and Dr. Tandon are also associated with the New Delhi birth cohort. The questions they can take in.
Yeah, just to say there was no ultrasound, obviously. So I think the way they did this was where Dr. Bhargav was with the Safdarjung Hospital in New Delhi. It was this whole radius of the Safdarjung Hospital where they followed up women of reproductive age group and visited them in the community every month and then they got the LMPs. So I think that's next most accurate. They did not obviously have ultrasound. Sorry, Lakshmi, I thought.
Okay, maybe further discussion can be continued afterwards. Thank you so much, Dr. Lakshmi. And
Yeah, so now let's move to the next speaker, Dr. Anilabha Basu. He's a professor at BRIC NIBMG Kalyani, and he's been, specialized in developing novel statistical and computational method for analyzing large-scale human genomic data. And one of his premier initiative is the Genome India, where he is spearheading as one of the multiple main collaborators. So, Dr. Basu, the floor is yours. Thanks.
All right. Thank you so much. I'd like to thank the organizers for this opportunity. So I'll talk about our experiences, and mostly this is empirical data sets which led us to this question, to ask this question about what is really normal for our populations. Let me start with let me start with this. I'm trained in statistics and I come from the Indian Statistical Institute. When I prepared this, I didn't know, of course, that the director will be sitting in the first row of this. So when we were a student, we had a set of very lame and naughty statisticians jokes. And some of them were like this, that we proudly proclaim that we are mean lovers, or we are eligible to dissect and discuss about others' posteriors. But the one which really is contextual to this is that we designed a T-shirt where in the front you have that something which I'm paraphrasing is, I know what is normal. And on the back, you will find something which is like this, which essentially is the Gaussian distribution, which you call is a normal distribution. But the quest for normality, I mean, of course, we didn't know what normal is, but the quest for normality essentially has been a very important context. And in some ways, what eventually has been a voyage is to go and deconstruct normality. And the fun of deconstructing things is that you start asking questions to people whom you admire and people who are your heroes. And one of the first things that we question, of course, one of the things which comes in questioning is the Vitruvian Man. Leonardo da Vinci's wonderful creation. And if you look at this, this was put into with absolute immaculate measurements, which he had done with respect to some kinds of measurements which was there by somebody who's known as Vitruvian. And this in 1940s, it was in 1940s, and it represents the ideal proportions of the human body. It symbolizes harmony between art, science, and nature, and eventually it is something which was known as something like an universality of human design. So this is so important. I mean, this was so important and this was so influential that eventually it came to be called as something like a Homo vitruvius. So humans were essentially associated very, very strongly with this particular picture. The impact of or the legacy of Homo vitruvius has been so immense that if you look into the modular of what constitutes a normal human being, then this was essentially the proportions which was laid down by Da Vinci in the Vitruvius Man. To the extent that Gray's Anatomy, which is the classical book, and I think there are many clinicians here who can confirm this. The 2004, which is the last edition of Gray's Anatomy, it still considers the humans as somebody who's a male, somebody who's a 70 kgs male whose height is about 5'9", and even the females are considered as deviations from the male body. So, as I said, I mean, the fun essentially lies in deconstructing things which you admire. The other thing which I admire very much, or which is my bread and butter, is genetics. And this also puts into context something which is very, very important in genetics. So the Vitruvius Man was used as a logo in the Human Genome Project, basically trying to depict something which is that the Human Genome Project is the blueprint of all of humanity. So it's like a normal sequence, which is like a universal human genetic code, which is a very large project which moved human genetics to a very large extent. It ran for 15 years almost, and it changed the whole game of human genetics in the world. But the question remains that so this is essentially the history of the Human Genome Project. But the question, as we move forward, the question that came to our mind is that is genetics really doing justice by assuming that there is something which is like a universal genetic code, and this can be applicable to all kinds of populations, all kinds of ethnicities, every diverse positions. So this is the persistent bias which has remained in genetics, which is, if you look at this, then in 2009, 96% of all genomic data that was available in the world was from European ancestry. It went to somewhere around 81% into 2016, but even as you can see, the most of the other ancestries are essentially people from East Asia, essentially China and Japan. However, if you look into the pie chart on your right, then you will see that something which is like, you cannot highlight this with this. So the Africans, who are 2.4% of the genomic data, if you look at the third line from the top, they contributed in 4% of new discoveries. So you sample fewer individuals, you get more dividend out of it. And this in context of the fact that if you sample less individuals, you have a problem with the sample size, which is kind of a statistical artifact. So your treasure trove essentially do not lie in doing more samples from the Europeans, but your chances of discovery are maximized when you look into populations which are understudied. So in appreciation to that, at some point of time, the Genome India project was also undertaken. The Genome India project had many, many goals. Of this is one. It put together 20 different institutes from all across the country. It came into as a consortium. It has various kinds of goals, but the primary goal, the overarching goal, is to address the question of Eurocentricity and the question of putting India, with the largest population size in the world as a nation, into the map of genetics. So in order to catalog this, what went ahead is to sample 20,000 individuals, of whom 10,000 were eventually sequenced. And this 20,000 individuals, for this 20,000 individuals, what also went around. So this is the marker paper which appeared in Nature Genetics. So this gives you a sense of the 83 populations that we have all across India, as you can see. And the population collection was very, very judicious. There were a mix of populations from all kinds of language groups, language families, essentially Indo-European speakers, Dravidian speakers, Tibeto-Burman speakers, and the Austroasiatic tribals. There were populations who were tribals and populations who were non-tribals. Then there were populations who come from different kinds of settings, as you can understand, and try to represent the whole of geographical space of India. So this is just a sense of the sample collections procedure that we went through. And as you can see immediately that this was during COVID-19, there were various kinds of innovative processes which were adopted, and it went along all places around this. You can see the differences and the diversity that we had. So this is a sense of the computation that went into eventually getting the genetic data in space. The genetic data, the combined genetic data, is now somewhere stored in the IBDC. So just to highlight this, there were 9768 individuals whose data I'm talking about, who are from 82 mainland populations, and the individuals generally clustered by population, which means that we have many, many populations in a sense that these are endogamous units where people are genetically similar and close to each other, and they may be different from others as well. Additional to the genomic data, there were these kinds of biochemical parameters which were also collected across the centers. Not that we had very, very huge uniformity in terms of 100% collection for all of them from all centers, but we had collected all of these biochemical parameters. And this is what I'm going to talk about mostly. So this is an overall phenotypes which Genome India had. As you can see, the gender distribution, or the as you can see that the age distribution of the age pyramid didn't have too much of an effect. There was some amount of demographic and habitat data as well, like smoking, alcohol, chewing tobacco, etc. This was how the data was collected and eventually came to some kind of a central repository. And this is where I would like to start. So this is LDL as an example, and if you look at the percentage who have high LDL, which is somehow kind of a normalcy defined by standards, then the proportion of individuals who have higher than 130 LDL, this is the kind of variation that you see across the populations. And mind you, the age distribution, if you look at the age distribution from these different kinds of populations did not vary too much. And this is age, if you do an age and sex adjustment to this, it still do not change at all. So So if you put them in the scatter plot, there is no specific pattern. As you can see, the greens and the reds, where the people have high LDL and the people have not so high LDL are all scattered all across this. So it's possibly very difficult if you put emphasis on all kinds of population. It's possibly very difficult to come up with something which is like a state level, even something which is a state level health patterns or a geography level health patterns. Incidentally, for this LDL, the green ones are the populations who generally have a little better LDL count in terms of the cutoffs which were defined are tribal populations. So if you look at the abnormal distribution, whatever is known as normal cutoffs, something which is deviant from that, and the proportion of populations which have abnormal distributions, that this is the percentage of ethnicities which has at least more than 20% abnormal distribution for all of these traits. So just to give you an example, there were two ways in which fasting blood glucose was measured. As Professor Tandon has also said that if you measure it through blood glucose versus HbA1c, then you get more people affected by diabetes if you use HbA1c. So 50 of the 73 populations, 50 of the 73 groups which were done had higher blood glucose, had diabetes if you use HbA1c, whereas 30 of the 51 different studies which were done had diabetes if you use fasting blood glucose. So if you take those normals as limits and look at individuals, then mind it, this is something which is like self-identified healthy individuals. Then 94% of individuals, close to 95% of individuals have at least one abnormal blood parameter or one abnormal parameter, which I mean, to somebody who deals with numbers, this is something which is very, very strange, and this really puts into question what really is normalcy in context of all of this. So is this a reference interval mismatch or it is a real disease burden? I do not know, but I think it may be a mixture of both of them, where there is a huge undiagnosed disease burden as well as compounded with something which is a reference interval mismatch. So talking about genetics, if I talk a little bit about genetics of this, so polygenic risk scores are the ones where genetics is universal, people tend to think. So you find something which is a genetic signal, you try to import that signal into your context. So these polygenic risk scores are essentially something like this. So for instance, this is height, and there is this individuals who have this AA genotype, they have a slightly lower height compared to the individuals who have GG genotypes, and maybe this affects into a 2 centimeter increase in height. So if you have multiple of, so some individual who has an AA genotype will have 0 addition to this, individual who have AG genotype will have 2 addition to this, whereas an individual who's a GG will have 4 centimeters added to this. So this is kind of the ideal kind of scenarios. And if you look at this, and for a polygenic trait where there are multiple variants which are associated, and these are associated through very, very large studies, then polygenic risk scores essentially add over the effects of all of this to come up with something which will port whatever is discovered in one population into what your population genetics is. So this is one of the reasons that one of the major things, because people have invested so much in genetics and there are so many results which we have. So let's see what happens if you try to do this for our populations. So this is height of females in global populations. As you can see, the orange one are the Africans, the dark greenish blue are the British, and the yellow are the Genome India populations. So the British and the Africans do not really have a height difference. If you look at the extreme left, so that's the distribution of their heights. They do not have a difference. But if you look at and the rest is Indians, these are the Genome India Indians are in yellow, and the green Indians, which you see in the next panel, are the Indians who are living in United Kingdom. These are the individuals from the UK Biobank. So there is obviously immediately a shift or an increase in height among the females of people living in Britain. But the interesting part is in the polygenic risk score. So if you look at the polygenic risk score, then on your extreme right are the polygenic risk scores for the British, which is that you get this information that has been done with thousands of millions of, essentially millions of samples to identify the genes or the variants responsible for height, and that predicts whatever is for the British on your extreme right, and for the Africans on your extreme left, which means that the Africans, this gives you no predictive power, almost no. This is even worse than a random prediction given a data set. The Indians do not do that badly, but again, as you see, the Genome India Indians, who is really a very, very wide combination of many, many populations, do worse than the Indians who were there in UK Biobank. The same is, this is the same story with the BMI. With BMI, these are the BMI. The Africans have the highest BMI. The Indians have lowest BMI. The British are somewhere in between. But if you look at the scores, then the Genome India BMI somehow does a little better than compared to others. I do not know what essentially is going into this, but this is a very strange thing which you start observing. Okay, so what brings me here? I mean, why am I in this Cohort Connect? That's also because that I'm from the National Institute of Biomedical Genomics, and we also have a cohort. This is called a Kolani cohort, which is around the region where our institute is situated. It's a peri-urban cohort. It is very interesting in a sense that Kolani is geographically very strategical in the sense that there is a train line which goes vertically, dissects it. On one side is very rural, the other side is pretty urban. So it's a peri-urban cohort, which is pretty captive. And it has somewhere around 40,000 individuals now who have, this is what the geographical location of this cohort is. And it has we had a two-step sampling design of this, of how we have selected this 40,000 individuals. This is essentially families which are selected. The individuals are essentially coming from families. On an average, the family size is about 4 to 5. And there has been a database which has been created on this. It has it suffers continuously, chronically suffers from funding, etc. But there's still, at some point of time, there has been some data which were collected on this. There were family data which was collected. There were individual level data which was collected, and then there is some kind of black parameters which were done. The summary of this is in this paper at some point. This is also not very young now. It was published in 2017, but this cohort is still going. I'd just like to talk just a little bit, because diabetes has been discussed in so much detail here, that the registered diabetics here is about 5.76%. And with other kinds of diseases. But if you look at the diabetes and the controls, this is the blood sugar level. So we do not have HbA1c measures here. It's blood sugar levels or fasting blood sugar levels. The cutoff is greater than equal to 126. And so what we found is that 5.7 is the registered diabetes, or people who know they have diabetes. 8% are the group of individuals who have undiagnosed diabetes in this cohort. And we also observed among the people who have diabetes, about 65% have hyperglycemia even after medication. They have uncontrolled hyperglycemia after medication. And these are the people whom we call resistant. These are the people who have the worst kind of parameters in terms of any other kinds of parameters or any other metabolic conditions that you want to see. The undiagnosed people also do not fare very well. Theirs is not as bad as the people who are the resistant ones, but it is still pretty bad.
Dr. Basu,
So, yes.
if we may wrap it up
Yeah.
in a couple of minutes, sure.
So here is my acknowledgement. Of course, I have to acknowledge the Genome India Consortium, particularly Shweta Ramdas and Debasrija Mandal, who have done just an enormous amount of work in cleaning up this phenotype data for all of us. Devashish Chandrika, they did most of this PRS and the genetic analysis that I presented here. The Kolani cohort investigators and supervisors, of course, I need to acknowledge them. Professor Partha Mujumdar, our founder director, he was the one who set up this cohort, had the vision to set it up. Shuman Pine, Mehboob Alam, and Aditi Mukherjee are the people who are still working on them, and they have put this all together. However, I mean, essentially, if there is somebody to acknowledge, I would really like to acknowledge all the people of this country who have voluntarily donated their blood and information for the Genome India and for the Colonic Cohort. And I'd like to end this not with my words, but with Maya Angelou's word, which says that diversity is extremely, extremely important, and we need to acknowledge and appreciate diversity in all kinds of senses that it comes. Thank you so much.
Wonderful. So we can have a quick one question in the interest of the time.
Honorable, the Genome India phenotype story, you showed that 94% people are, have one or the other abnormal thing. I don't know whether you have tested this using one single instrument, or there are multiple instruments that has been used, because if that has been used, then it is better not to show that. Rather, what you can do is you can create correction factors and then use that to see what the effect is.
Yeah, so yes, I mean, you're partially, of course, correct, because it is not uniform in terms of the exact instrument, the exact protocol. It is also not the same laboratory which has done this, right? It has been done all across India, so it's not that. But my point is not this. My point is that the laboratory which has, in the local setting, has given this report to us will be the same laboratory which will give the report to this individual if that individual would have gone directly, right? So if this is not true, then one point is that either all of these laboratories are doing something which is terrible, which needs to be really taken into account. But it is true that yes, this is very, very it's a big shortcoming of this, that it's not uniform across all kinds of equipments, all kinds of 20% difference.
Same sample giving 3 different instruments, there is about 20 to 25% difference.
But are you saying that the both of them will give you the same thing as normal versus abnormal? I mean,
Yes. So the concept of normal, the range that they give, that is questionable.
So you think it's a machine artifact that what?
No. So machines, if same sample you give to 3 different machines, we have a poster you can go and check. 400 samples we have taken, same sample given to 3 different machines gives 3 different values.
So how do you determine? Eventually, how do you decide?
So using that, if you take all the samples and do it in different instruments, you can generate a calibration curve. Most of the parameters are good, but there are some parameters which are off. So that you can create a calibration curve and then do the...
Yeah, I mean, so we have tried to do a little bit of something which is very similar to what you were saying, which is like trying to look at distributions for all of them individually and trying to come up with something which is like an outlier to that. But yeah, even then, when you start doing this, whatever you come up with as an outlier will have a completely different cutoff given the population that you are talking about. All right, so one question, right? Okay, thank you so much.
So next speaker is Dr. Sivasubramanian Ramakrishnan. He is a professor of cardiology in AIIMS, New Delhi, doing a lot of clinical research along with patient care and medical education. His expertise spans interventional cardiology and cardiovascular medicine with a focus on improving outcomes through innovative clinical approaches. All yours.
Thank you. I may be kind of a misfit in a cohort study situation, but we are all preparing scientists, we are all preparing for the future. At times we forget the present, and one of the presents we have already forgotten is how do we manage a heart attack in an average Indian. So, how do you take about the standard care, heart attack care to every Indian? That is the question. So we all know that So this is where we are. We all understand how important CVD is. I am not going to do the detail, but a rough estimate suggests that 30 lakh Indians suffer from heart attack at the lowest extreme. So that is the minimum estimate, that 30 lakh suffer from the major heart attack. I will be using this term. The major heart attack is known as STEMI, which is an ECG term called for ST elevation myocardial infarction. So we find ST segment elevation, that is what is a major heart attack that is known as. And unfortunately, so various estimates suggest that less than 20 to 25% of average Indians are treated in time. So how am I saying that confidently? We are running a big registry by Nitish Nayak, so he's running a MACE registry. So this is just includes all the major hospitals like AIMS, Bhubaneswar, AIMS, those kind of tertiary care center. There the thrombolytic rate in North India is roughly 17%, 17%. So by looking at the total number of molecules of these agents told, like tenant place, streptokinase, these are the thrombolytic agents that are given this for this treatment. The total volume that is sold is roughly 10 lakhs. So roughly 1/3 are actually getting treated. So ladies and gentlemen, I would like to put forth here the most common treatment an average Indian gets for heart attack in 2025 with all the gadgets, we are reaching moon everywhere, is no treatment. How long we have been saying like this? Maybe I am presenting these slides for like last 10, 15 years, and I just changed the year. We now wanted to make a real change. That is why we harped on this project. So what is a heart attack? So the heart attack is like, so basically there is a blockage, which could be a 20%, 30% blockage. So what happens is there is a clot that is formed, and that clot it can be on a 20% vessel or it can be on a 80% vessel that suddenly gets occluded. Heart is a end artery. That means there is nothing else can come from say somewhere else. So it produces a heart attack. Whatever area of muscle that it is supplying will go off. One of the therapies is give thrombolytic therapy, which is just an injection that can be given, or we just do coronary angioplasty where we put a stent here, and then the other thing that has come up is a combination of both. So what we call it as pharmaco-invasive therapy. So in effect, the Western countries, especially the Scandinavian countries, are the only ones who are able to do 24/7, 365 primary PCI for all the population that they encounter with MI. So the most important thing is whatever you do, we'll come to that later. So in India, this is the most important figure that you all have to understand. This is the viable muscle that is given here, and then the time. How much the viability of the muscle goes down, the artery that is getting occluded. These are all based on experiments long back, 60s and 70s, all these experiments are done, both in animals as well as there are human autopsy-based studies are there. Clearly the muscle starts to go down tremendously like this, and then there reaches a plateau by around 6 hours. So the best time for recovery is the 60 to 90 minute window period that we have. So time is life and time is muscle. So this we all understood for ages. This is, I'm not saying something that is known from the 70s. So what are we? So this is not something that is unusual, that everywhere across the world there are some problems in handling patients with major heart attacks. So there are like patient-related delays and system-related delays. Patient first of all has to understand that, okay, this chest pain could be of heart attack, I have to immediately call help. So that is the patient-related delay, and there are a lot of system-related delay. And what happens in a country like India is there is an additional delay. Number one, the patient-related delay is also longer. Commonly, they take a Hajmola, they call some friend, what is happening, what should I do, before they call some help. And then there is a delay in reporting to the right hospital. That is what we try to answer. So we at AIMS also, AIMS is sitting in South Delhi in a really reasonably better locality compared to the country. Then we did some small sample size surgery studies. We found that 60% of patients coming to AIMS in middle of South Delhi actually often reach to some other hospital before they are referred to AIMS. So the time is critical, time is wasted. And most of the time, at least in Delhi, at least these hospitals are able to handle it. But rest of the places, these hospitals are not equipped to handle it. But it is not a patient fault. We initially, when we are harping on this, HPACs reported like 40%, 50% go to a hospital which cannot handle anything. But it is not a patient fault at all. It is a system fault. That patient goes for fever, the same hospital, goes for headache, the same hospital, goes for vomiting, the same hospital. If he goes for chest pain for the same hospital, it's a hospital's problem that he cannot handle the chest pain. It just cannot take an ECG and handle the ECG. So that is what we realized, and that is why we thought of coming up with some different models. So I told about the golden time. These are all the various data statistics that were published till 2017, which we compiled in the STEMI position statement. So this is the average time of various studies that have been reported till that time. So we were discussing about 6 hours. It's a golden outer limit of best time. And this is the average time various studies reported. So look at where we are. So whatever we are here, so what is the most important thing is we have to open the artery by some way or the other. Whether you do PCI or whether you do thrombolysis doesn't matter. So we have to do something. So what we understand is heart attack is definitely a very high morbidity and mortality thing, and the outcomes are less than satisfactory for sure. And opening the artery in time is the key goal. And thrombolysis is effective and it really saves life, but only 20 to 50% receive timely treatment in India. This is, we are talking about 20s, 25s and all. So if you are southern part of India, it may be 50%. If you are northern part of India, it could be 20%. So what are the problems? What are the problems that are there? So we don't have ECG machines and defibrillators are not available. The trained professionals for STEMI diagnosis 24/7, 365 at each center is not there. Even if they are there, there is a big hesitancy in administering thrombolysis, making a label of this is heart attack and give thrombolysis. That confidence is not there. And obviously, thrombolytic agents are expensive and their non-availability and non-affordability. One of the good things that has happened with all this advances that happened is we are able to do our own tentative place with some formulation differences, and the cost has come down, say, from initially it was around 60,000-70,000 per vial, now it has come down to around 19,000-20,000. So with this, we started this kind of a pilot study. We started off with what about delivering the care to the patient's doorstep. We said, will it be possible? There are a lot of challenges to do this. So this is, we call this Mission Delhi, where we have a motorcycle respondent with all the packs put in, ECG machine, the defibrillator, the first aid packs, and the basic intubation kit with all the medicines were given. Initially, we started off with 5-kilometer radius and we went on to 10-kilometer radius. So this is a small video that we actually recapitulated. So, with the patient's consent, this was recreated. This is the exact place from which the patient was picked up and the patient was thrombolyzed. So we could reach through the traffics, we can reach there. And the best part is we are able to reach there in quick time. So the average. So patients are generally, this is the COVID times when it was done. So we were able to reach the hospital, the person's place. At that time, many of the patients were not able to reach the emergency because there was COVID going on. Only COVID patients were let in. So ECG is taken and the ECG is transmitted, and that is read by a doctor sitting in the console. And actually, the beauty of this is that 95% of the time, the diagnosis of STEMI is straightforward. One ECG is good enough to diagnose the major heart attack. So actually, if you look at it, a simple injection like pantoprazole for gastritis that is given cannot be injected in one push, whereas this tenetoplase can be injected by one push. There are a lot of challenges in this. Like, for example, in our system, the nurses are not empowered to administer a drug in the absence of a doctor. So a lot of likapati chala between us and the nursing council somehow to make it happen. Officially, what we said was, okay, the doctor gives a consent on a tab. So that will be taken under like a consent and given, orders are given under this thing. So even when we started off, we never thought we will be able to achieve all this. So the patients, we are able to reach the patient within 14 minutes in a 10-kilometer radius of AIIMS. And we were able to interpret the ECG and do an ECG and interpret the ECG in 8 minutes. If there is a thrombolysis needed, we could finish it off in 35 minutes. But would you ask me, like, is it a successful or a failure? I would say we really failed miserably. Because after 5-7 years of effort, we could only treat 100 patients. Why we failed? Because we created a standalone system of excellence for STEMI, for which the patient has to remember a phone number, he has to call in case of an emergency. Despite all our efforts, patients, even after diagnosis, the patients were willing to take an ambulance of Apollo and go to Apollo rather than come to AIIMS. So that is the problem that was happening. So we thought that kind of a standalone system cannot work. Meanwhile, we started working on the PhD models. So near Hyderabad, we checked out this kind of a, whether this kind of app-based system can work in a PhD level. So there are a lot of challenges in that. But then we hopped upon this model. So thanks to Professor Balram Bhargav, who was there at ICMR at the time. He took a risk, kind of a risk, to make it happen. So what is the plan? Is that we are not going to the patients. I think that may be really futuristic to do it. And we may not be able to do it in PHC. Let us concentrate on district headquarter hospitals, civil hospitals, and the CSCs and selected PHCs, which are decently equipped or which can be trained. So we understood what are we targeting. So what we did was, this is our STEMI Act, which was created now, we are completing 6th year now. So what is the idea? That we wanted to enable these smaller hospitals for ECG diagnosis and timely treatment. That was the idea. The idea was to double the thrombolytic rate and half the time to treatment. We actually ended up doing it we initially planned for 10 districts, we ultimately ended up doing in 9 districts, which are across the board that are there. So what we are able to achieve is something different. I think many of you may be aware of Tamil Nadu STEMI care model or the Goa STEMI model that is existing already. They are in a different planet, actually, unfortunately. So they were focusing on something else. Their thrombolytic rate is 65%. Their problem is how to transfer those patients who are thrombolized into a PCA capable center and do a pharmacoinvasive therapy. Our problem is totally different. Our problem is that how to get that 17% to 70%. The thrombolysis that is given into only 17% of people, how do you make it to 70%? That is the whole thing. So whatever we say is a hub and spoke, here we are not talking about a classical hub and spoke model. Is the hub is, spoke is a small center where patients are given thrombolysis, and hub is the hospital where angioplasty is done. Here in our model, we are actually enabling the small hospitals to do thrombolysis by the hub. So what is happening is, Shimla is the center, for example. Shimla has identified all the CSCs around it. They identified around 25 centers which can be trained. The physicians there were trained. The physicians are given ECG machines, and the paramedics were trained how to do ECG. And the ECGs are transmitted in an app. And immediately the senior resident on call cardiology will get a notification once the patient comes in. So this is the patient, 64-year-old male, diabetic for diabetes, hypertensive, presentation 6 hours chest pain, BP, pulse rate, that's all. It will come with an ECG. So immediately he can respond whether this is STEMI or not. Once he responds, I will go to the app later. So this is the app, app-based, everything can be done. The total treatment can be done, and then patient can be transferred to the major hospital through the 108 or whatever system of ambulance that exists in their state. So initially when we proposed this, and the task force members are discussing this project, and they know that this has a backing of the ICMR DG, but in person the communication was, what is this kind of a project? This is going to fail. You are thinking of making this PhD doctor take an ECG and transmit the ECG and interpret the ECG, and you want them to thrombolize. There are not enough doctors to write paracetamol there. You have to know reality. That is what the kind of the comments that came in. But lot of effort went in. Right now, that is where we are. So we have completed 7,800 patients across India, across these 9 centers. So they have been thrombolized. So some of these places it was almost 0. That increased to around 86% thrombolysis, 75% thrombolysis. And we are able to reduce the time and reduce the symptom time and everything. So 2 things are very simple that are easily possible. ECG diagnosis is very well established, and the management is not a rocket science. It's just a simple algorithm-based management that is very simple. Too simple to be true. And this is the app that we created. So it has all the information, including consent and everything. So the contraindication and indications for thrombolysis are listed out here. So with this, repeatedly, we were harping on the doors of, knocking on the doors of the health ministry. Maybe after 3rd or 4th attempt, they yielded. And now they have made it part of National Health Mission. So the advantage of STEMI care being part of National Health Mission is that the tenecteplase, that is a simpler bolus agent, was added to the essential medication list. And any state who wants to implement training, defibrillator, ECG machine, telemedicine, and system establishment, TNK, the medicines, the whole expense is going to come from National Health Mission. So what has created is, it has created a healthy competition among states. So every state is competing with each other to do this. STEMI as part of this. Many of the states have an NHM. Under the NHM, there is a STEMI officer who wants to establish this kind of a program. So that is what it has taken off. And we need to do all this and various things. And this is how we were trying to classify various hospitals for the nationwide program. So how do we classify each hospital and what is the protocol to be followed? So all those things are there. In essence, we wanted to do health system mapping to be done, gap analysis to be done. We need to create capacity building, supply chain management, monitoring evaluation, and then recording and data management. And these are the things that are needed, which are, I think, pretty easily trainable. Like. So with this same thing, I think there are very few success stories. The same model has been implemented in various states. One of the very successful model is Andhra Pradesh. This was started in 2022. Now they have almost across Andhra Pradesh, it has been established. And this is where they are. Already around 4,200 patients have been diagnosed in small hospitals across Andhra Pradesh. So same thing is happening everywhere. This is with a lot of efforts, obviously. And then there are some states which are very advanced. So like the Goa and Tamil Nadu, they have their own program which is very well running. And Kerala, Maharashtra and Gujarat, they don't have an official system running, but somehow their private and public thing, at least in the cities, they have a reasonable care where patients reaches, patient awareness is better. But still, I would suggest that they should also establish a system of care, because STEMI care doesn't need the greatest doctor, doesn't need the greatest hospital, does just need a system of care and timely reperfusion. That is what is needed. So what is this thing? These are the ones that are establishing. So a lot of them are actually reasonably well established, at least 1 year right now. And the most important thing is many of the states like Odisha are also setting up the whole system. So it's, I think the way we are managing our major heart attack is changing. And the whole thing is done free of cost to the patient. This 25,000 injection is actually given by the government in government centers free of cost to the patients. So I would like to conclude. So if we all get angry, if our pizza doesn't reach in time, why can't us cardiologists and system providers deliver care in time, especially when something is life-saving? Because India needs it and we have to do it. Thank you.
Any questions? Yeah. Questions, comments?
So, a wonderful talk. What are the deterrents to use of air ambulances in a city like Delhi?
I think one is affordability, availability, everything is a problem. Right?
Because
it can be one for some very big industrialist or some big VVIP, but it cannot be purported as a routine care system.
No, it has been a routine care system in West, but
for example, we always think that we are getting very rich and we are becoming pretty rich and all. But there is a lot of debate about when we are discussing about this national program for STEMI. There is a discussion about there is a lot of industry pressure also about to include the PCA also in this. That means angioplasty also in this. So then we had a back-end calculation. 30 lakh heart attacks happen. Each heart attack you have to spend 1 lakh for an angioplasty. We don't have finances for that. 30 lakh into 1 lakh, our health budget is beyond that. It is beyond our health budget. So we don't have, when we look at the whole volume, we are getting away because only 20% are getting care. We are able to provide care. The moment you have to give care to 100 people, 100%, we don't have neither the manpower nor the infrastructure right now, even currently. So we have to be realistic. Like we are talking about real rural people where possibly this air ambulance would be of use, but there I don't think it's ever going to come in our lifetime. So like for example, where do Australia or Sweden use air ambulance? They whenever a call comes, they make sure they talk to the patient. There's a probability of heart attack is very high, or the patient is very sick. They calculate the ambulance going time and pulling back time. So they realize that this is not going to happen in time. Then they dispatch the ambulance. There is also not a default dispatch. So it could be very futuristic, but it's not going to happen in our lifetime.
So one more question, sir. Sir, myself, Saktivel from this institute, I had COVID positive in 2021, and I am diabetic patient and continuing the disease is continuing. And recently, I have been tested for the ECG, and in 3 hospitals I checked it. It came out to be right side bundle blockage.
I think we can have a discussion later. This is a simple thing, nothing to be worried.
Okay.
Okay. maybe further discussions can happen afterwards. So thank you so much. Thank you so much, Doctor.
So we move forward to the last talk of the session, which is by the SciEx Dipankar Malakar, Application Support Manager, SciEx India Private Limited, Bangalore.
So thank you, organizing committee, to give me opportunity to talk in this forum. Yeah, that's good. So I'll talk about the role of SciEx mass spectrometers in various cohort studies. It's not changing. So first I'll talk about the SciEx Q-trap system. That is one of the hybrid model, and this is used for targeted quantitative analysis for lipids, metabolites, or small molecules. And what is the unique part of this Q-trap system? Like it can be used for both quantitation and also generating the MRM. MRM is called multiple reaction monitoring, that is used for quantitation using triple quadruple system, as well as it can be used for library searching using the full scan MS fragmentation, and also it has the capability to perform the MS to the power 3. So I'll talk about that system. So there are different application areas it can cover. One is the targeted analysis. Then it can also perform kind of semi-targeted as well as non-targeted analysis using the ion trap present in the system. Then mate ID analysis possible, and also impurity profiling analysis, and using MRM3 or MS based quantification. It is very useful for the sample which having the matrix interference, and general unknown screening, and then natural compound analysis also this instrument can be used, and like targeted proteomics, metabolomics, as well as lipidomics application. This is some example what I can show you, that like quantitation experiment using this SciEx triple quad instrument. So different biological samples like biofluids that can be spotted, like dry blood spot, that the analyte can be extracted, and then it can be injected to the SciEx triple quadruple or Q-trap system for targeted screening analysis. So these are the different clinical applications, like newborn screening, like amino acid screening, like 14 amino acids can be screened and quantified. Then acyl carnitines, that is like 35 carnitines available for quantification. And then also these are the different clinical markers, like methyl malonic acid, citric acid, homocysteine. All these compounds can be quantified. Then catechol amines also can be quantified. So these are the panel of clinical molecule. Then TDM analysis, vitamins like vitamin D2 and D3, and hydroxy vitamin D2 and D3 vitamin B12 analysis, all this method, LCMS method is available with SciEx. Then 45 physiological amino acid analysis kit also available with SciEx. And then steroid also can be analyzed using the LCMS MS method. So this is the tech note published long ago using SciEx very basic model, the QTrap system API 3200 in our SciEx demo lab. And this tech note published almost 10 years back. And this is showing that the amino acid and acyl carnitine for the newborn screening using the dye blot spot method. So like basic model of QTrap is enough for such kind of studies. Then vitamin D analysis, this is the crash and shoot sample prep, is very easy, like protein precipitation followed by the supernatant collection and running through the LCMS with a very short run time. It is possible to monitor the vitamin in the plasma. This kit is used as Chrome system kit, this analysis. Apart from that, this analysis also, this QTrap system also can be used for targeted proteomic analysis, like very low level detection. This paper published in Nature Communication using the QTrap, SciEx QTrap system called linear ion trap. So here here they reported that it is possible with a great mass, precision, very low level detection is possible. Then we have some analysis using the metabolomics. So this is the high-end triple quadruple system used, like 6500 QTrap or 7500 QTrap. Here almost 336 serum metabolite method was developed, and this is validated or verified using the SRM transitions, which is reported in the plasma, like 1950 transitions. And this is a single LCMS method where reverse space chromatography was used. So this is, then we have, you can see that different metabolites distributed, almost 85% of the MRM transition with a less than 20% CB. That is can be achieved, like quantitation result can be achieved with a 734 transition, MRM transition can be monitored. So we apply called schedule MRM or the retention time scheduling option we apply here for monitoring many different analyte. And this is the lipid analysis using the 7500 system. This is like almost 900 MRM transition in positive ionization mode and 1092 MRM transition in negative ionization mode. So these are the different lipid classes, like 20 different lipid classes can be targeted. And here we can see like close to 2000 lipid species can be monitored here. And here one of the important part is the scheduling of the different transition with a dynamic dwell time and dynamic window, retention time window extension. That option is there for, and that will help to monitor many analyte in a single LCMS run. So I'll talk about the high resolution mass spectrometry as well. That is mostly used for unknown screening or biomarker discovery workflow. So we have a system called Genotop 7600 and also 8600. So the important the features, the key features here is called Genotrap pulsing. So after the collision cell, so this is a QQ-TOF technology, but after the collision cell we have a ion trap which actually improve the MS sensitivity, and it allows low abundant peptide detection. Apart from that, we have a dedicated fragmentation cell called electron activated dissociation cell, EAD cell, that help to give complementary fragmentation of the parent ion, and it helps in the PTM post translational modification site mapping. And because of the ion trapping, it is possible to gain the sensitivity, and also we can do high-speed data acquisition. Both data-dependent and data-independent acquisition is possible using this Genotop technology. So this is the new version of Genotop 8600 launched in 2025 ASMS, and this Professor Matthias Mann lab member presented this data in ASMS, and you can see that it's a complex sample can be analyzed with a very low concentration of sample injection on the column. Here we can see that human, yeast, and E. coli protein they are mixed together to make the more complex sample, and we can able to achieve very good number of identification, like close to 12,000 plus protein groups with a column load of 200 nanogram of the complex sample. So here we used a workflow called SWAT, and this is called data independent acquisition with a Xenotrap on in the system, and that is why we can able to achieve good sensitivity. And for high throughput, especially for this cohort study, high throughput analysis is important. So here we can, this data suggests that K562 human cell line loading amount, different loading amount, like 5 nanogram, 50 nanogram, and 200 nanogram with 200 SPD. That means 200 sample per day. That we can able to detect good number of protein identification. Even for 500 SPD, still close to 5,000 proteins can be identified, and also it can be quantified with a good CV percentage, like less than 12% CV in many of the cases. PTM analysis, like post-translation modification analysis, again, this is the HeLa cell line that is loaded, is a very complex sample and loaded in the Genotop 8600 system, and then it is a Whisper Zoom 40 SPD. This is EvoSafe nano LC is used in the front end, and 40 sample per day. That way, data was acquired, and then we can see the 25,837 proteins, phosphoproteins with a phosphorylation site that is identified with the Genotop 8600 system. This is another example where phosphoproteomics study, we can see the difference in the spectra of the CID. CID is called collision-induced dissociation. This is routinely used in LCMS, but EAD is an additional or unique feature, another fragmentation technique that is electron-based fragmentation technique. So here CID, this kind of PTM studies, the neutral losses in the spectra is quite evident, and it also then we lose the site of the modification like phosphorylation. But EAD still the phosphate group, the labile phosphate group is still attached to the fragment ion, so it will be easy for the detection of the site. This is another example of peptidomics. So this is also a new area is coming up, especially for say urine or plasma peptidomics analysis. So this is one example where Genotop 7600 is used. Here the HeLa cell line was digested with elastase and then immuno-enriched. So the HLA peptide was monitored, and there we can see that EAD fragmentation actually helped to identify greater than 2300 HLA binding nanomer peptides. This is the technique from SciEx using the Genotop 7600 system. So summary, so the routine analysis like newborn screening, catecholamine, vitamins, amino acids, all these can be carried out by SciEx. Medium level or the basic level SciEx QTRAP system, but for targeted protein, metabolite, or lipid analysis, where you need a superior depth of coverage, there the high-end QTRAP system is required. And Genotop system like 76 or 8600 system can be used for high throughput proteomics and metabolomics as well as lipidomics analysis. So EAD fragmentation technique, it provides a complementary fragmentation option and can be used for detection of PTM sites, and it can be used for peptidomic studies as well. So this is all about my presentation.
Yeah, so thank you for the talk. We may have the questions, couple of questions.
Hello, Dr. Malakar. It's a nice, insightful talk about the mass spec SciX. But saying that in Xenotop, there is a extra fragmentation EAD over CID. So in this case, EAD can help in the lipid detection. I think what is the molecular mechanism? It is a kind of a heterolytic breakage or homolytic breakage. In that perspective, lipid can be detected more accurately in EAD dissociation.
Yeah, so the data is not shown here, but for lipids, especially the like double bond localizations and also the cis-trans isomerism detection, and then phosphatidyl choline and that differentiation of the phosphatidyl choline and phosphatidyl serine, that kind of differentiation also can be done through this EAD fragmentation technique. So not only for peptides, even for lipids, it will be very beneficial.
Yes. And second question is that what are the other instrument is comparable with the other company like your Xenotop 76 or 86?
So Xenotop 86 or 7600 has this EAD fragmentation technique. If you compare with other vendors instrument like ETD, that is restricted to the peptide level, like multiply charged peptide level. But for singly charged, like lipids or metabolite, it is not so useful. So then you need a UVPD kind of configuration to get that kind of fragmentation for singly charged molecule.
Okay, thank you.
Any other question? Okay, so if there are no more questions, so thank you very much, Dipankar. So with that, we conclude this session. Over to you. Thank you.
Thank you so much, session chair and moderator and all the speaker who contributed to this technical session, and especially to all the audience who are here even after lunch in such as comfortable weather to listen to the technical session. So now we are marching towards the last technical session for the day. Before that, we have a small announcement for all the participants who presented their posters. Their certificates are ready and they can collect it from the registration desk. So now, moving to the last technical session of this conclave, I would request Dr. G. Karthikeyan sir and Dr. Shalimar sir to come and chair the session and moderate the session. We have heard of both of them earlier in the panel discussion, so I think all of us are aware of their contribution and introductions. So without taking further time, I request them to please take over the session. I request organizer to please welcome them with their flower bouquet. I request Dr. Ajit to please.
Okay, we'll start this session with the industry talk by the Illumina company. Can we have the speaker from the Illumina, please?
Hi, good afternoon, everyone. And I know all of us had a very good meal and still we are feeling a bit sleepy. So I'll try my best to keep you all engaged and awake. So The organizers, first of all, a sincere thanks to the organizers who gave Illumina as an opportunity to talk about our expertise in cohort analysis and multiomics. Somebody told me that we don't know about you, so please introduce yourself as well. So Illumina doesn't need the introduction, but I do. So I am Anu. I work as a strategic account manager for large population genomic initiatives in India, as well as Southeast Asia. So before we dwell into the presentation, my executive leadership team has shared a gratitude to all those researchers who are present in this auditorium. And I think most of all the other researchers who are currently diligently working in the research laboratories across India for adapting Illumina technology as an integral component of your research projects. Because of your faith in us, we have been able to achieve a global leadership position in genomics, which is motivating us to improve daily. And that is why we are bringing a lot of innovations. So today again, I'll be talking about how the genomics is actually impacting the precision health genomics at large scale. Yeah. So Illumina's mission of Illumina is always to improve health genomics with the help of its sequencer. Our sequencers are being utilized not only in the research laboratories, but also at various commercial organizations and hospitals to generate the data. So not only the sequencers, we have a suite of softwares which helps in interpreting this data so that this data can be utilized in the clinical practice. So the journey starts from generating the sequencing data of an individual patient or individual participants. And gradually these data are accumulated as in when the more and more people are added in these kind of programs, these kind of clinical study. And not only that, even in a research or even a service lab who is providing the service. So gradually with the time, a cohort is built up. And this is how these cohorts actually helps not only to identify the significance of the variant which are labeled as unknown, because more and more you generate the data, more and more you are able to correlate it, and also generating the population-specific variant, population-specific databases. And ultimately, this information is again translated into the clinical practice so that the individual patients can be benefited. However, we need to accelerate this feedback loop. So the moment a variant of unknown significance is generated, it is not only creating an unbalance in the dynamics of the clinical analysis, but a lot of variant of uncertain significance which are being generated at various cohorts and which remain in silos, they create a lot of slowing in the progress of the population-specific data generation, which can be translated into the clinical practice. That is why a real-time exchange between the research laboratories and the clinical settings is really required to speed up these kind of processes. So what does it take? To unlock these discoveries at scale, it is not only the aggregation of the data. First of all, the tough region of the genome need to be analyzed. So these are the complex structures, non-coding variants, trinucleotide repeats, structural variations. All those need to be deciphered. And then inclusion of all kinds of ancestry. So most of the time, the cohorts are limited to a limited number of people or limited number of ancestry. So more and more ancestry, when they are being included, it reduces the unbiasedness. And then scaling. We have heard a lot of talks since morning, and all the cohort analysis journey started from a small cohort, and then they started building it up to a large level. So is the tool which we are using, or are the tools, they are sufficient enough to handle the scaling up of these database? And then most important is integrating the omics. When I say omics, multi-omics, it's transcriptomics, methylomics, and proteomics. So once you identify the variant, what kind of impact it is creating on human biology, it can be identified by analyzing the multi-omics. So by integrating all the component of the omics. So Illumina's connected software suite actually close this loop. So from generating the reads to analyzing the code, and then this code data to be converted into the research analysis, and then ultimately integrating the multi-omics data and then translating into the clinical practice. So if you see about the slide, in the Dragon, we have a suite of pipelines in the Dragon software, which not only analyze the single nucleotide variant, but also the copy number variations. Along with that, there are structure variation, short tandem repeats, and there are certain complex genes. For example, spinal muscular atrophy. If you see a normal NGS test, nobody prescribes NGS for a spinal muscular atrophy because it's a exon deletion duplication event. So you can't pick it up by NGS. But when you are doing some cohort analysis, and in case that population is having the carrier status, that can be picked up by this pipeline. Short tandem repeats, pharmacogenomics variant. We did a beautiful study in Indonesia, and we did a pilot project wherein we have identified novel pharmacogenomic variant in those star alleles. And of course, the HLA typing. So we are very proud to share with you all that Dragon 4.4 has been appreciated for its highest accuracy and precision by Precision FDA. If you see the left-hand side of the slide, okay. So if you see the left-hand side of the slide, you'll see that in a very small span of 5 years, we have improved our Dragon with the error rate, which reduced 87%. And if you compare it with the open sources, the false positive rate is drastically less in comparison to the open sources. And this actually helped in taking a very big leap in structure variation accuracy, and this also helps in personalization for bigger gain in SNPs and indels accuracy. So just to give you again a summarized view of Dragon, it has a very highest accuracy of single nucleotide variation, approximately 99.94%, copy number variation 97%, and in other variants, I will not take time in that. Structural variation, short tandem repeats, 13 targeted gene callers. These are the complex gene which I was talking about, HLA typing, pharmacogenomics, which are approximately 22 pharmacogenomics genes, and the variant annotation. I'm a geneticist, again. So my introduction, you will keep knowing me during the presentation. I'm a geneticist and I face this challenge a lot. So most of the time, whenever the patient used to come to me and they used to have this report, patient is having the phenotype, and I'm sitting with a report wherein it's a variant of uncertain significance. And he wants to know, the clinician wants to know, what should I do now? Should I consider this variant and start my treatment? Or should I forget about this variant? Is it a benign one? So this is the challenge even till today. So I started my journey 10 years back. So there are approximately 70 million protein coding variants, and variants with known function is only 0.1%, and variants of unknown significance is 99.9%. Why is it so? So this slide actually explains the reason behind that. So if you see on the right-hand side of your right-hand side, 65% of the variants are present in the coding region, and the remaining 35% in the non-coding region in terms of the splice sites, promoter, enhancers, and microRNAs. So Illumina has built up a team of 200 experts, which are with a new segment of bioinsights. They are developing AI apps, AI suits, to decipher all these reasons. So this is our vision for upcoming 5 years, and our journey has already started. We have already launched primate AI coding variant. So this particular application has been trained on millions of primate variants, which helps in identifying the missense variant which impacts the protein function by analyzing the protein structure data. Also, we have also launched Promoter AI, wherein in this app, the tool is being trained to analyze the variants which are present in the promoter region. And how does it affect? It affects the expression of a gene. So once we identify the variants in the promoter region, it helps in interpreting the non-coding variant, which also helps in a lot of rare diseases and the splice sites. You must have seen a lot of reports wherein it comes, oh, the variant is in the splice sites. There are so many alternate splice sites. We do not know what is the impact. We can't pick up the variants which are in the splice site region. So this is the another app, this is the another application wherein the tool has been trained to pick up the variant in the splice sites. So even the known coding variants which are impacting the rare diseases can be easily deciphered. So Jivas and Fivas, they have become the foundational tool nowadays in every genetic program. However, the strength of these tools actually depends on the cohort behind them. Most of the time, the cohorts are sparse. So you get minimal signals, biased results, and less inclusivity. So the solution is there should be aggregations of cohorts with a similar intent or similar kind of SOPs. And since morning, and I think since yesterday, all of you are discussing, and I joined this session since morning, all of us are discussing about this. Let us collate our cohorts with similar intent. So aggregating these cohorts are really important to reduce the biasness, to increase the inclusivity, and to identify those variants which might have been missed in these small cohorts. But is the aggregation enough? So for getting a better outcome or true value of the data, the aggregation, along with the aggregation, there should be a flexibility, scalability, and operability, which I'll discuss in my next slide. So when I say aggregation, I am pretty sure that, and since morning we have discussed these concerns. Whenever we are enhancing our size of our codes, you need to reprocess the previous codes and our data which you have already done. So that's the biggest challenge. The tools are not capable of aggregating the previous code data. Then the scalability. Once the code size is increased, the data accuracy decreases. And some of these tools, they produce outputs which are hard to use with other tools like Hail or Pig. It's a flexibility. So many solutions are tightly coupled with the platforms, and that results in inability to upload the data into cloud or HPLC, local HPLC clusters. So this is how we have proven with our IgG tool. So we have used it in Tomo 100K project, in Singapore 112K population size, And of course, in UK Biobank, 500 case size. So this dragon is capable enough to adding the code. So without reprocessing the previous code, again reprocessing for the data analysis, we reduces the batch-wise variations because this is capable of handling a large data size. Once the data is generated at scale, it is manageable by Dragon. And then the seamless integration. You can do the seamless integration with the other tools like Cohort. And the most important is the flexibility. The data can be easily uploaded onto the cloud and the local high performance computing options. So this is just one case study wherein our journey started from Dragon version 3.3, and today we are with Dragon version 4.2 at UK Biobank. And when they started this project, the code size was not 500K. So with the time, the code size got increased, and this is how Dragon actually helped. Without reprocessing the data, they were able to aggregate the 500K sample data, not only the aggregation, but also analysis of the data and coming out with a lot of clinical significant interpretation. And I think I need not to tell this to this crowd because since morning we are hearing everyone is taking the example of UK Biobank. So no matter what's the size of the cohort, whether your cohort size is of 1,000 sample size or your cohort size is of 10 million, Illumina has suite of softwares which can easily handle these data, and we are here to help you out for your cohort size, for your cohort analysis. Again, I'm emphasizing again and again, it's not about aggregating the data. The journey starts beyond this point. Once you aggregate the data, how to go ahead with the analysis, interpretation of the data, utilization of this data into a meaningful product. So this is where we need Illumina's support or Illumina's software suites. So at the end, I would like to conclude here is that there are certain, just continuing with my previous slide, that when we really want to come out to this longitudinal cohort analysis and coming out with an significant interpretation and come out with a product which can be used in future for individual patient. That is the purpose. That is why all of us are here. So integrated and dynamic knowledge exchange accelerates the discovery. So time is really, really critical, and our tool helps in accelerating your discovery. Plus, we are able to handle the scalability. More the size of the cohort, better it will be in terms of the unbiasedness, inclusivity, robustness. And then, of course, infrastructure matters. It should be secure, interoperable, and scalable systems are essential for sustainable innovation. Thank you for being a patient listener. Thank you again.
Thank you, Dr. Anu, for this update regarding what's new coming up with Illumina. Can we have questions? Please
So
go
just
ahead.
one. Thank you. We use Dragon, of course. So far, we have used about 12,000 whole genomes using the Dragon analysis. But one problem we face is that we don't get the mitochondrial and the Y chromosome in the same analysis. We have to do it separately to get. So in any of the versions, it is going to be integrated?
Mitochondrial will be integrated in 4.4 version, but I'm not sure about Y chromosome. For that, I need to go back to the expert team.
Okay. Thank you.
Okay, if there are no more questions, we'll end the session out here. Thank you, Dr. Anu.
Thank you.
So there's been a small change in the program. So Dr. Kumaran will be speaking now because he's online and he needs to go before this we are already running late. So Professor Kumaran is a distinguished researcher who is basically working on the effects of early life nutrition, intergenerational programming, how it affects the future risk of NCDs. He's based at Southampton, and I now invite him to talk about the effects of intergenerational programming on NCDs from Mysore. Professor Kumaran, you're online. You're muted, sir. Can somebody help out, please?
Yeah, I can hear you. I guess it's on my laptop. I can hear, but on the system it's not audible. Just please give us a moment. Hello, sir. Can you say something? Hi or something? Yeah, yes, I can hear you. I guess there is some audio.
Will you let the chairs know? I think they are looking a bit puzzled.
Yeah,
now it's working. Now it's working.
Okay, Dr. Kumaran, you're audible now. Please go ahead.
Okay. Thank you. Thanks very much for the kind invite. And I'm really sorry I couldn't be here there in person, but a combination of work and family issues made it impossible for me to travel. What I'm going to do over the next 15-20 minutes is to share the research that has happened in our unit in Mysore. Can you see the slides?
Yes, sir, we can see them.
In slideshow
Not yet, but
mode?
Not yet. Yeah, we can see them now. Slideshow.
Great. Thank you so much, sir. So I'm going to discuss about intergenerational programming and the evidence from our Mysore studies over the next 15 or 20 minutes or so. Those of you who have worked in longitudinal cohort studies will know that this is never the work of one person. So what I'm really doing is presenting this work on behalf of my team. So our work in Mysore over the last 30 years or so has essentially revolved around David Barker's fetal programming hypothesis, when he originally suggested that transient insults during crucial periods of fetal growth have permanent effects and thereby leading to increased susceptibility to adult diseases, mainly cardiometabolic disease, which is what they focused on at that time in Southampton. We now know that it's not just the period of pregnancy that matters, it's factors across the life course, including the preconceptional period. And this concept has now evolved into what's now called the developmental origins of health and disease. So we've been working mainly with 3 cohorts in Mysore. I'll go from the bottom upwards. The first one is the retrospective cohort, where we have been following up a group of men and women who were born in the Mission Hospital, in the Holsworth Memorial Hospital, also called the Mission Hospital, who were born there between 1934 and 1955. We recruited them for the first time when they were aged between 40 and 60, and we have been subsequently following them up since. The second cohort is the Mysore Parthenon cohort, where we recruited the women from the antenatal clinics at the hospital in 97, 98. So we followed up the women when they were pregnant and then their offspring subsequently from birth onwards. And these kids, I still call them kids, they are now about between 23 and 25 years of age. And then the last one is the healthy cohort, the Healthy Life Trajectories Initiative. This is a trial cohort, and we are still recruiting for this trial. And this trial is again based on DOHAT concept. So I'll briefly sum up the work in each of these 3 cohorts over the next few minutes. So we first started off with the Mysore birth record study, which is the oldest cohort. this group of men and women were born between 1934 and 55, as I mentioned. And this was the first study to really test the fetal origins hypothesis in adults in an Indian population. The reason the mission hospital was selected for this was the maternity hospital that was established in 1905. And the hospital had maintained meticulous birth records from 1934 onwards. On the right-hand side of the slide, you see a sample of a old case sheet. I've changed the names of the father and the mother for confidentiality purposes, but everything else is as it is. So these records contain the parent, name of the father and the mother, their caste, their religion, the mother's age at that time, the previous obstetric history of the mother, and then very detailed birth measurements on the child, including birth weight, birth length, and head circumference at birth. And about 50% of the birth records also had information on maternal weight and external pelvimetry. So this study was led by Claudia Stein, Caroline Fall, and David Barker, and I started my research career here with the fieldwork. So what we realized was, although we had the birth records, we didn't know where these people were. As you will all appreciate, kids don't get named at birth in India most of the times. So we then had to trace these people who were born in the hospital. And luckily for us, Mysore had a relatively stable population in the early 90s. So most of the men and women who had been, quite a few of the men and women who had been born in the 30s, 40s, and 50s still lived in and around Mysore. So we undertook a door-to-door survey of a 2 square mile area around the hospital, which then expanded to 8 square miles. So what we did was we literally knocked on every door, asking people if they were born in the hospital. If they said yes, how old they were, and if they were reasonably within the range of our of the range we were looking for, which was between 40 and 60 years of age. We took down details on which you can see on the right-hand side of the screen here, which would enable us to match them to their birth records. We didn't have proper addresses in the area at that time, so our field workers would draw a hand-drawn map of where we found these traces, and then we would go back and translate them into a large-scale map. We matched them using a computer phonetic matching program based on the mother's name, because a name like Kairanessa, for example, could be spelled Khai, Khy, Ki, Ky. So the initial match was based on phonetics rather than spelling, and then we would go through a very strict pro forma where we tried to match the information in the birth record with the information in the case sheet. And once we were convinced we had a match, we then invited them to our clinics for detailed cardiometabolic investigations, including blood tests and OGTT, ECG, questionnaires, etc. So we managed to trace about 536 people initially, out of whom 517 participated. And when we looked at their risk of coronary heart disease, when they were between 40 and 60 and related it to their birth measurements, we found very similar measurements to what had been found in the UK. So a smaller size at birth was associated with an increased risk of coronary heart disease in middle-aged men and women in Mysore. Lower birth weight, a shorter birth length, and a smaller head circumference at birth were all associated with a higher risk of CHD. When we looked at type 2 diabetes, the picture was slightly different. We found a higher rate of type 2 diabetes in relatively heavier babies as measured by, these were relatively heavier but shorter. As you know, ponderal index is based on both length and weight. And it was also more in babies who were born to relatively heavier mothers. And again, when we say relatively heavier, it's all, they were not obese by any international standards, but we split them along the median into mothers who weighed less than 47 kilos and mothers who weighed more than 47 kilos. And we then speculated whether this was because could the mothers have already been, have gone through some amount of transition in the 40s and 50s, and did they have early signs of gestational hyperglycemia? And I'll come back to that in a short while. We then tried to look for mechanisms and to see whether the mechanisms that had been identified in the West were also replicated in our population. So we looked to see whether the link between small size at birth and adult cardiovascular disease was linked through arterial compliance or through left ventricular mass. And we did not find any associations, unlike the West. And it just seemed to suggest that Indian populations perhaps had a different mechanism for the link between fetal growth of birth size and adult cardiometabolic disease. We then continued to follow up this cohort. We recruited their children to look at intergenerational effects. We compared birth weight between the two generations, And we found that the second generation definitely had a higher birth weight compared to the first generation. The mother's BMI had a greater effect on the birth weight of the second generation, but the father's height had a bigger effect on birth length. So we saw some effect where both the mother's nutritional status and the father's nutritional status had independent effects on the next generation. We continue to follow up them with serial cardiometabolic data. And most recently, my colleague Murali Krishna added studies on mental health and aging for the first time when these men and women were between 60 and 80. So they underwent a battery of cognitive tests for dementia and other mental disorders. And we then repeated all the cardiometabolic measurements which we had done previously. So they've now had about 4 rounds of follow-up. And what we found was that birth weight also predicted cognitive abilities in late life. So those who had a better birth weight had better cognitive abilities in their 60s, 70s, and 80s. And this was independent of all the other known factors for cognition, such as maternal education, their own education, socioeconomic status, etc. So the second cohort I mentioned, the Parthenon cohort, was specifically set up because of the findings from the first cohort. So we wanted to specifically look at the effects of gestational hyperglycemia on the growth and development of the child and the potential for cardiometabolic risk. So we recruited these women in pregnancy. They all underwent an oral glucose tolerance test between 28 and 32 weeks of pregnancy at that time. The children were followed up at birth, and then they had detailed anthropometric measurements every 6 to 12 months, and then more detailed cardiometabolic and cognitive assessments at 5, 9, 13, and most recently at 20 years of age. So this was led by my colleagues, Dr. Krishnamani, Dr. Jackie, and Dr. Veena. So what we found out then in 97, 98 was the mean BMI was 23 kilograms per meter squared, which, if you look at it, suggested international cutoffs for South Asian populations as 23 as being overweight. The average woman here was already reaching that mark. Gestational diabetes was 6.2%. This was one of the highest proportions of gestational diabetes that was known at that time. You know, most studies had suggested it was much lower than this. But although these women appeared well nourished, 2/3 of them had vitamin D deficiency and about 40% had vitamin B12 deficiency. We had very little folate deficiency, probably because they were being supplemented with folate. We found that vitamin B12 deficiency was actually linked to both maternal BMI and the risk of GDM. So those who were vitamin B12 deficient had higher BMIs, and they were also more likely to have had gestational diabetes mellitus or hyperglycemia in pregnancy. And when we followed them up 5 years later, the ones with vitamin B12 deficiency were more likely to become diabetic at the 5th year follow-up. We found a similar pattern of the thin fat phenotype, which Dr. Yagnik has probably spoken to you about this morning. So similar to the findings from Pune, we also found that these babies born in Mysore, although they were lighter than comparative babies born in the UK at that time, or if you look at WHO standards, they were relatively fat spared. We continued to follow up the children, and one of the key findings from this study was related to subscapular skin fold, which is a measure of adiposity. Children born to mothers who had gestational hyperglycemia had higher subscapular skin fold thicknesses at birth compared to those whose fathers had diabetes or control mothers. And this difference was not only significant at birth, the gap between them and the other two groups tended to increase as the child became older. We also found that children born to mothers with gestational diabetes had higher BMI in childhood, they had higher blood pressures, they had higher insulin resistance. And at 13 and 20 years of age, we also measured their cardiometabolic responses to stress through the Trier stress test, which is a standardized method of inducing social stress. So the children underwent 2 tasks. One was a speaking task, public speaking task, and the second one was a mental arithmetic task with a continuous cardiovascular monitor recording their pulse, blood pressure, cardiac output, etc. And we found that children who were born to mothers with GDM had exaggerated cardiovascular responses to stress, suggesting whether stress could be a possible mechanism for the link between early life factors, and later cardiometabolic risk. Around the same time, there had been other studies in India which looked at interventions, mainly micronutrient interventions. And both the study in Pune, which Dr. Yagnik might have talked about, and the study in Mumbai, which was led by Caroline Paul and Ramesh Poddar, showed there was a moderate increase in birth weight if women were supplemented with micronutrients preconceptionally and during pregnancy. But we then realized that single interventions at best have modest impact, particularly when you consider populations which have multiple challenges. And it was now becoming obvious that the first 1,000 days, i.e. pregnancy and the first 2 years of life, were not really enough, and we probably need to start preconceptionally. So on this background, and on the background of the WHO's Ending Childhood Obesity report, the Healthy Life Trajectories was set up. It was an initiative that was formed by 4 national funding agencies, DBT in India, and 3 national funding agencies from Canada, China, and South Africa in collaboration with the WHO. And the idea was to set up these 4 linked intervention cohorts in Canada, China, South Africa, and India, based on DOHAD concepts, to try and generate evidence to see what could potentially work from a DOHAD perspective into reducing the risk for cardiometabolic outcomes in childhood, and also to improve early childhood development. So these 4 countries were chosen because they cover the range of transition. A high-income country in Canada, Shanghai in China, which is completely transitioned, Soweto in Johannesburg in South Africa, which has undergone rapid transition over the last decade or so, and then rural Mysore, which is just beginning to see the signs of transition. So I'm just going to briefly talk about the India study design. This study is currently going on. We are hopefully going to complete recruitment by the end of this year. The area that we have chosen is relatively deprived, subsistence farming, low levels of literacy. They have high levels of underweight, stunting, and anemia, although we are beginning to see increasing rates of overweight, particularly in women of childbearing age. This is a community-based study with individual villages as a cluster. So we are doing it as a cluster randomized study. And our intention is to recruit 6,000 women so that we have 2,100 children at the age of 5 for a primary outcome. And our primary outcome is adiposity as measured by fat mass index. And we measure fat mass index by DEXA. Unlike the other 3 sites which have 1 intervention arm and 1 control arm, we have added a 3rd arm. So the interventions are multifaceted. They incorporate nutrition, maternal mental health, avoiding pollution, parenting skills, child development, hygiene, and all underpinned by behavior change. And so the first group gets the suite of interventions that begin before pregnancy, continue through pregnancy, and into postnatal life until the child is 3 years. The second group basically receives the same suite of interventions, but the interventions start once we diagnose pregnancy, which in practice is around the end of the first trimester. And then the 3rd arm is the control arm. And the reason we thought it was important to have this pregnancy arm was we would like to look at the relative costs and benefits of starting an intervention preconceptionally versus starting in pregnancy, particularly in a setting such as ours. So before starting the study, we had about 2 years of extensive formative work, community engagement. We met with all the community leaders and the local community in all the 105 villages, because for a long-term study such as this, which is a 10-year study, we can't really do the study without the support and engagement of the local community. The studies had to be harmonized across the 4 sites so that we tried to collect data in a similar manner. And I'm sure all of you are well aware that doing any kind of harmonization after the study is done is almost impossible. So we've spent about 2 years trying to harmonize our data collection tools and our intervention domains before we started the study. The formative work helped us adapt it to the local context and the needs of the local population. So in a way, the interventions were co-developed with the community to make sure it was not only acceptable, but also feasible. And we undertook extensive quantitative and qualitative methods, particularly using focus groups to understand participants' perspectives, their needs, and which helped us guide our intervention package. We also undertook extensive pilot studies so that when we eventually kicked off the study, we knew how we had to go about doing it. This is the current status of the study. We are close to completing recruitment, as I said. We have a very high retention rate, almost 90%. We have already got over 1,500 children born and 2,000 pregnancies. We have collected a huge number of biosamples, and we are building a biorepository which will be available for other scientists to use in due course. And we are now focusing on the 2 and 3 year measurements. Many of the kids have now reached 2 years. So we are focusing on the 2 and 3 year measurements, where we are also adding a lot of neurodevelopmental assessments in addition to the anthropometric and body composition assessments. We have just begun our mechanistic analysis. We have extracted DNA from the first 2,000 women, and we are extracting genomic data on them now. So will we have definitive answers for policymakers? I think this is the question that we are always asked. And we are now at a phase where we have moved on to intervention studies in Cohort. So we will be uniquely placed, but it's going to take more time. Policymakers need evidence of impact on health outcomes. And there's always this tension between, is a childhood risk marker really going to translate into an adult disease? And by the very nature of this work, intergenerational programming and life course evolution, it takes time. And what we are trying to do to support that is also build in both economic evaluation and process evaluations in all of our studies, particularly in healthy. So hopefully we will have some answers in the next 5 years. I just wanted to finish with this challenge of maintaining cohorts. We've been maintaining these cohorts for nearly 30 years, and keeping the cohort engaged is a big ask. We try and do that with regular contact. We send them greetings for birthdays. We send them greetings for certain festivals. We act as their first source for medical advice and support. Although we may not be able to provide medical care ourselves, at least we can arrange for referrals. And we undertake regular public engagement activities where we ask the participants how they would like to receive the information about future research projects, how they would like to receive the results of these projects, and also what things they would like to see. So for example, when we have some of the older participants say they would like to have kidney scans or brain scans, and then we try and incorporate those into the next projects. Funding is the main issue really with the challenge of maintaining cohorts, because coming from small institutes here, we don't really have intramural or long-term funding. So our funding has to be on a project by project basis, and trying to maintain these between project funding is actually quite challenging. So I'm just going to finish by thanking all the teams I've been fortunate to have worked with, the participants, of course, and our funders. Thanks, and if there's time for any questions, I'm happy to answer them.
Thank you, Dr. Kumran. That was fantastic. It's particularly interesting that you've transitioned from an observational design to a randomized design. I just was curious, before we go to questions from the audience, I just wanted you to tell us, if you can, about what the suite of interventions that you are using in your trial. What is that?
Okay, so it's a multifaceted intervention. We are tackling multiple domains, and the domains we are tackling are nutrition, maternal mental health, child development, parenting skills, pollution, particularly from handling pesticides and indoor smoke, and hygiene. And a lot of these came about during the formative work we did with the local community. So what we do is we have 6 sort of educational interactive modules that we deliver before pregnancy to the preconceptional group. And these are done as cyclical short amplitude sessions. Each session focuses on a certain aspect. So one focuses on general health, one on diet and nutrition, one on physical activity, sleep, and screen time, one on mental health, one on pollution and hygiene, and the last one on preparing for pregnancy. So we use a technique called healthy conversation skills, which is a method for all form of communication with participants. It's been shown to work in low-income settings, and we basically it basically empowers the women to make decisions based on their own circumstances. The only thing we administer is multiple micronutrient supplements. Nothing else is administered. It's all based on behavior change. And we teach them, so in the physical activity module, for example, we teach them simple exercises that can be done. And what's interesting is we have just begun our first round of process evaluation. So when we've done this, we have found that different groups of women seem to have picked different things that they can adapt, and they have changed. So some women have told us that they've changed the timing of their food. Some have changed the way they eat by incorporating more vegetables. Some of them don't look at the screen before going to bed for 30 minutes. So each woman seems to have picked something that suits them. The pregnancy and the postnatal modules are related to the growth and development of the child. So it's basically about parenting skills and child development.
Okay, thank you. I'll open it out to the audience if there are any questions from the audience. If there are no questions, Shalima, you can move on to the next speaker. Thank you, Dr. Komaran. I think.
Thank you. Thank you very much.
Okay, I have the privilege to invite Professor Rajesh Dikshit, who is the director of the Center for Cancer Epidemiology at the Tata Memorial Center, Mumbai, who's going to talk to us on Indian study of healthy aging and establishment of longitudinal cohort with biobank. Professor Dikshit, please.
Thanks, Chairman, for the introduction, and I thank the organizers for inviting me in this wonderful conference, which we are coming to know about the various cohorts which are ongoing in India. So basically, I'm talking about the two cohorts here. The one is like the individuals who comes to the Tata hospitals. They come from the various parts of the India. And when they come to the Tata hospitals, different parts of the Tata hospital, we have the Tata hospital in many centers, as you know. It's not only in Mumbai, it's in Mumbai, it's in Varanasi, it is in Guwahati. So we have the opportunity that the cancer patients are coming to these different centers, and along with them, many controls also comes in these hospitals. So there is some opportunity to get the information, detailed lifestyle and genetic information on these individuals who comes to the Tata hospital, and then do some risk factors association studies. So we have enrolled different common cancer pools who come to the different cancer hospitals of Tata Hospital. So we have the 10,000 controls so far collected with their blood samples. And then we have the individual cancer sites like gallbladder cancers, which is very common in India. We have the breast cancers. We are participating in confidence project on this, on the genomics part of it. The oral cavity and oropharyngeal cancers, which are again very common in India, and the lung cancers, non-smokers, which again very common in some parts of India. And all these case and controls have the very detailed lifestyle histories, including the obesity, including smoking, alcohol, past histories, oral hygiene, and etc. So it's a very big questionnaire. So very detailed lifestyle questionnaire is there. There is a blood sample, so it gives us chance to do some sequencing and the genotyping. And then there are tumor samples are also available on 10% of the cases. And all samples are stored in the automated biobank and also in the liquid nitrogens. And so far we have done the genome-wide association studies. Some of them are published already. So we have done the buccal mucosa cancer case control studies with 4,000 cases in control. It is published in eBiomedicine. It's getting published. Lung cancer non-smoker case control studies. We have the gallbladder case control studies, which is already published in the Lancet Oncology. And we have the Isha longitudinal cohort studies, for which I will discuss in detail. And the breast cancer case control studies, on which we have done the genotyping on 6,000 cases, and it is also the part of the Confluence Consortium. So here is just very briefly give you the results of the interesting finding from the buccal mucosa GWAS, that you see some of the hits in the new loci, which were not seen in the European population, where they don't have the buccal mucosa cancers, but they have the anterior tongue as a major part of the cancers in their areas. So it's useful to have the Indian specific GWAS studies. We also found the Notch1 as one of the important germline mutation in the in Indian data set. So we know the utility of Notch1 in the somatic mutations, but this is for the first time we came across that even the germline variants in the Notch1 is basically affecting the buccal mucosa cancer risk. And one of the interesting thing that it comes is a gene environmental interactions, that if you are tobacco chewers and if you have the high genetic risk score, polygenic score, then you develop a cancer, buccal mucosa cancer, almost 10 years earlier. So compared to those, if you are similarly chewing, but if you have low genetic score, then you still get the cancers, but then you get cancer 10 years later. So you gain the 10 years of life if you have the less genetic susceptibility. So environmental factors, lifestyle factors are important, but the genetic factors are also playing their thing. And this is the genetic heterogeneity among those 10,000 controls populations, that the different parts of the India have the different genetic architectures, and this needs to be accounted in any of the genetic studies which we will do in the future. And we also try to compare correlate the genetic correlation between the populations. So we had the Taiwan, Europe, North America, and Hispanic data sets. So there was some correlations with the Europeans, but very less correlations with Taiwan and even with the North American population. So globally also, the genomic correlations between India and other population is closer to the European population ancestry, but less closer to many other populations. And this is the genome-wide studies from the gallbladder cancers, where we found the ABCB1 and ABCB4 transporter genes. They are responsible to increase the risk of the gallbladder cancer. And this is already published 3 or 4 years back. And then we also did some sequencing, and some of this is under publication, so I'm not presenting the results here, but the breast cancers, we have done 1152 targeted sequencing, exome sequencing, along with the GWAS studies, whole genome sequencing of gallbladder tumor and the blood samples paired. It's on the 60x coverage. And the cohort, as I will talk, that we have done the whole genome sequencing on almost 2,000 individuals. And then we are also doing the gut microbiome on the limited numbers of the samples. So these are the basic cohorts which are coming from the patient to the Tata hospital at different points of the time. And then I'm talking more about the longitudinal cohort, which is, we go to the house-to-house surveys, and we are doing it mainly in the Barshi. And now we have collaborations with the Goa. The Goa state government has collaborated with Tata Hospital to have the cohorts in the Goa. And we have the Tata Hospital in Varanasi, so we have also started, piloted it in the Varanasi. But the main part of the cohort, which is we have done so far in the last 10 years, is in the Barshi, and Goa is being started. So I will present most of the things which is related to the Barshi. So we know that what is the need of the cohort? We know that that disease burden is very well documented in India because of the lot of surveys, cross-sectional surveys are there, cancer registries are there, but we still don't know the environmental and genetic risk factors in India. That is, I think, relatively not very well explained, that what are the risk factors which are unique to the India. And we know that burden of disease is different in India, and therefore there is a heterogeneity in the risk factors that must be accounted for. And so it's important that we need a population-based cohorts in different parts of the India, like UK Biobank, Kaduri China Biobank, the Mexican City Biobank. So these biobanks are there, which have given so enormous amount of the data so far, and it has increased our understanding in the disease causation. So we believe that if you have the similar kind of cohort in India, then we will have some understanding which would be different. So what we have done so far, that we started this cohort study, which is called as the ISHA, Indian Study of Healthy Aging, 10 years back. And we targeted the recruitment of 500,000 individuals from the Barshi, Guwahati, and Sangrur in Punjab. And so far, we have enrolled 200,000 individuals in the age group of 30 to 69 from one study centers. So there is a small pro forma, and on the small questionnaires, we have enrolled 200,000 individuals. And then we got the detailed lifestyle information. And the blood samples are collected and stored in the automated biobank. And so 80,000 is collected from Barshi, 10,000 are collected from Varanasi, and we have the automated biobank where the blood samples are stored. And then we did a small sub-studies to understand the very specific questions to address the specific question. And in the 20,000 individuals, and we are working on that. I will show some of the results of that sub-studies. We are measuring the obesity, basically in that thing using DEXA. We are doing the mental health. We are using the SKEED questionnaire for the addressing mental health. We are using the physical activity by using the wearable in the hands. So more specific exposure and smaller subset of the cohort. So 20,000 cohorts would be followed up for the additional details. And so we collect the repeat blood samples. When they come for the sub-studies, we collect the blood samples, and we are additionally collecting the urine samples, and sometime when it is possible, the stool samples are also collected. So the repeat measurement of obesity is done at 4 different points of the time. So what we have done so far in these data sets which was available, so we have sequenced 2,000 samples already, whole genome sequencing. We are developing a reference panel for imputations, and we have done the biochemical analysis on the subsamples. And the goal is to do the 40,000 GWAS on 40,000 individuals with the imputation, which is based on the Barshi cohort studies. And we are following them up and doing the linkages with the help of the verbal autopsy. And so far, we have encountered 4,000 deaths so far in this cohort. So what are the key features of this cohort? It's a laptop-based cohort, so all information is collected by the laptop. We have established infrastructure. There is a completely automated biobank, which can store up to 3 million samples. It's a Lyconix infrastructure. It's very similar to the UK Biobank. We work very closely with the UK Biobank, and we have the collaborators and the collaborations with the scientists in the UK Biobank and also in the Oxford universities. So some part of the study is also funded by the UK Biobank and the Oxford University thing. We have established the molecular epidemiology laboratories at Tata Hospital in our Center for Cancer Epidemiology, so that we have the capacity of doing whole genome sequencing. We can do the heavy metals detections. We can do shotgun metagenomics. And of course, the GWAS and the bioanalyzers, all things are there where we can do all this analysis of the biosamples which are collected. We have established the IT infrastructure for analyzing the large genomic data set. So the data is stored and very swiftly analyzed. And we have started the academic programs to develop a skilled manpower, because this is a very unique manpower which is trained in epidemiology as well as in the molecular biological techniques and their analysis. So it's not ready-madely available. So we are training those manpower also. We are hosting the graduate and many postgraduate students from the US, UK, and many parts of the world are coming to us. They stay with us for 3 months or 6 months, and we are hosting them. And we have also established a lot of international collaboration for this study. So what we have measured so far, so we have measured blood pressure 3 times, height, because to call an individual as a hypertension, I think my cardiologist will agree that you don't need one time hypertension. It has to be at different points of time, has to be collected. So we are collecting 3 times blood pressure, 3 times height, weight, waist to hip ratio is collected 1 time, blood collection is collected 2 times, so 1 time on all, and on sub-studies collecting again. Urine collection, we are collecting 1 time. We are also collected nail specimen for the pesticide analysis in particular. Body fat for the obesity, we have 1 time Tanita, and 2 times sub-studies we are doing Tanita and DEXA. So basically 3 points of time we have collected the body fat. A stool we have collected on the subsamples. Physical activity we are measuring through the wearable devices. And for mental health, we are using the PHQ-9 and then SKEED questionnaire version 5. And this is a baseline. The design is like that. We first do the enumeration and the questionnaire, then the setup clinic in that area. So those who are enumerated, they are called up to attend that smaller clinic, which could be in the school, it could be in some community centers. It's the temporary clinic where you collect the blood samples, measure the blood pressures, measure the grip strength, and pulmonary function test is also done. And we resurvey this cohort for up to the 3 years. And we have done 3 years of follow-up on some of the participants. And we have got so far 324 cardiac events, 208 strokes, 255 kidney diseases, and now 300 cancers. It's 140, but now I know that we have linked it to cancer registry, and around 300 cancer cases are there. So this is like a field structure, that how it is done. So there are 4 tehsil of the Barshi, and there is a principal investigators which is seated at Tata Hospital. Then there is one coordinators at the Barshi itself, and there are the team of 4 team, which has the lab technicians, surveyors, and team leader. So these together, they go in the field and collect the data. And when we set up the this thing, a clinic, then this is that we take the consent, and laptop-based interviews are done at home. We do the blood pressure, then we invite them for the clinics, and then we set up a clinic, basically, where they come, and then we do 5% resampling on some of the individuals to test that the information is correct or not. So these are the questionnaires. So what this questionnaire contains, it contains the demographical data, it contains the socioeconomics data, the general health-related behavior, and then it also contains health behavior, tobacco, chewing, alcohol. We have the very detailed food frequency questionnaire, which is developed based on the 24-hour recalls. Physical activity is collected. Then household composition is there. Then there are many physical measurements. I just discussed that. We collect the family history. We are collecting the sleeping and the mood. And then there is also reproductive history for the woman. So a large data is being collected on all these individuals. And this is like just to show you some of the photographs, that how we go house to house, and it's a laptop where the information is collected. So the information is collected online, basically, but because there is no internet, so what we do is the different surveyor goes to those houses, and the information is collected on the laptop in the evening, and this information is provided to the manager laptop from all these 3 investigators. And these investigators, this data is synchronized. And once the data is synchronized, both from the clinics and both from the field, then it is sent to the Tata Hospital, maybe same day or maybe the next day. So because the internet is not there in remote part, it's not working many times. So we collect the offline information, and then at office, it is synchronized and sent back to the Tata Hospital. And this is the health checkup in the clinics, how we do. We are doing a grip strength, blood pressure, anthropometry, bioimpedance using Tanita, lung functions, and then biosamples collections. And then the health report card is given to them. And then if there is anything, because we don't measure the cholesterol or anything immediately at that point of time, so we are not able to tell them, but we tell them about their obesity and blood pressure thing in the health checkup cards. Then the blood samples, they are collected, they are sent back to the Tata Hospital, and we have processed them within 24 hours. So we have the automated mechanism to aliquot them. They are aliquot into 4 different vials, into the Buffy-coat, into the plasma, and into the RBCs, and these aliquots are stored into the automated biobank for the longer time. So this is an automated biobank where the samples can be stored at -80 degrees centigrade. So all these vials are barcoded at the bottom, and they can be retrieved automatically because there is an automated retrieval options is there. And in this biobank, there is sufficient redundancy so that there is a light failure, there is a UPS failure, or there is a compressor shutdown, then all those things has to be maintained, because it's very important that when we are collecting the cohort samples, they need to be there for 20 years and 25 years or 30 years. And if you just have the tubes which don't have the proper barcoding, which you can't retrieve it properly after 20 years or 30 years, then it's going to be very difficult, because we are not talking about 1,000 or 10,000 samples, we are talking of 100,000 samples. So maybe, and that too after 20 years. So maybe none of them, us will be there. And so it should be designed in such a way that even after 20 years, you can retrieve the samples. So that's vision is there with this biobanking and storage of the samples. And the follow-up, there are different ways of doing follow-up. We have the cancer registry there in the Barshi, So it's our own registry. So we link it data passively with the cancer registry. We do the active follow-up by going house-to-house survey. We also do the follow-up using the phone calls. We also do the linkages with the death registers. So we go to the municipal corporation and see how many deaths have been occurred. Linkages with the Aadhaar card has been so far not possible, but we are collecting the information on Aadhaar card. So in future, like if Government of India agrees to provide that health events to this cohort, I think that should be the voice or message should go to the government that at least those bigger cohorts which are operating in India, they should get the information about the health status from the Aadhaar so that we can do the passive follow-up and we don't require to do the active follow-up. And this is just to summarize how many active follow-ups, so 10,000 active follow-ups in the last 2 years. We have done the mortality data collections and then cancer registries, how many cases, how we do it, and how much of resurveys has been done. So this is how because it's the most important thing that if you want to have the cohort, then how you are going to do the follow-up and how you are going to take the outcome. Because if you are not able to follow them up properly, and if there is a lot of dropouts after 5 years, after 10 years, then all of your efforts will go away. So it's very important that in beginning, we should take all the efforts so that all the data, all the individuals could be followed up. And just to show you the obesity, we are discussing a lot about obesity. So in the cohort, you can see that Isha, our Barshik, and the UK Biobank. So there is a clear pattern and clear distinguish between the obesity profile of Isha in India and the UK. So they are much more obese compared to our thing. And as was discussed earlier also, that abdominal obesity is much higher among Indians compared to the UK. And this has been published in International Journal of Epidemiology. Then in the resurvey, so far the goal is 20,000, and so far we have done the 8,000 almost. We are again collecting the blood samples. So we have the second blood samples from the same individuals after some 5 years. So I think this gives you some chance to study some biomarker, because some of them will develop some diseases in between. So that will allow you to study that kind of thing. We again collect the urine sample for the first time on all these individuals, and we are doing the DEXA scan for more detailed obesity measurement. So in the first phase, we are doing only Tanita machine for the anthropometry, but in the samples, we are doing the DEXA scan, and we are doing the gut microbiome. We have collected so far on 50 samples. We have done the short gut metagenomics, and we are doing on 150 samples. Stool has been collected, and the goal is to collect the 500 blood samples. We have done the biomarker on these sub studies, the urine and the serum studies, and we are doing the mental health resurveys using the SKEED questionnaire, much more detailed questionnaire in the SKEED. And then you can see some of the results of the biochemistry analysis, that cystatin C is much higher. In almost 64% individual shows the higher level of 64 cystatin C. And then there is another thing, is triglyceride is almost 50% of the individuals shows the very high value of the triglyceride. So I think these two, this is a rural India, so they don't have 30% of the high levels of the cholesterol, but the triglyceride levels are usually worrying. That why they should, so it's some food habits needs to be changed more. So context in the next 2 years is the enrollment on all the remaining individuals, 100,000 more, and we have 100,000 total blood samples already there, but now we want to have 100,000 more, and then linkages with the database. That's a very important thing, that how to do this. Outcome, how to measure the outcome, that's very interesting and important point, because in India, particularly in the rural India, the individuals die without proper cause of the death. And then if they die, we do the verbal autopsy. But verbal autopsy may not give you the very proper, precise, the cause of death information. And therefore, it's very important for us, even for other cohorts which we are maintaining, that how we are going to measure the outcome and how we are going to do the follow-up. That's the important thing. And then we have to set up a case cohort studies, like nested case control was discussed, but case cohort is another very good option. So we have set up one case cohort type of thing to study the air pollution. We have studied the sub-studies for measuring the obesity. So there could be some specific research question type studies within this larger cohort where you can do many more exposure measurement and do more proper outcome measurement. So these are the challenges, as I already mentioned, that health outcome adjudication, that how you confirm the causes of death, particularly in the rural cohorts, it's a very challenging. The linkages, we are more dependent on the active follow-up and the phone calls, but if there is some system, like we say the UK Biobank, but they have the facility to link it passively. So most of the time they are not doing the active follow-up, they are linking it passively. And so we need some passive mechanism. We have the mechanism in place, like Aadhaar is there. So, so that if the data are allowed to link, then it will save a lot of our time. And the active follow-up, we don't have to do the active follow-up. Of course, the funding, getting continuous funding support is always challenging, because to maintain this a large cohort, to keep collecting the blood samples, storage of the biobank, that itself is a huge cost. Even after maintaining of the biobank itself is a very difficult task, which cost you almost 80 lakhs rupees per year just to store the samples and handling all the problems that we are facing when you maintain the biobank. So the funding is required all the time. And to do sequencing and genotyping, of course, there is another kind of funding. We could do 2,000 whole genome sequencing with our funding, but we keep trying to apply to many funders. And the idea is like this, that there is a recruitment phase of 500,000. And once you do the 500,000, right now we have roughly 100,000, then you need to do the follow-up on all 500,000 for at least 3 years by some methods, active follow-up, passive follow-up. You do the data cleaning and everything, and then you do the data dissemination. So we are talking about that, how to share the data, but to share the data, you need something in your pocket. If your pocket is empty, you can't share with others. So you have to first fill up your pockets with some data, with some samples, with quality control is done, with some basic analysis is done, some sequencing, convert your samples into data, maybe do sequencing on all the samples or do the genotyping on all the samples, and then that genotyping data can be shared. I think that would be the ideal way of doing. That's what I think in our cohort. The other cohorts may also think in a similar way. And we will be open to the data dissemination with there would be a review protocol by the steering committee, and then there will be some approval from the directors, and then there will be assignment of scientists from CCE who will work along with that external scientist to work on the data, because we will understand our data much more better than others. So there will be some scientists which could be appointed to work with maybe Indian Statistical Institute. They can explore the data, but our one scientist will work with them. So this is what our planning is. Thank you very much.
So congratulations, Professor Dixit, for an excellent presentation, and to you and your team for building such a big cohort. We know all of your publications which have come from. So we can have questions, please.
So very interesting. Your one data on genetic correlation mode with European population compared to Taiwan or other Asian population. So any thoughts on that? Any particular population structure in your cohort itself that explains that?
Yeah, there are, I think, population structure within India is also different. And of course, out of India, the Europeans are most closely, as is shown in the slide, it is also published, that Europeans are most closer. Why it is, though, we don't, of course, they come from the different ancestry. And one particular example, for example, is the LDH2. So the prevalence of LDH2 SNPs, which is particularly important for the alcohol, is 27% in the European, 17% in Taiwan, and that's only 6% in India. So it means, and therefore the LDH2 gene was not significant in our jivas. But alcohol is very strongly risk factor in buccal mucosa cancer when we do the questionnaire-based analysis. So it means that there are some genes other than LDH2 which might be important for the Indian population. So this is how there are
probably your cohort has more ancestral North Indian than any other population groups.
Other?
Ancestral North Indians or than any other populations group. That might explain this high correlation with European compared to the Asian population.
Maybe because we don't have the South Indians in this thing, of course. Yeah, that could be one of the reasons. Yeah.
Yes, I have one more here.
Yeah.
So, what are the healthy clinical parameters for a healthy aging? Since you are working on healthy population like aging populations, what could be the clinical parameters that can be controlled for a healthy aging?
Yeah, so of course, the physical activity is one of the thing. It's I can just guess. There is no data has come from my cohort study which I can answer. So what I can see based on the different cohort, but there is no data from side that what are the parameters for the healthy aging.
You would not have been standing here.
Yeah, I know the answer. Yeah, that's what I said, that I don't have the answer from my cohort. I can just give you the general answer from other studies. Yeah.
So excellent talk, and just what are your views? Why, like, is it a ethically good thing to go for a DEXA in a normative population?
Yeah, DEXA is an important thing because it's we talk about obesity, but it's not only the obesity as such. It could be the obesity in different parts of the body, whether it's abdominal obesity is important, it's arm size is important, and many studies have shown that even for the same BMI, you have the different.
No, that is very well known analysis per literature, but like you were doing already Tanita and all. So what is the difference you see, or what is the agreement you see between these body impedance analysis based versus DEXA, and like, do I need to expose a normal population to radiation?
Yeah, so now because we have done some correlation, so as far as abdominal obesity concerned, there is not much difference. There is a very good correlation between the DEXA and the Tanita machine. So that's why we don't have to do on all 100,000 the DEXA. And so therefore we are doing it only on 20,000 individuals on the sub studies. But what DEXA gives, not only the obesity, but it also talks about the osteoporosis and many other conditions which could also be studied. And it also gives you the idea about the distribution of obesity in the various parts of the body, because we are doing the whole DEXA scan. So whether the distribution of the obesity, the fat in the body, has some relations with the disease, that the question which is still unknown, even in the European population. So I think this the DEXA, that's our target. That whether the distribution, it's only we know about abdominal obesity, but whether the distribution of the fat in the different parts of the body also affects the disease outcome. That could be studied with this type of thing.
Thank you.
Dr. Dixit, I just have a trivial question here on the dais.
Okay.
I just saw in your list of physical characteristics that you're collecting length of index and ring fingers?
We are collecting the 2 nails, yeah.
No, index and ring.
Yeah, we are collecting that.
What's I've never seen that before.
2 and 4, yeah, because we have done now just one paper in case control study in the breast cancer, that this digital ratio, they are predicting the breast cancer, because the hormonal level at the womb can determine the length of second and fourth finger. So that's the hypothesis, basically, the basic biological hypothesis, that the estrogen level at the time of the womb that reflects the length of second and the fourth digit ratio. And therefore we have collected this. And in the case control studies, it's not, as you say, it was just association, statistical association, confusing, but still because, but we got some association there in the ratio of 2 and 4, which we'll publish hopefully in the scientific report in 2 or 3 months.
Thank you, Professor Dixit. Thank you.
So we come to the last speaker of the evening. No, 2 more? Okay, sorry. So next is Dr. Purnima Prabhakaran. Dr. Purnima is the Director, Center for Health Analytics Research and Trends at Ashoka University. She will talk about GeoHealth India, leveraging interdigitating cohorts for exposome research. Dr. Purnima.
Thank you, Chairs. Good afternoon, everyone. Again, thank you, organizers, Dr. Shantanu, IMT team, and the audience for sitting here patiently. It's a challenge actually being the penultimate speaker, but like our cricket matches where the penultimate overs are often the most exciting, I'll promise I'll try and keep this a little exciting. At least I hope that you'll get excited. Reason being, I think we've spent 2 days talking about a lot of different cohorts. I think at last count, over 20 different cohorts being presented. And the idea was to eventually maybe bring all of these cohorts together. And what I will present here is actually an example of exactly just that through our work, but also bringing in not just the health outcomes, a lot of health outcomes have been discussed over the last 2 days, but bringing in exposure assessment, which is, I think, another emerging determinant of health and disease, and it's important. I think I heard mention of air pollution a couple of times in a couple of cohorts. That's okay. So I'm going to be presenting to you work under the India GeoHealth Hub. And just to give a little bit of context, I did mention that I will talk about environmental health, not least because it's still a very nascent domain of public health. And I think it was mentioned by Dr. Rajesh Dixit that we still haven't understood or studied enough the environmental determinants of health. And I think it's important because we are among the most vulnerable countries to the environmental determinants of health. And if you go by the global burden of disease estimates, a quarter of the global burden of disease is due to environmental determinants. And as we know, most of these are modifiable risk factors. And when I talk about environmental determinants, it's things like air pollution, climate change, water sanitation, hygiene, exposure to heavy metals, organic contaminants in food and water. And really, environmental health also should talk about what the health system response is. So what did we do? We did some research. We also focused a lot on capacity building because of the fact that this has remained still a nascent teaching discipline as well in a lot of the MPH courses across India. We've tried to give some policy inputs and of course advocate for more and more conversations on environmental determinants. And my work actually is work that I've done both with my team, both at the Center for Chronic Disease Control and at the Ashoka Center for Health Analytics Research and Trends. And you heard about the CARS cohort yesterday from Dr. Sailesh Mohan and Dr. Shivani. And this portfolio of work in environmental health actually leverages long-standing cohorts of our own, CARS and Uday, both of which Dr. Mohan mentioned yesterday. But what about others? And this is exactly mirroring the conversation that we are trying to do for the last 2 days. How can we bring cohorts together? We also have leveraged biorepositories, our own, but others as well. And we have added extra efforts in terms of building the domain of exposure assessment for things like air pollution, but also temperature. As a country, and especially for people who have come from Delhi, this is the season. Air pollution, but also increasingly India's become the onslaught of heat waves. So we have started working on both air pollution as well as heat through our in-house exposure assessment efforts. We've also developed protocols for chemical exposures, and we have used what we have heard just now in the afternoon, a life course approach. And how we have done that is a unique approach using interdigitating cohorts. So what is that? Just to remind our people who were not there yesterday, the CARS cohort is a state-of-the-art population-based cohort that was set up in 2010 in 2 cities in Delhi and Chennai. It was set up with the intention of studying cardiometabolic disease in adults in these 2 cities. It's over 20,000 adults aged over 20 years with nearly 15 years of follow-up and still ongoing. So there's a lot of data that has been collected, intensively phenotyped. Biomarkers have been collected. Several aliquots of serum, plasma, buffy coat urine have all been stored and examined over the years. And Just to say that in the timeline of things, extensive data was collected since 2010, but leveraging this cohort, we were able to establish what is today known as the GeoHealth Hub. The GeoHealth projects were funded by NIH and in 2016, and we were one of 7 that were funded around the world. So I think we were very fortunate in terms of time, because for those of us who live in the northern part of the country, 2016, we remember as the airpocalypse year. It was the worst air pollution that anyone had experienced. It's only getting worse over time, and we were fortunate to get this funding in that same year. And we had thought ahead and decided that maybe we should leverage our cohort to start examining things like air pollution. So this is the several time points over which data was collected in this cohort. Over time, we have added different objectives. There was some conversation that happened earlier about adding new objectives. CARS cohort has now gone beyond cardiometabolic risk factors to add things like aging, brain research, and I think this became an excellent platform for us to actually investigate this exposure, air pollution. I just want to introduce the term exposomics over here. It's probably something that we all have been doing for a long time. And the reason why I bring it over here is it's a term that's been used for 20 years in the US and in Europe. There are networks, International Human Exposome Network in the US, and there's REACH network in the European countries. And it was funnily so, only in May this year, that they tried bringing the global South, as they call it, into this conversation and saying that we need to bring people together for a global human exposome project on the lines of the global human genome project. It was kind of funny to me in a way, because I thought what we all are doing in our cohort studies is really this. We are bringing together personal exposures, environmental exposures, lifestyle exposures, and here was this effort at a global level saying the global South, the developing countries are missing. So I'm like really wanting to bring this concept of exposomics to India, and it's about really moving from one exposure, one outcome, to multiple exposures and multiple outcomes. This is really exposomics. We do it in a way by adjusting for confounders, but actually examining each exposure and outcome is really the concept of exposome. It was introduced in 2005, 20 years ago, by this epidemiologist called Chris Wild. So just hold that thought there. Coming back to India GeoHealth Hub, it's a fully integrated research and training program funded in 2016. We had a 5-year grant till 2021, and we're fortunate to be one of the GeoHealth hubs that got repeated funding in 2022. So we are in 2022 to 27 funding. And we had 2 important verticals, both research, where we thought that we should focus our efforts on advancing the science of air pollution epidemiology to investigate impacts on cardiometabolic outcomes for India, contextualized homegrown evidence, because as we all know, as the winter session of Parliament is going to start soon, year after year the question is asked, where is the evidence from India? Why are you giving us global burden of estimates disease when we're talking about air pollution and impacts on health? So here was the effort to fill that gap and address that question and build our own repository of evidence on the impacts of air pollution on health, starting with cardiometabolic diseases. We also focused efforts on training. And the important gap that we started to fill when we started out in 2016 was to develop an exposure assessment model for air pollution. Those of you who are familiar with this term, how do we measure air pollution back in time, may know that pollution control boards in every state put up monitors around the cities to measure air pollution. And this distribution of monitors is not equal across the country. At least it wasn't back in 2016. Delhi had 20 monitors, where there were some parts of the country had 0 monitors. So no surprise that Delhi's air pollution gets talked about so much, but not to discount the levels of pollution we have in Delhi. So here was the effort first to develop our own model to measure exposure to air pollution, taking cognizance of the fact that air pollution is due to a number of different particles and gases in the air, but also it is modified by things like temperature, humidity, and a whole lot of other determinants. So while there are institutions like, I think, IIT Delhi, which has developed an exposure model for air pollution based on satellite data, this model is called an ensemble model. It's only been done for the US, I think Mexico and Israel in the past, was developed for India by a team starting for these two cities, taking into account a whole lot of predictors, not just the data from the pollution monitors, but also the satellite data. We took emission inventories that was developed by IIT Mumbai, meteorological data, which is temperature, humidity, wind speed, everything that affects pollution, and land use data. I think we had the director of CRRI here. So land use data included road networks, position of power plants, land classification data, and in other things like population density. So multiple variables, that's why it's called an ensemble model. And what we were able to develop is an exposure model, metrics for the city of Delhi and for the city of Chennai from 2010 to 2016. And it is done through machine learning methods. And what you see over here, this is Delhi on the side, and that is Chennai, is the daily exposure to particulate matter. PM 2.5, it is a pollutant in the air, which is really small, 2.5 microns in diameter. And the one that is the important culprit for impacts on health, because we breathe it and it reaches the lungs, but also crosses over to the bloodstream and causes a range of effects on every organ system in the body. Intuitively, we think if we are breathing polluted air, it's only respiratory effects, but it's beyond that. There are effects on a whole lot of organ systems from breathing polluted air. So this was, you can see the model changing color. The red and orange is actually, the orange and red is actually the winter months. So this had a really high prediction accuracy. And with this model, long story short, we had our own model, our cohort, the CARS cohort, with a lot of phenotype data. We had hypertension data, fasting glucose, lipids. We were gathering mortality data. So we were able to analyze the links between exposure to PM 2.5 and a lot of these outcomes: hypertension, diabetes, lipids, and mortality, to name a few. And I'll give an example of the message, for example, from the first one, the air pollution and hypertension. What we were able to show is that for every 25 micrograms increase in the PM 2.5 levels in Delhi, in our study population, the blood pressure increased by 3 to 5 millimeters of mercury. At an individual level, I mean, I have cardiologists sitting here, maybe it's not too much, but at the population level, the message that we gave to policymakers is, if you are able to reduce the Delhi pollution levels by 25 micrograms at a population level, from 100, average of 100, 125 is what we see in Delhi. If you can make it 75, the prevalence of hypertension in Delhi can be reduced by 10 to 15%. Now that's a whopping statistic, because probably you will move away that many people from the health system accessing care for hypertension. So that's the kind of narrative that we have used with policymakers, and we have messages similarly for type 2 diabetes, lipid levels, and mortality as well. So what next? So we had gained the experience working with two cities, and we were fortunate, even in terms of funding, to get more funding from, this time from the FORMAS group, which is the Swedish research agency, and we were able to scale up this effort to the entire country. So starting with Delhi, Chennai, with the additional funding, we scaled up this model to the entire country. So today we have exposure to PM 2.5 at 1 square kilometer resolution daily. From 2010 to 2021, we are updating it to 2024. And what we were able to do is relate it to a whole lot of outcomes. I already showed you what we did with hypertension and diabetes, but we are now able to do many more analysis, which includes mortality. We have got both the stroke and the cancer registry data now, and we are this is work in progress. We are trying to do the analysis for that. And any other health outcomes data sets can now be leveraged, collected anywhere in the country in this time period, to look at the associations with exposure to PM 2.5. That is an example, that is a graphic of the national model that we have developed for PM 2.5. And you can see, you see it in the news, the Indo-Gangetic plain is where it's worse. The pollution levels are the worst. And this is 2008 to 2020 that I've shown here, but this model is now available and accessible to researchers who would like to link PM 2.5 to any health outcomes that you have, provided you have the geocodes of the participants. What next? Again, we finished moving from 2 cities to the country, but we wanted to move to other exposures, and therefore we also leveraged this resource and platform to develop a model for temperature. So today, we also have a national model for the same time period for exposure to temperature for the whole country at 1 square kilometer resolution. So participants anywhere in the world, you can look at the association. And of course, we often tend to look at silos. We'll only look at, even when the outcomes, we tend to look at outcomes separately, but even in the exposures, if you're exposed to air pollution, you can also be exposed to heat. So looking at the interaction between heat and air pollution is another example. I wanted to move on to where we actually looked at pooling our resources to even extend a hand to other cohorts and bring them into this consortium. So our next round of funding, the next 5 years, we had this funding from 2022. We tried to address further gaps. So what were the further gaps? What are the existing gaps was? All of us were focusing on the particle pollutant, PM2.5. But it is possible that this particle also has certain constituents. It could be gases, it could be metals. And so what is this specific characteristic in terms of this? When you speciation, go into speciation of the pollutants, what are the different particles? Because it may be that these particles, heavy metals, for example, could have different health outcomes. So the other information that we wanted to gather was, we were working only with adult cohorts because that was the resource we had. But what about other life stages? Children, pregnant women, elderly. So this is where we focused our effort for the next round of funding. The GeoHealth HEALS is the health exposures across life. I think it was the acronym. So we decided to expand not just from PM2.5 and temperature, but also bring in nitrogen dioxide, comes from transport, and ozone, as well as temperature, to examine the impacts on a number of different cohorts. We brought into our partnership, our consortium, cohorts that had collected data for different things across the country. And we did it strategically to actually cover the life stages, the life course approach. So we had this, talking from this side, pregnant women and children. This was the life cohort in the Share Medicity hospitals in Hyderabad, and the GARP cohort, which was set up in Bikaner, a hospital-based pregnancy cohort. Children also from the life and GARP cohort. Now you can see, I'm not reading out everything, but these cohorts were set up for certain purposes. To examine those outcomes, you can see sample sizes up to 3,000 and more in some of these. You heard Dr. Yajnik earlier. He is also part of this effort. So he brings in the PMNS study with the adolescents. We have our own adult cohorts, CARS and Uday, which have cardiometabolic risk factors and more. We are going to get all the brain markers and stuff. And we also have older adults in this. So the end of the life stages, the older adults, through a MILES cohort, which is also from the Share Medicity Hospital. But in our own CARS and Uday, because our cohort participants are aging, the one gap that we had to fill with primary data was to collect elderly data from the CARS and Uday cohorts. But all of these other partners came together with a common objective of working with us to examine the association of all these environmental factors with their health outcomes. So this was a partnership that we established, and I'm just walking you through quickly all the different exposure assessments that we had. This is my colleague Siddharth Mandal, who was responsible for developing that model. So we are expanding from PM2.5 and to NOx as well as ozone through our spatiotemporal models. 1 square kilometer resolution, I just wanted to share, we are downscaling it further to 200 meters. So that accurate exposure in terms of the spatial resolution. We're also going to do speciation, as in we are going to collect data by putting our own air pollution monitors in these sites, taking the filters and analyzing them for their constituent components. And then some subsample of these participants will also undergo personal exposure monitoring, and I'll tell you a little bit about that. So my colleague Prashant Rajput is involved in the ambient monitoring and speciation. So he goes down to all these sites, our study sites, and puts up these monitors. These are called MFCs, mass flow controllers, and we get the filters after putting these up for a week, and in both seasons, in summer and winter, because we are aware that the pollution impacts are different at the different seasons. So we are collecting in these sites the filters and transferring them to IIT Kanpur. So another collaboration there with IIT Kanpur, we are able to analyze our filters for example, the mass of carbon and the heavy metals as well. These results are not published, but I just wanted to show, as expected, Delhi, Sonipat in Haryana, highest levels of PM 2.5, but also the organic carbon, elemental carbon, and all the different metals. It's still work in progress. The personal exposure assessment, this is just to validate what we do in terms of the modeling, to take a sample of people in these sites and actually give them a backpack in which they carry an air pollution monitor as well as a actimeter. So you can record their activity for the 24 hours, again done in 2 seasons. Very, very resource intensive, but really gratifying when you get these results. So what they do is carry this backpack with the air pollution monitor with the GPS placed in it. And for 24 hours, they carry this. There's a tube that actually monitors their air pollution levels. The data comes to us centrally. So this is done by my colleague, Dr. Jyoti Menon, and she's an environmental engineer. So my team, my team is very interdisciplinary because it requires so many different specialists to do this work. So post-monitoring, they also collect data using a questionnaire, sources of exposure, cooking, moving around, and where you have been over the 24 hours. All that information is collected with very stringent QA/QC protocols. And in terms of the health outcome assessments, I told you the cohorts that came to us in this collaboration already had their health outcome information, but we added, and Gagandeep in my team is leading this, added additional data collection for the elderly cohort, because that was something that was still missing. So what I wanted to bring back to you is this concept of interdigitating cohorts. So bringing together cohorts in a partnership where you are covering the entire life course, both retrospectively and prospectively, using their data. And like I mentioned, we have the life and GARB cohort contributing to pregnancy and neonatal and child outcomes. We have Dr. Yajnik's Pune maternal nutrition study giving us the adolescent data, Kars and Uday and Miles data giving both the adult and elderly data. So in the interest of time, I'll quickly just go through what we did with the elderly people. So we did cognitive decline, muscle strength, frailty index, a number of different tools were used, and we had to collect this in our own Kars and Uday because that is that work that we hadn't done yet, but we wanted to fill that gap, and we recruited our own participants to do these measurements, and nearly 8,000 people have contributed to this. It gave us urban-rural geographic difference, north and south, urban-rural in the Uday cohort, and as well as gender differences. We had almost equal distribution of males and females, so we have a whole lot of outcomes measured in the elderly in the other end of the life stages as well. So Uday gives rural and urban, and I will not go through these results, but this is all data that is coming out from our work. So physical measures in the elderly, frailty index, cognitive impairment, and this is an important one that I wanted to show. So here is a graphic representation of how we have brought these cohorts in the interdigitating approach. So in the timeline of things, PMNS actually was set up early. So they are now adolescents. We have the live cohort and the GARB cohort, which are contributed, which are set up in later in time, but they have the children and adolescents. And you have the Kars and Uday and Miles, which have given us the adult data. So several different cohorts coming together, giving us their data, and we are going to be able to analyze air pollution, temperature, nitrogen dioxide, ozone, and account for all the confounding factors, which all of these people have already collected. So it's going to be a rich output in terms of the environmental determinants of health across the life course. I wanted to say a little bit about the training activities, because I said at the beginning, people to do this kind of research are scarce. We did a scoping of this exercise. There are people and colleges that are teaching environmental sciences. There are a lot of, nearly 100 at last count, teaching MPH courses. But environmental sciences and public health coming together as environmental health sciences is something which is still lacking. And we tried to fill that gap by doing our own capacity building through a number of different things. We conducted short courses. Initially, we used to do this only in Delhi, but we went around the country last year conducting courses in ICMR institutes, in the Swaminathan Foundation in Chennai, different topics, and these courses were conducted with our collaborators from the Harvard School of Public Health. We also had masters and DRPH. So we built this kind of capacity building into our grant application. So capacity building was at the core of what we did, and just a snapshot of the number of courses that we have conducted, over 13 courses in the last 1 year, with almost 400 participants trained, from introduction to air pollution, environmental health and air pollution epidemiology, to statistical methods, to endocrine disruptors, climate change and health, heavy metals and health, a whole lot, socio-environmental determinants of health. So it's a whole lot of different aspects that will feed into this space of work in the coming years. Pictures from those training workshops. I want to close by saying thank you for all the partnerships that we've had over the years. The CARS cohort was a collaboration with the Emory University. GeoHealth was with the Harvard School of Public Health. But the Stockholm Karolinska Institute, which got the funding for the national model, and a whole lot of other national as well as international institutions that contributed to this effort over the years. A lot of publications that have come out of this work. But I just wanted to, Sir Dr. Shantanu said, say something about data sharing. So I actually had to add these slides last night. So I just want to say that, we've talked so much about data sharing, confidentiality, stringent, rigorous procedures when you're this term federated stuff, Every collaboration within this consortium involved a stringent MOU where we agreed on certain things. So data sharing, confidentiality, who still owns the data, but you're coming together for a common purpose. So we were very careful. I'm not again going to read all this. I'm happy for you all to share the slides, but data sharing, that shared data will be solely used for the purpose that we put in the agreement. If anything beyond that, then we can talk. So that's the understanding that we start with, because all of us understand cohort studies are the most resource intensive study design. So people have put several years of their lives writing grants, getting funding, and doing this work. So if we are going to just get their data and do some analysis, but helping them by giving our model, which was 3 years in the making, I think people understand that it is for a common public good. So our data sharing and access, confidentiality and data protection, lot of clauses that we have carefully thought through, put into our MOUs, and I think that's probably there. So how we do the data management. So all of this is written in our agreements with these partners. So that's it really. And of course, publications have their own intellectual property rights. We give due authorship to all the partners who are involved. I think the key takeaways here is we don't have to set up cohorts and spend 3 decades of our life doing cohorts and stopping there. We can work together, leverage the strength of existing cohorts, establish partnerships for purpose. You will be driving the frontiers of exposome research in India. I don't know why people think that we haven't done this kind of research in India. All of us are doing it. We just didn't call it exposomics research. Of course, this work from our group actually gives insights into a lot of environmental determinants of health and disease, and it's establishing a strong evidence base, I believe, if there are listeners, to feed into programs and policies in India. And yes, closing with acknowledgements to all the individuals, institutions, and partners who were involved in this work. Thank you.
Thank you, Dr. Purnima. As promised, you made it interesting. So we'll open for questions.
Yeah, it was a very exciting talk, seriously. Everybody was awake, though it was the last one. Just one question. You also mentioned briefly about temperature and heat waves. So how are you measuring the exposure in that? Is it dry bulb or WBGT that you'll be using?
Oh, it's a model. So similar to the PM 2.5 model, we have developed the model for temperature. So there is data that similar machine learning tools, we've got the satellite data, and we've also got whatever ground data that we can get. meteorological variables, everything goes into this model, the same ensemble model that we did for PM 2.5. In studies that we will go into the ground to do, we will actually validate it by putting our own sensors maybe.
Okay,
But this is a model which has like over 90%.
So that's all dry bulb, because generally that's the dry bulb data that is coming for heat. So WBGT is something very interesting where people are only doing it for some specific studies. So, but that is the real data, which it's near to the.
It's not even widely distributed. Temperature monitoring, it's usually in the airports that monitor, or there are few people who put it up for research purposes. Monitors are less, they're sparse compared to even our air pollution monitors today.
Thank you. Thank you.
So while we wait for any other questions, I just was curious as to how you said that your model, the model that you developed was 80% accurate. So what was the gold standard? What did you measure it against?
So against the monitoring data. So you have ground monitors. So pollution control.
Yours is much more
granular,
high resolution than what is available, right? So how do you?
So I think it's, I may not be giving you the right answer, but it is this, there is satellite data which has very fine resolution as well. So there's satellite data, and then the model data can be also validated against that. But we in our studies are putting our own ground monitors and doing the co-location.
That's in the future, but
Yeah.
you showed that 80%. So I was just curious as to how you measured that. So
I think it's against the other models that have, I mean, there are no other models that have used this technique in India, but I think satellite data has a very fine resolution. So most people are depending on satellite data.
But your model also includes
Satellite data plus all of these other variables. So I mean, I can ask the person who did the work modeling, but I think the validation is.
And I guess the other important question is, these are all ecological data, right? It is not individual patient, individual person related data. So you have to correlate, you assume that what you find in the environment is what the person is exposed to. I mean, that assumption.
The thing is, for most of this data, we have the geocodes of the individuals. Addresses, and we actually are geocoding also all the data, even the cancer and stroke registry data that we are getting. We're actually doing the GIS resolution, and we are going to get the geocodes. So we'll do it as fine as possible for the attribution. So that's where, where people are not going to give us the geocodes, I will not mention the institute, but we were looking, I've spent 18 months trying to get a nationally collected data for a specific health outcome. They were resistant to giving us the geocodes. So in that case, you can bring it up to taluk level or district level and have it at a different resolution, because confidentiality stuff, so they don't want to.
Thank you. Are there any more questions? Thank you, Dr. Purnima.
Thank you.
Okay, we now come to the last talk of this session. So may I invite Dr. Neeraj Kumar Das, who's the Chief General Manager, Medical Services and Head of Department at Oil Hospital. And he's going to talk to us on energy, environment, and health, Oil India's integrated approach to sustainable well-being.
आप डाउन कैसे करें? Yeah. Good evening, everybody. Respected chairpersons, esteemed delegates, faculties, organizers. I'm here representing Oil India. Regarding Oil India, it is a E&P company, exploration and production of crude oil. So you know the crude oil is a fossil fuel. So there is a lot of environmental pollution which indirectly affect the community health. But Oil India is dedicated its full energy to reduce the pollution, and to reduce the effect on the health. So regarding our company, it is a 65 years heritage of Maharatna Company 2023 and sustainability focused with clear path net zero 2024, and India's target is 2070. In this regard, Oil India CMD Dr. Ranjit Raut has signed MOU on 21st April 2023 with CSIR, and the main focus point hydrocarbon exploration and upstream downstream operation, renewable battery storage, green biogen, etc. The MOU marks a strategic step towards the integrating science, technology, sustainability of the energy future. So this is to be the leading future-ready integrated energy company committed to sustainable energy, securing the India through performance excellence. The mission pillars are delivery energy, responsibility, protect the environment and ecosystem, promote employee and community health, and drive innovation and green transition. So this way we try to align energy, environment and health, reliable, affordable energy for India's growth, renewable solar, green, hydrogen, biogas, renovation and R&D partnership with CSIR that we have already signed MOU. Regarding environment, reducing emission and conserving natural resources, bioremediation, waste and water management, biodiversity and climate resilience. Health, comprehensive healthcare via 200 bedded of central hospital and satellite hospitals, periodic health assessment, CSR-based health outreach, and rural health awareness program. This we can skip. So this is our one project, oil, Basundhara. You can look at before how during that exploration time, how that deforestation occur, and we have converted with the help that forestation part. Established bamboo stem of 2 hectare and Dihingpatka area. That was before, and that's the after. So this is one during the production time how the environment was affected, and other side you can see because of our ES team and RD team proaction that again the reforestation has occurred. This energy for sustainable and collaboration, exploration of Himalaya hot spring for microbes and biohydrogen production capabilities. Our R&D teams goes collected microbes, and that microbes is used to reduce the pollutant in soil and water. So this is how isolation of biohydrogen producing bacteria strain from water sample of areas, hot spring in Uttarakhand, and this is used to reduce and remove the effect of crude oil on the soil, water. So environment and health, the environment impact assessment and statutory clearance for project. Zero discharge policy in drilling operation, treatment of produced water and sludge, ETP and produced water treatment unit ensure the discharge with CPCB and NNAQ standard, continuous monitoring, air, water, soil, noise via accredited lab result within norms, rainwater harvesting, green belt development and biodiversity conversion near operational area, tree plantation drive and green cover expansion for carbon sequestration, circular economy practice, reuse, resource recovery, industry by product. This is how that after product of crude oil, how the area become polluted, then our effect, how we have cleaned it out and reforested. So main motto was first to clean up the environment so that it does not impact on the health of the community. However, there is little impact of the community is there. So we have 200 bedded hospital with medical and surgical diagnostic care, 24/7 emergency trauma services. We have full-fledged operation theater with all laparoscopic gadgets. We have ICU, hemodialysis unit. We have diagnostic all facilities, pharmacy and blood bank. We have ambulance and patient transfer services like basic life services and ATLS ambulance equipped with emergency and response. So this is our hospital facility. Health framework at All India Limited, we approach in two ways. Number one, an employee and executive of Oil India. And number two is community, because the oil is the open industry, so there is a lot of impact in the nearby community. To prevent the community, so we are careful about the community health. For health of the employees, we follow the oil industry safety guidelines. So every 5 years, up to 45 years of age, 3 years, 45 years to 55 years, alternate years after 55 years, and at the time of superannuation. And for community, extensive outreach via health camp, preventive screening, awareness drive, CSR program addressing maternal, child health, sanitation, safe drinking water, and non-communicable diseases in operational area. What we include in PME, our objective is to ensure the early detection, prevention, and management of lifestyle and occupational diseases among the oil employees. Cover all employees, including physical, biochemical, radiological, and specialist evaluation. The vital signs like BMI, metabolic profile, cardiac, ECG, echocardiography, as needed renal, hepatic parameters, all blood tests are available there. So this is last year PME report. 1094 cases we have done, and this is the data: hypertension, hyperlipidemia, override. See. So in comprehensively, if you see in metabolic and lifestyle disease dominate the top 4 conditions: hypertension, hyperlipidemia, overweight, and fatty liver, account for the vast majority of the cases, underscoring the high prevalence of metabolic syndrome risk factor. Hypertension is the number 1 concern with 309 cases. Hypertension is the most widespread disease requiring focused intervention strategies. High comorbidity risks, the high numbers of overweight, 224, hyperlipidemia, fatty liver indicate that many individuals are likely facing multiple risk factors simultaneously, significantly increasing their long-term risks for cardiac diseases and diabetes. Next tier disease, diabetes and thyroid and other metabolic disorder are the most common diseases, each with 117 cases, suggesting a significant burden of endocrine health issues. So this is the strategy impact, the way forward: strengthening the occupational health surveillance and early disease intervention, enable data-driven wellness policies and preventive care program, integration with digital health record for long-term employee tracking, reinforce oil commitment to the health pillar under the energy environment health framework. And this is for community. We have a project SPURS. Under that, we conduct regular health camp, maternal child program, and eye care drives in rural community, safe drinking water, sanitation and waste management, infrastructure for the villagers, health awareness and environmental education program, rapid medical relief and disaster response when required. So this is picture how our project Oil SPURS giving service to the community. 2024 to 25, 1,152 mobile camp we have conducted. The beneficiary 58,994, cumulative 19,22,228 since 2015. And what services we provide: diagnosis and treatment of non-communicable and common diseases, lab tests, free medicine, counseling and awareness. So this is the diagram showing the last year of project SPURS. So way forward, integrated sustainability through science, depend the CSR oil collaboration for scalable R&D outcome, scale up bioremediation, produce water, reuse and waste to resource technologies, expand renewable energy and green hydrogen pilot project, broadens CSR health outreach and strengthen PME coverage, continue alignment with India's net zero goal, which is 2027, our target is 2040. So closing note, giving time constraint, a detailed analysis of the data could not be present. The compiled insights are under comprehensive evaluation. Oil India reaffirm its unwavering commitment to employee health and well-being. Cohort Connect 2025 offers a valuable avenue for knowledge exchange and future synergy. We aspire to return with more incisive and data-driven presentation in the next edition. This is our first present. I have talked to Dr. Sengupta. We are not very much aware about that cohort study. In fact, these are all raw data I have presented, because 2 days before we got our invitation letter, we have collected quickly this slide. But we are eager to enter into this cohort study so that we can help from our side growing India in the way. Thank you very much.
Thank you, Dr. Neeraj. Do we have any questions? Okay, so we'll end the session out here.
Thank you.
Dr. Neeraj. Thank you.
Good evening, everybody. Now it's time to the valedictory session, and as we are running out of time, I request Dr. Souvik Mathi sir, Dr. Santanu Sen Gupta sir, Dr. Sardana sir, Dr. N.K. Dhal sir, Dr. Umakant Subuddhi ji, and Dr. Santosh Kumar Behra ji to come on the dais. Yes, sir, we will make it. Huh. I request our director sir to honor the people with a flower bouquet. It's a Herculean task organizing Cohort Connect, and the team is available on the dais, and the main motivating factor is none other than our director sir, which is a host institute. So I request director sir to take this onus to greeting all our cohort counterparts and connected partners, I should say. It's a always wonderful feeling being connected within the CSIR and out of the CSIR for R&D purposes. And health is the core of everything. And the last deliberation was an environment also. So we are very glad to see that we have Environment and Sustainability Department, and HOD of Environment and Sustainability Department, Dr. Dhal sir, is here with us. So we are feeling the gamut fulfilled in a holistic manner. Thank you, sir, for guiding us and motivating us. Now I will request Dr. Souvik Mathi, sir, Director IGIB, to say a few words.
Good afternoon, everybody. And I think all of you will agree that last 2 days, all of us, we have enjoyed the science and the discussion which was around the cohort data, etc., was quite enjoyable. So during outside of this auditorium, I have opportunity to discuss with many people who are running cohort. One of the issue which I have understood is that the continuous funding. So one of the proposal which I am making, whether it is going to be viable or not, but I think all cohort PIs can come out and can make a foundation or Section 8 company and look for CSR funds. I think there are huge amount of CSR fund, 35,000 crore, and then using this we can help whenever any cohort need money or so and so forth. If all of our cohort participants like PIs are joined, I think it is not going to be very difficult to attract CSR fund. So I hope this we can explore. What I understood in past 2 days discussion. Anyway, I again thank you all to extend your support, come here and participated, sharing your data. Somebody who has traveled late night like Nikhil. So I really thank you, because presence of people like you, clinicians come researchers, makes huge difference to people like us. Thank you all, and I hope that next somewhere we'll meet, maybe third version of this conclave. Thank you very much.
Thank you, sir. Now it's time to listen. Today is a Children's Day, and the brainchild of this cohort is our Dr. Santanu Sen Gupta, PI of this project. I request Santanu sir to say a few words.
Yeah, I think what he meant was our cohort is only 3 years old, so it's children. So, it was overwhelming for me. I just did not realize that so many of you will come, and the program, when we started, we thought we'll call some people, and then this really was amazing. 2 days continuously, and I think here all of you are sitting. Next time, one thing I realized, it can't be done in 2 days, it has to be 3 days. Cohorts increase over it. And I would specifically thank IMMT, Director IMMT and all the staff. Without their support, this would not have been possible. So last month, this was a big conference, and last month I went on a vacation for 1 full month. I could do that because Ramanuj Narayan is here and his very efficient team on the stage, and the students, they did an amazing job. Behind the scenes, they were all there, and we did not have to do anything. From our side, I can tell you, the only person who worked was Ajay, and this was my most relaxed conference organization. So I got the name, but I actually didn't do anything. And students, I thank you. All of you have come. You have been, last 6 months, you have been traveling to places, collecting samples. Did a great job. I hope you enjoyed Bhuvaneshwar. Some of you, I think, are going to Puri tonight. Be safe. And all the speakers, Shobik has already told, when we see so many doctors in a hall, it gives us, really, for example, Ramanuja's that sentence has been echoing everywhere. पत्थर में फूल खिल रहा है. So आपका वो famous हो गया, newspaper में भी आ गया. So I thought it is and Ramanuj has been a very good host. So thank you everybody. As Shobik suggested, we will meet again next year somewhere, and hopefully all of you will be there. Thank you.
Thank you, sir. And the team is strengthened by a doctor himself. He is Dr. Sardana, sir. So I request him to address the gathering.
So, good evening all, and with due regards to all the luminaries, physicians, and our staff from CSIR-IMMT and IGIB, and our dear students and coordinators of the Phenom India. It is really overwhelming that you made time to come out here out of your busy schedules. I'll not spend much time. I'll just say a loud thank you to all for coming here. And no such projects actually run without the support of a large workforce which goes behind these things, and exhaustive training and analysis which goes behind. So we hope that we carry it into the future. And thank you all once again for coming. Jai Hind.
Thank you, sir. And today the Dr. N.K. Dhal sir is here, who is the chairman of this whole national conclave, Cohort Connect, and he is presently chief scientist and head of environment and sustainability department. I request Dr. N.K. Dhal sir to address the gathering.
Thank you, Dr. Manish. So, good evening to all. On the dais, our respected director, CSIR-IMMT sir, then Gupta sir, Dr. Biren sir, and my friend, Dr. Subudhi, Dr. Behera, and of the dais, our beloved director, Ramanuj sir, and all my department staff members, HRD head Trupti madam, and all the heads of the department, esteemed doctors from different parts of the country, cohort participants, my dear student friends, ladies and gentlemen. At the outset, we are extremely thankful to all of you, and especially Maiti sir, Sengupta sir, for selecting CSIR-IMMT as a venue for conducting 2 days important national seminar. Before I say something, let us give a big round of applause to our director, Dr. Ramanuj sir, who is always motivating us, inspiring us, encouraging us to do such type of important works seminar. Friends, if you will not believe, even if before 1 week also, we had some problems how to get the money, financial problems, everything, Dr. Sengupta sir has clearly told. It is only due to director sir. Several times I met in his chamber, he told it will be done, don't worry. He is the only person who always insists us to do such type of thing, for which today many people from across the country are here. And friends, another one thing I want to tell you, the moment you come over here, you have seen the infrastructure development, what Ramanuj sir has done during his tenure. See the infrastructures, greenery campus. I hope definitely you must have enjoyed. Coming to the cohort, I participated in two, 3 talks, and I know that many things we have learned from the esteemed doctors and all the cohort participants. And when there is a program, there was a blood collection. That time also I have seen many of our students participated, and when I came to Dr. Subudhi, the result is very encouraging. And I have remembered before the seminar, Dr. Sengupta sir had presented in our Bhatnagar Hall and told about the diabetes, gut microbes, which is very, very relevant to us during today's lifestyle. And I hope we must have enjoyed. Let us try our best, because it's a CSR program, to make the CSR Cohort program successful in future also. And on behalf of CSIR-IMMT and on behalf of entire CSIR-IMMT participating team, once again, I am extremely thankful you all people have come here, enjoyed here and participated and make the program successful. If any problem, please excuse us, give your blessing for the growth of the institution. Thank you very much.
Thank you, sir, for guiding throughout the journey for making this Cohort Connect program a successful and memorable one. Now I request Dr. Santosh Kumar Behra, co-convener and senior principal scientist of CSIR-IMMT, who has taken the onus of many responsibility to conduct this program. Over to Santosh Kumar Behra.
Good evening to all. It is truly an honor for me as the co-convener of this 2 days National Conclave on Longitudinal Cohort Studies to deliver the validated remarks. Over the past 2 days, we have witnessed an enriching convergence of ideas, curiosity, and scientific rigor. Doctors, students, researchers, and scientists from diverse domains came together with a shared purpose, understanding how long-term systematic cohort studies can shape the future of science, healthcare, and public policy. This conclave has not only deepened our knowledge, but has also strengthened our collective resolve to pursue high-quality research that stand the test of time. The discussion on study design, data integrity, ethical dimensions, and translational impact have been particularly inspiring. I am confident that the insights gained here will empower many new collaborations and research initiatives. My heartfelt thanks to our distinguished speakers, session chairs, and panel experts for their valuable contributions. I also appreciate the enthusiasm of the young researchers and students whose questions and participation added great energy to the event. A special word of gratitude goes to the organizing team for their tireless effort in ensuring the smooth conduct of this conclave. My special thanks to our director. He has backbone of this conclave. He has given free hand to us to work, and our people have given best effort to do this conclave successful. As we conclude, let us carry forward the spirit of inquiry and commitment that define these 2 days. Together, we can build longitudinal research frameworks that benefit not only the scientific community, but society at large. Thank you all for your presence, your time, and meaningful engagement. Wish you a safe journey back and continued success in scientific pursuit. Thank you.
Thank you, Santosh. Now it's time to the most important moment. As we know, there was a poster competition inaugurated by our S&T minister yesterday. There were 37 participants who participated in the poster competition from all across India, and all are successful, but as the judges have to judge 3 winners, so I will be announcing the prizes. For the distribution of the prize, I request Dr. Nikhil Tandon sir and Dr. Salimar sir to come on the dais for some moment. Dr. Nikhil Tandon sir and Dr. Salimar sir, please come on the dais. I also request our director sir to, because it is a prize distribution moment, sir, they will carry the image of Souvik Mehti sir is there. So the third prize goes to Vikas M. Hiramat from CSIR-IGIB New Delhi. He has been adjudged third prize. दोस्तों तालियां थोड़ी बजनी चाहिए क्योंकि ये बच्चे की अथक परिश्रम है और जौहर है रिसर्च फील्ड में जिन्होंने पुरस्कार को अर्जित करने में उनको एक प्रतिष्ठा प्राप्त की है. I wish him all the success in the life ahead. Congratulations, Vikas M. Hiramat, CSIR-IGIB, New Delhi. Third prize. The second prize goes to Sujay Krishna Mathi, CSIR-IICB, Kolkata. If he is here, anybody from IICB, kindly collect the. Dr. Partha sir is requested to kindly collect the prize for the Sujay Krishna Mathi. In absentia और ज़्यादा जोर से ताली बजनी चाहिए दोस्तों. The clap should go to him. It's our CSIR IICB Kolkata. And the first prize goes to Harsimrat Kaur, CSIR-IGIB, New Delhi. Congratulations to all the winners. And here comes the clear indication that women and girls will be leading the scientific domain. Congratulations to Harsimrat Kaur for getting the first prize and best wishes to you. Thank you to Nikhil Tandon sir and Dr. Salimar sir. Now I request Subuddhi ji to propose vote of thanks.
Good evening. It's really pleasure to propose the vote of thanks. Professor Nikhil Tandon sir, Dr. Salimar sir, and all the dignitaries on the dais, those already have left, and those are boarding in the airport, and students. It's really important to see the combination of both the Director of IMMT and Dr. Ramanuj Narayan, and Director of IGIB, Dr. Souvik Moiti. So whenever Dr. Moiti invites Ramanuj to come, then Ramanuj will tell that he is our boss. Then when Souvik Moiti sir will address, he is my guru. So you can imagine, so they are very close friends, and that is the combination where students can take a lot of inspiration from both of them, and I too carry that. And dear students, without you, the total cohort program will not stand at all, and you have traveled across the CSR lab. I hope you all agree that we will propose a big round of thanks, very grateful, and grateful to your parents that you have all joined to the bigger program, where maybe after 10, 20 years, 30 years, when we will become aged, we will be part of the cohort program, somewhere you are, because cohort program spread so much so that maybe after 10 years, any individuals will ask in the country, he will be tell that I will be in CARS cohort or CSR cohort or any other cohort. So I am very, very grateful, and both the directors, all the doctors, delegates, chairpersons, particularly our Chairman Dr. N.K. Dhal sir, Co-Chairman Dr. Madam, and all the organizing committee members I cannot take because 96 people are there. They are spread from the airport to the railway station, to the different hotels, to the venue, to the research, and particularly our students, volunteers from IMMT. They have done wonderful work. If any shortcomings, please forgive the committee members, particularly Santosh Behra and me, because that's maybe our problem. Otherwise, our students have done really wonderful. I'm very thankful to Santosh Behra, who has taken almost 90% of the job. I am so relaxed. And Santanu Sengupta is remotely, planning and always, tracking through WhatsApp. There are so many WhatsApp groups, okay? And particularly Mukti Madam, who has just joined and, make all things easier. So whoever, the program itself like a cohort, so, people eager to join together. Nobody feel that we are the guest. Everybody is like a host. So I'm again, thank you all for joining the program, and hope next year and next to next year we'll keep on joining more people of the cohort and as well as students. I am very grateful to all the team members, particularly Dr. Sardana, Kumardeep and all. So let's close this event for today, but cohort will continue and keep continuing. Manishji, maybe you'll have. So now we'll all stand for national anthem.
जनमन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंधु गुजरात मराठा द्राविड़ उत्कल बंगा विंध्य हिमाचल जमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष माघे गाए तव जय गाथा जनगण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे.
Thank you all.
Please do not forget to take your belongings. Stay happy, healthy, and happy journey to all of you. Enjoy the city of Temple. Once again, Jai Hind, Jai Bharat.